whole our hormonal milieu is disturbed. Disrupting it, it may interfere with normal timing. The physical health, vision, increased rate of myopia, continuously seeing the screens for a very long time will create myopia and digital eye strains. You know now the children are at even 6 years, 7 years, 8 years are getting spectacles. And activity displaces time that would be spent on physical activity, increasing the risk of weight problems. Naturally, we go on seeing, and in between when we are watching the screen, we'll be having a binge eating or snacking. So we keep on eating that we don't know how much we have eaten also because we are so engrossed. So that is the reason for obesity problem. The body clock connection. The woman's reproductive system runs on a precise hormonal clock which is tied to the body's main circadian rhythm. The chain reaction is screen time at night suppresses melatonin which disrupts the circadian rhythm which can dysregulate the release of key reproductive hormones like FSH, LH, estrogen and progesterone. Increased stress, oversleep from screen time also increases the stress hormone like cortisol which can further signal to the body that it is not the safe time for reproduction. The cortisol, you know, cortisol will start putting the belly fats. Cortisol is the antioxidant, so it become the body becomes prone for so many other diseases because increased cortisol levels. The melatonin isn't just for sleep. It also acts as a ovaries and help to regulate the menstrual cycle, that you know. And I think that is the reason that maybe our girls are achieving menarche at around 8 years, 7 years. Now maybe this is the one cause because they start looking at the screen very early age, and this signals the early menarche. And maybe that is the cause which we are observing. Risk of the irregularity by disrupting the melatonin and HPG axis, chronic late night screen time may contribute to irregular periods, more severe PMS symptoms, potential exacerbation of conditions like PCOS, polycystic ovarian disease. Even I think in practice also now dysmenorrhea has increased so much. We never used to see 10 years back so many girls coming. Now even OPD, I think out of your 50 patients, 10 will be girls having so many problems that we never used to see earlier. So they are having these all problems: dysmenorrhea, irregular cycles, PMS, severe PMS symptoms. So that's what the screen time is creating havoc in them. Difficulty in conceiving, of course, PCOD is one of the reasons, and melatonin plays a role in protecting egg quality from oxidative stress. Low melatonin levels could compromise this protection. Ovulation impact. The precise hormonal timing of FSH and LS, which is essential for ovulation, can be thrown off by a disrupted circadian rhythm. So that we know PCOD is the burning problem, and maybe screen time is one of the reasons. There are so many other reasons. So whenever we are advising any PCOD patient, we should one of the columns or in history taking, I think in coming years we'll have to see how we see menstrual history. There will be a screen time history. So how many hours you are seeing, how many hours of mobile, how many hours of laptop. So that should be the norm in coming years. So difficulty in conceiving. So in reproductive age, I just told you this is the one where infertility, you are also coming across the infertility, especially unexplained infertility is increasing day by day. And screen time, we never ask how much hours he spends, what times he sleeps. In infertility we never ask. So I think now we should make a routine in infertility unexplained, we should ask for all these things and try to reduce and help them out. Menopause, already you know, it is a very violent phase in a woman's life as far as their mental status is concerned. Significant sleep disturbance for over 40% of the women due to hot flashes, hormonal drops, and this screen time is adding, that is pouring oil into the flame, and this sleep disturbances, they suddenly increase 3 to 4 times in menopause. Screen time acts as an accelerant to this problem. Late night screen use suppresses melatonin, making it even harder for a menopausal woman to fall asleep and stay asleep. And I have come across many people telling ki as the age old, as the lady grows, she is spending more time on screen time because she has enough time when the grandchildren sleep, and she has no time because everything is ready, so she can't spend the time, and she is spending more time with the contrary to what we believe ki younger are spending more time with screen time. It is not so. Elders are spending more time with the YouTube. Okay, so you have to caution them when you are treating for menopause. Of course, I just told you it worsens the insomnia problem which is already existing in menopause. Mood and fatigue. Severe deep deprivation leads to daytime fatigue, brain fog, anxiety, mood swings. All symptoms that are already common in menopause, they are all exaggerated with screen time watching. The dry eyes, because of menopause, they already have dry eyes, and this adds to the problem. Screen time makes this worse as people blink up to 60% less. We blink 60% less while staring at a screen. So that is a big gap what rest we are giving to the eyes, and that time the eye problems are increased because dust and other environmental factors, they start acting. Male infertility also, I think it is out of context, but I am telling you ki male infertility also has a big connection with the screen time. We always tell ki don't watch laptop on your thighs, don't put your mobiles in the lower down pockets, always keep away and all. So surprising connection. Screen time is strong indicator of sedentary lifestyle which is directly linked to poor sperm health. Major study found that who watch more than 20 hours of TV per week had 40% lower sperm count that men who did not watch. Conversely, men who exercised for 15 plus hours per week had a 73% higher chance of higher sperm count than those exercising less. So whenever we take history of male infertility, we'll have to tell them ki reduce screen time, reduce screen time, reduce screen time. That will increase their sperm count. So that is what I wanted to stress. The takeaway is it is often not screen time itself, but sitting that causes the problem. Long hours of sitting will increase the local temperature and reduce the motility and count. So, of course, heat scrotal hyperthermia occurs by long sitting and tight jeans and laptops. Radiation. Studies on Wi-Fi and mobile phone radiation have shown it can reduce sperm motility and increase sperm DNA damage. So, keeping the smartphone in front of pants, that I have just told you that. So, what are the recommendations? So, create a digital curfew. Stop all the screen use 1 to 2 hours before your desired bedtime, which is I think impossible to follow because we sleep when the mobile falls off our hand. So till then we don't sleep. So, but I think we should make it a habit ki stop all the screen use 1 to 2 hours, put all the notifications at rest or block them all, and just keep one hospital number. That because that is an emergency obstetricians, we don't know when we will get a call. Rest all are blocked. Get it off your lap. Use laptops on a desk, table and lap desk. Encourage men to keep phones in a back pocket. Filter the light. Use night mode, night shift on all devices in the evenings. And consider blue light blocking glasses for late night work. So you are supposed, because now IT industry is a big industry, they have to work in the night according to the US or other countries timings. So they can use blocking devices to reduce the blue light emission. Move your body, break up long periods of sitting, stand up, walk around, actively schedule physical exercise to counteract sedentary life. That's what we always promote, ki talk while you walk. So when you are talking, you just try to walk and don't sit and talk, because that will at least minimize the weight gain what she is going to achieve. Optimize the bedroom. Okay. So thank you. This was just to highlight and sensitize you people regarding the screen time. I think in history taking, this is going to be a major column when we are taking in the next years. What is the screen time they are using, what mobile they are using, because now mobiles are coming with emission standards. So we don't watch the backside of mobile, only we watch the model and other things. But now this one, government has recommended you should not emit so much of blue light, other things, we should follow that. So try to educate the people to use less and less screen time to improve their health. I thank Dr. Durgadas and other executive committee for giving me an opportunity to participate in this. Thank you once again.
Thank you, sir, for this energizing talk in the morning. And we started the session of time, and you have stimulated our melatonin today, sir, for this discussion. Thank you, sir. Now I call upon Dr. Aparna N. Ma'am is consultant at Reproductive Medicine and High Risk Pregnancy, Gunashila Surgery and Maternity Hospital, Baswan.
An infertile couple. There were so many things actually which was running in my mind. ಯಾಕೆಂತಂದ್ರೆ ನಾವೆಲ್ಲರೂ ಮೆಡಿಕಲ್ ಸ್ಕೂಲಿಂದ ಗ್ರಾಜ್ಯುಯೇಟ್ ಆದಾಗ we go through a systematic format, we learn taking a thorough history, evaluating them, examining them, and coming to a provisional diagnosis, and after a thorough evaluation again we define what is the actual diagnosis, and we treat the root cause. But when I entered this infertility or treating the subfertile women, I saw a completely different picture. Actually, they come with so much baggage of things. Their self-esteem is low. They come with social pressures, family pressures. Their relationships are so much imbalanced and they are in acute stress. So we have to see them as a whole. So whole person healing is what the holistic approach is. We treat them seeing what the need the body is asking for. We have to approach their soul and calm their mind before actually we start them through the journey of fertility treatments. So the holistic health is addressing the physical needs, the emotional needs, the mental needs, social and the spiritual health well-being is what the holistic well-being, which addresses all the layers of human personality. So as we all know that the subfertility or infertility is on a rising trend in India, on the worldwide, and the WHO itself addressed that 1 in 6 couple faces some challenge in their lifetime regarding the fertility. So India is again not excluded with this. Being a thickly populated country, we also are declining with our total fertility rates, and the recent 2023 census showed that from 2.1 total fertility rate which is required for the replacement levels, it has already dropped to 1.9 all over India. And in Karnataka, you can see it is at the level of 1.5. So this is something alarming where in the coming 2 or 3 decades, every 4 or 5 women, we will be facing some fertility issues. So this is something we have to address immediately. So as sir just now told about the factors, the increasing screen time, how it is affecting. So in the holistic approach, this is also very one alarming factor what we are seeing. In Garbhagudi, we follow the holistic approach therapy where it includes a thorough counseling, meditation, pranayama, breathing exercises, yogasanas, and we also have inculcated the alternative medicine application where we utilize traditional medicines for detoxification and rejuvenating their reproductive health. So does the evidence also support this? Let's see. So recently, ESHRE 2025, it updated its ovarian stimulation for IVF and ICSI guidelines, where it showed that there is a strong predictor of pregnancy and live birth is female age and BMI. We all knew that female age is the strong predictor, and it has also included body mass index is again the main predictor. Why? Obesity can lead to abnormal oocyte quality by down-regulating SIR-T3 pathway. It shortens the telomere length of oocytes, affecting the development of embryos and fetuses. Also, obesity leads to decreased maternal mitochondrial DNA content, further increasing the mitochondrial dysfunction. With all these things, obesity in women or men for that matter, it increases the probability of encountering subfertility in their lifetime, and also it increases recurrent spontaneous miscarriages by decreasing the oocyte quality, embryo quality, altering their maternal immune imbalances, endometrial dysplasia, and also obesity related genetic abnormalities. We all know that now healthy eating and the flexibility, physical activity is very important. So we emphasize our couples to be physically active, and this systematic review and meta-analysis published in 2022 showed that moderate to high levels of physical activity significantly reduces their overall risk of infertility by reducing the gonadotrophin levels fluctuation, boosting their immune functions, inhibiting the inflammation by modulating hypothalamic pituitary gonadal axis. And as the nutrition is the most essential factor, the most essential aspects, again managing their body mass index and boosting their fertility is the nutritional approach. We all, being the obstetrics and gynecologists, we emphasize the women for their healthy eating habits, again emphasizing them on healthy habits also, the social habits, reducing their alcohol intake, smoking, again excessive caffeine, which can result in increasing their period for achieving a healthy pregnancy. Recently, the last week, where I saw 2 new couples with subfertility, the women are heavy smokers than men. So this trend is increasing again. So this is one of the important factor why I have brought this topic into address here. There is a paper which has published in 2022 where they analyzed the present smokers or the former smokers. In both of them, there was a difficulty in achieving a healthy pregnancy. There were more pregnancy losses, stillbirth, and ectopic pregnancies. And the study has shown that it will take 7 long years for the chemicals accumulated with smoke to shed out from our body. So this is again important point to address. And again, stress and quality of life, it is no less, which can affect our female or the male infertility. We all know that infertility can increase the chances of poor quality of life and distress, and it goes like a gear wheel mechanism, where the poor quality of life or infertility increases their distress, or the distress and infertility can cause poor quality of life. So how do we break this? So if we modify their lifestyle choices, there enhances their fertility factors. If the quality of life or this vicious cycle is not addressed, it continues as a distress that alters their HPG axis, and reproductive dysfunctions continues, which impacts on their quality of life. The impact on life satisfaction is very much affected. The female identity is affected, emotional stress increases, they have imbalances in their marital life, and also the sexual dysfunctions is on a rise because of this. It equally affects both the male and the female infertility. So, in Garbhagudi, we regularly emphasize our couple on physical activity. As sir said, walk and talk. Again, the women who are into their professions, we tell them stand-up meetings, learn desk exercises, how can they effectively utilize avoiding their screen times. Again, sitting for longer durations to be avoided. Stress management is a key indicator here. Sleep well, manage your healthy diet, and avoid junk or processed foods. So we take the women through a detailed counseling process where lifestyle history is taken. We teach them how to handle their emotions, the depressions or the negativity. How can they overcome their anxiety after the fertility treatments, improving their dietary patterns, addressing their insomnia, work and home related stress. By this, we improve their lifestyle changes required for successful pregnancy. We have inculcated Garbha Yoga in Garbhagudi, where yoga uniforms the body, mind and breath. With this, the ability to modulate their endocrine system and enhancing the fertility outcome improves, similarly as with any other exercise. So we know now the health benefits of overcoming the stress. There are many health benefits. Overall, it helps in improving the quality of life and overall holistic well-being. Also, we have introduced the addition of the traditional herbal medications into our fertility management, where we utilize Panchakarma or Uttarabasti treatments, which helps in detoxification and regeneration of reproductive cells, improving their fertility. This was a study published in 2022 in Chicago, Illinois, US University, where they saw 80.4% of their couples who are taking infertility treatment are seeking some sort of alternative medicine in the form of yoga, massages, or medications, or in the form of meditation, herbal supplementations. And this proved that the very high number of subfertile women seek some sort of alternative medicines to boost their fertility. And we are in the process to provide more scientific evidence on this. And I always tell my patients that keeping their body, mind, and soul in alignment is the mantra for healthy reproductive life. So let's see some of the real case scenarios which have benefited from holistic approach here. This is one of my young couple where 28 and 30 years, extremely anxious. They were very much stressed with 2 years of trying period. When they stepped in, I asked her, you are such a young girl, 2 years married life, why are you so stressed? And she said, doctor, I have a history of endometriosis. At the age of 18 years, I got laparotomy done and the endometriotic cyst, which was of 8 centimeters, was removed. And the doctor told me to get married immediately and have a childbirth. But I delayed my marriage for another 8 to 10 years, and now I have landed in a fertility clinic, which I was aware 10 years back. So this is how, with the history, she came with giving a positive counseling. Her AMH told to be around 0.9, and we started with her IVF stimulation. With first cycle of IVF stimulation, poor quality of oocytes, again no embryos created, which again increased her stress. The counseling kept on continuing, she could not control or calm herself. She started with her second IVF journey also, where one day 3 embryo was formed, again failed to implant. This lost all her hopes. Here, we should not rush into the treatment. One lesson, we have to calm them before we take into any fertility treatments. She came requesting for donor oocyte cycle now. So should I do for a 28-year-old woman with 2 years of marital history because she is not able to create good embryos, was a question. Even being 0.9 AMH, when we did her scan, there was recurrence of endometriosis, but we could see good 8 to 10 follicles in both the ovaries. So sensing their emotional exhaustion, we advised them, please take a pause on treatment. Let's focus on de-stressing and detoxification therapies. And consciously we worked on reducing their stress to allow both the body and the mind to heal. And to the magic, she conceived naturally after 2 months. And yesterday she texted me, she got her anomaly scan and it is going well. So it's a reminder that when the stress is eased, the balance is restored and the body often responds with miracles. This is similar, one more young couple, 29 and 34 years, married for 4.5 years. They already come to me with multiple treatments already taken, like multiple cycles of OITI, almost 6 to 8 cycles failed. And when she was diagnosed with mismatch AMH and AFC, where AFCs are good. Both the ovaries is showing 10 to 12 follicles, but her AMH constantly is between around 1.1, 1.3 somewhere, where previously she has been told about decreasing AMH and poor quality oocytes could be the one reason why she is unable to conceive. And with this history, she's already completed 3 cycles of IUI, failed to conceive. So by this time, she's exhausted. And she has a constant doubt in her mind where she's able to form good embryos or not. That is her constant doubt. It's not about the fertility. She's constant doubt is my egg quality is good or not, whether I'm able to form good embryos or not. So she came asking me, doctor, can you please do one IVF cycle for me? I want to know whether I'm able to form the embryos or not. Because last 4.5 years, I am through this journey and I'm actually fed up now. So when we, again, positive counseling, all these therapies started, when we did her IVF cycle, she was a hyporesponder. Even though good, actually, enteral follicle counts were there, but she was responding very slowly. She took prolonged stimulation of almost 13 days and only 8 follicles responded. And when we retrieved 6 were mature, we could form 4 good blastocysts for her. By seeing those images of 4 good blastocysts, actually, there was a sense of relief in the couple. Now they could sense that, yes, I'm able to form those good embryos. and it renewed her confidence. We advised them, see, there is a new life within you now, please take a break and take these stress therapies, all those things, take a break at least for 1 or 2 months, get yourself renewed, let's then go for the embryo transfer. To the beautiful twist of fate, during their break cycle, actually she conceived naturally. So she was just waiting for that one information that she can actually form good embryos inside. So that was the only factor maybe which was not helping her to conceive. And when the mind comes, hormones heal, when the balance returns, the life begins. And this is another beautiful story, the couple of 35 and 39 years of age, both couple working in IT, long working hours. Women comes with history of AMH of 0.6, and already she had undergone one IVF cycle where only 2 oocytes were retrieved, again no embryos. In the first consultation, she tells me that she has a relentless work, very long screen time, and her BMI is 34 and she doesn't have any work-life balance. And it was clearly asking me that she has to take some pause there from the treatment. So couple were sent for metabolic corrections, weight reduction, uttarabasti, or detoxification, regeneration therapies, not just because I wanted them to continue the treatment, but actually she was asking for that. Her body was asking for that. So with renewed health and calm, when I started her IVF stimulation, because AMH was on a lower side and her age was increasing, in the first cycle I could create 2 good blastocysts. I could retrieve 9 oocytes and create 2 good blastocysts. She herself wanted to do the second cycle where we could form another 3 embryos. So now she had 5 good blastocysts in her hand. With very first embryo transfer cycle, she conceived twins, and months later she delivered 2 beautiful healthy babies. So this is the living proof, when the body finds balance, miracles are born. So when the patient come to our clinic, actually they come with this, some imagination. Yes, my doctor will take me through the journey of natural IUI or IVF treatment, and they imagine that, okay, when doctor tells me let's try naturally, oh, she's taking me through a very slow ride. When I tell with IVF, okay, little she's getting speeded up. When we tell IVF, they think that already I have a baby in hand. Is it true? So maybe with the last 3 cases, now we understand it is not the mode of treatment, how we have prepared them previously. The pre-preparedness is what important for healthy pregnancy and a healthy baby. So I believe in taking a detailed history, being interactive, being empathetic with the couple, understanding their core problems without any judgment, seeing their what emotional status they are they actually ready to start the fertility treatment? Or by starting or rushing into the treatment can actually make them worsen at sometimes. So with what pre-preparations are needed for the couple to gain this holistic well-being to create miracles of life. Thank you, and I wish you all the holistic abundance.
Thank you, ma'am. And yes, today the take-home phrase will be, body finds balance, miracles are born. Thank you, ma'am. Thank you for this beautiful talk. Moving on, now we would like to invite Dr. Jyoti GS. Ma'am, kindly come on the stage. Department of Obstetrics.
Today I will be speaking on ERAS, that is Enhanced Recovery After Surgery, pertain to our subject, obstetrics and gynecology. The point we are talking about is precision versus protocol. So, what exactly we mean by ERAS? It is multimodal, evidence-based, a clinical pathway, clinical care pathway to reduce the stress and speed up the recovery. We all know that whenever a patient gets operated, there will be a lot of surgical stress response. Catabolism will happen, there could be insulin resistance, leading to altered GI motility, fluid shifts, immunological changes. So what we were following, are still following, is the traditional perioperative care, where we include prolonged fasting, giving liberal IV fluids, putting routine drains, delaying the feeding, and delaying the mobilization. So This ERAS aims to preserve the normal physiology, reduce the stress and accelerate the recovery, reduce the complications and shorten the length of stay in the hospital without increasing the readmissions or the reoperations. So, what it is a team approach to surgical care with evidence-based practice. Why do we want to follow this? Because there are certain principles like early return of bowel function, more effective pain control, increased patient satisfaction, reduction of anxiety, improving the patient outcome, how it involves the patient in their care plan by focusing on education and goal setting and implement the very best evidence and the ERA's core principles and optimization. So the key principles include pre-operative counseling and nutrition strategies and perioperative practices giving regional non-opioid analgesia, maintaining fluid balance, normothermia, post-operative measures which I have been telling, early mobilization, early feeding, thromboprophylaxis, and ACOG emphasizes that the success of ERAS lies in implementation of all these multiple elements together and not as a single isolated measure. So, when you look at the pre-operative components, counseling is a very, very important part. See, we may be good surgeons. That alone is not the sole reason for good recovery. The patient should be ideally counseled very well about what lies, what operation she is undergoing, what are the risks and benefits, all those things, and she'll take it properly in her mind. So dedicated pre-operative counseling, and if the patient is a smoker and alcoholic, for any surgery, it is better that they stop it 1 month before, and active identification and correction of anemia and comorbidities, and the fasting guidelines are such that they can ingest light meal up to 6 hours before procedure and drink clear fluids up to 2 hours before procedure. Fasting 2 hours before the procedure is enough. In fact, they give the glucon D water. My friend used to give glucon D water 2 hours before the surgery. And commercially available, that's what, carbohydrate loading drink can be planned 2 hours before the surgery to eliminate oral mechanical bowel preparation. Not much of bowel preparation, they say it's physiological is better. So, analgesia, we are focus on regional and sacral blocks, all those, if it is possible, especially in elderly, it can be given. Prophylaxis for nausea and vomiting before the incision, that is 1 hour before the incision, we can consider giving this antiemetics to reduce the per-operative nausea and vomiting. And fluid optimization increases, as I said, in high-risk patient. Antimicrobial therapy, we have our HICC guidelines. First generation cephalosporins can be given, and cleansing of the skin. Preparation is very important. Alcohol-based chlorhexidine solution is what is asked instead of the povidone iodine. Vaginal cleansing also with 4% chlorhexidine. Avoidance of drains and vaginal pack. We do an ectopic pregnancy, laparotomy, salpingectomy. You are very sure there is hemostasis. Please do not put the drain and avoid putting the drain for enhanced recovery. Okay, temperature, maintenance of normothermia during the surgery. Activity, very evening of the surgery, she should be out of the bed more than 2 hours, and day after the surgery until discharge, that is by about 8 hours, she can start taking fluid. And she can start taking orally on the bed, up in the chair for all the meals. No NG tube, remove it at extubation, start regular diet, and the sham feeding. That is, we are stimulating the Pavlov reflex and giving chewing gum 4 hours after the procedure. And analgesia, as I said, avoid oral opioids is given only if indicated, and you can give ketorolac as non-steroidal anti-inflammatory drugs. Fluid optimization 40 ml per hour until the next 24 hours and then discontinued. Catheters, removal of catheters within 6 hours post-surgery, and assess for removal of drains and vaginal packs, if at all put, as soon as possible. So you should have a defined discharge pathway. So you should fully mobilize the patient as soon as possible. If she is able to tolerate solids without any nausea or vomiting, and she should be put on oral analgesia. Then once she is up and about, she is ready for discharge. So this is what is told as in the gist in this slide. So it needs a multidisciplinary approach. As you can see, we have the anesthesia medical team, our team, surgical team, nursing team doing all this in the pre-operative, operating theatre and in the wards. So what is special in cesarean section is the intraoperative element such as managing the anesthesia, maternal hypothermia, surgical techniques. No need to just peritoneum is just mesothelium, approximation is enough. If subcutaneous space is more than 2 centimeters only, we can close, we can suture it. And then antithrombotic element, sham feeding, that is giving chewing gum to eat, and immediately ambulating the patient up and about, sitting on the chair, and she should start her food, and urinary management, removing the catheters early and early discharge. So this is what is important. Fluid management is also very important, and thromboprophylaxis. These are the important things for cesarean delivery guideline pathway. So when you do a gynecological oncology cases, these patients, because of prolonged surgery, are at increased risk of venous thromboembolism, and they should receive dual prophylaxis, both with mechanical compression and chemoprophylaxis, and it should be initiated preoperatively. And in vaginal and vulvar surgeries, use of preoperative vaginal estrogen in postmenopausal women decreases the postoperative complications. These are the special things only which I have highlighted. Otherwise, general things hold good for these patients. And in those patients undergoing procedures more than 30 minutes, they should receive dual mechanical prophylaxis with low molecular weight heparin. And if there is any problem due to old age for thromboembolism, mechanical compressions. Then this is for vaginal packing in vaginal hysterectomy or any other vaginal surgeries is not ideally recommended. If you feel hemostasis is good, no need for vaginal packing, because it does not decrease the post-operative bleeding or hematoma formation, or it does not reduce the post-operative pain. And I'm going again down. Okay, this is for minimally invasive surgery. The implementation of ERAS for minimally invasive surgery is to reduce the OT time and lower the opioid requirement. When we implement ERAS in robotic surgeries, laparoscopic surgeries, vaginal hysterectomy surgeries, again it is very good because patient is mobilized and there is decreased hospital stay and there is enhanced potential. Some patients are discharged on the same day. Minimal invasive procedure patients can be discharged on the same day. So pre-operative counseling is very important with carbohydrate loading, as it reduces the chances of insulin resistance, anxiety, and chances of hyperglycemia post-operatively. And blood loss is very important. Blood loss reduction methods are very important because it reduces the inflammatory response and accelerates the post-operative healing. That is one thing we should know. So all in all, lesser hospital stay, lesser post-operative pain, reduced analgesic use, and faster return of bowel function, and no increased admission. So this is one meta-analysis. We have seen that as the number of ERAS protocol elements increase and there is negative outcome is reduced and the patient has gone home early. So what is this precision? This precision is built on the protocol and it refers to tailoring these protocols to individual patients using more advanced data based on the type of surgery, complications, epigenetics, and to personalize the care beyond a one-size-fits-all attitude. So it uses genomic, pharmacogenetic, and epigenetic data, and depends on which type of surgery you are doing, what are the associated complications, so that you can adapt the ERA strategy to specific patient profiles. And the benefit is it realizes the full potential of ERAs by accounting for individual patient variability such as age, comorbidities, specific genetic factors. So it is a tailored approach giving more effective care. So population based is you are giving a common treatment for a common disease that cures a portion of the population. Whereas precision ERAs is different treatment for individual patients based on their profile. So the protocol is well established everywhere and widely implemented in all surgical disciplines across the world. But precision is a new evolving concept that builds upon the foundation of ERA's protocol and addresses the variability in patient responses observed with traditional ERA's implementation. So, for example, all patients undergoing a specific procedure, as I told you, for example, they receive a carbohydrate 2 hours before surgery. So, we should see whether all patients need it, whether the patient is a diabetic. You should see and you should tailor the protocol. And some persons may be having low pain threshold. Probably those are the patients who need more than the analgesics which is prescribed in ERA, such as they say give only NSAID, don't give higher morphine, opioid derivatives. Then you have to see whether these individuals need higher analgesia. So you have to tailor it. The highlight that ERA's protocols are often designed based on the surgical procedure and alternatively propose that they should be created based on person type rather than surgical type in order to manage post-operative pain and other peri-operative metrics. So it is personalization over protocolization. So what is the future of ERA's precision? It reflects a broader trend in medicine towards personalized care and relies on data and technology to create more effective and targeted strategies for recovery. So, predictive analysis you can do using large patient databases to identify individuals who may benefit from specific interventions, and it needs real-time monitoring. You can utilize these wearable devices, mobile platform, and track the patient even after discharge, and biomarker analysis incorporating inflammatory markers or genetic data to identify patients who are at higher risk of complication. So by adopting this fine or granular patient-centric approach, ERA's precision aims to further enhance the already significant benefit which has been derived from the ERA's protocol, the standardized ERA's protocol. So practical tips for adopting it in our hospital: you can start with a pilot group, select one group of so probably hysterectomy patient, create a clinical pathway, assign a coordinator, frequent multidisciplinary meetings with all the faculty, disciplinaries involved, education of all the staff and simulate the pathway, patient education materials in the form of leaflets and videos, and gradually increase it for other procedures with continuous auditing. So it concludes to say that while ERA's protocol generally improve the outcome, the degree of success can vary significantly depending on a patient-specific factors. Precision medicine seeks to address these variations by providing a more nuanced and personalized application of ERA's principles. So this is it. You are doing a targeted management. So accurate diagnosis is important. You can give improved health outcome by precision ERA's protocol. The beneficiaries could be to the community, to the patients, to the clinicians, and to the researchers also. Thank you so much.
Thank you, ma'am, for the practical and insightful talk. I request now all the speakers. Babita MC ma'am, Shailaja Alankar ma'am, Anita SM ma'am, to kindly request volunteers. Gizare sir, DV Gizare sir, Dr. Jyoti GS ma'am, Dr. Aparna ma'am, kindly to go to the gratitude wall, sir.
Thank you everyone. It was an honor to be as a chairperson to such an informative session. Thank you all.
Panel discussion. May I now have the honor of inviting our esteemed moderator, Dr. M.B. Bellad sir, Professor and former HOD of OBG at KSOGA Medical College, Belgavi, to grace the dais.
Thank you so much. This was this is what I had shared. It's okay now. Thank you. I request all the panelists and the experts, please come over the dais. I'm happy to share here that this presentation was shared with all the panelists and the questions were also put. So they are all well prepared. They are going to add on to this. The panel is on. First of all, I bring greetings from my esteemed institution. But I request before that the previous session, ERAS we should follow because good enhanced recovery following surgery. We are currently practicing in our laparoscopies and the surgical procedure like cesarean sections. So we are doing and we are happy about that because that improves the mother and baby bonding. So ERAS I was talking. So this is solution to roadmap to anemia in pregnancy. I just want to invite Dr. Rupakala madam, Dr. Sheila, they are the experts. You can add the comments, madam, whenever there is another question, answer is something is left, you can add. And also at the end, you give your comments because all the panelists are going to give one message at the end. So I want you to be your own message. And these are my panelists, very senior members, and all are unique in their own ways, and they are all distinguished people in their places. Please introduce while your first question is there on who are you, from where you are coming to. So this is my outline of this total presentation which will be covered in this. So you all know that this is the latest, just introduction I am giving that 712 women die during pregnancy and childbirth. Almost one death every 2 minutes worldwide. Total of 260,000 women we are losing every year as per the 2023 data. And 30,000 maternal deaths. See, we have come down from so many lakhs of death to 30,000 maternal death in India. And that is our 82 to 85 deaths per day. And thank you all. Yesterday we also said this in convocation that we have reached a maternal mortality rate of 88 as per the 21-23 SRS report. So that 556 when I became a consultant in 1990 to today we are having 88. And unfortunately in the last 2 years, previous to this 20-22, Karnataka was in 58. But when 21 to 23 we have increased to 68. So that's little bit tragic, and we are north of South India. So if we want to prevent these deaths, and look at the prevalence globally, we are at 40 to 60, just lesser than Africa, which is more than 60%. So rest of the world, it is 20 to 40%. So this is all known, the anemia, how important. I am asking Dr. Anita, can you explain and introduce yourself first, that what has happened in NFHS 5, National Family Health Survey 5, what we found.
Thank Organizing Committee and Dr. Bella sir, who had prepared a very good presentation, and I didn't know that anemia had so much to read and prepare so much. So thank you sir for the wonderful introduction and presentation. For the question, I have got national survey of 5 compared to the 4. We have seen that all the anemia cases has been increased, whether it is seeing about the NFHS 5.
Only one drawback of NFHS is which time of the pregnancy they have done is not very clear. That is one important, because first trimester it is different, second and third trimester it is different. So this is what I just want to highlight is it has increased. Anemia has increased in NFHS 5, and even men have become more anemic, and at every level woman is anemic. One word I want to say. One thing is, we are also talking in the panel, more important than anemia, it is iron deficiency. So look at this, all states, they are all anemic states. And obstetricians also are anemic and iron deficient. This is my statement, and they never take oral iron. If anyone wants to prove that, you can come in front of me. How many days have you taken 180 tablets or 100 days oral iron? If you are, you may be exception to the rule. Thank you. 45% of the pregnant women and 47.8% of in Karnataka, they are anemic. Dr. Mudunur sir, what are the important maternal effects and pregnancy outcomes due to anemia in pregnancy? First introduce yourself, sir.
Good morning. I am Dr. S.R. Mudunur, Professor in BLDA Medical College, Bijapur. Thank you for this opportunity. So all of us know that daily we deal with the anemic patients, and the common problems the mother faces are preterm labor, postpartum hemorrhage is also more common, sepsis including urinary tract infection, and severe cases there is always risk of CCF and even maternal mortality also. For the baby, the low birth weight, growth retardation is common, preterm babies, and abruptio placenta, especially in megaloblastic anemia, it is much common. And overall perinatal mortality and morbidity is more, and impact on the brain development. There is cognitive deficiency in the fetuses where the mother had not just anemia, even iron deficiency also. And babies develop later on in the neonatal period anemia also. And there is increased incidence in the later life, the cardiovascular disease and diabetes and other chronic disorders.
That's fantastic. You see, when we were undergraduate, we were taught that however mother is anemic, baby never suffers. It's a wrong notion that your baby, I'll come to that vicious circle. Before that, I just want to know, because PPH is a major killer of the pregnant woman. So I want to ask, there are 5 mechanisms. I'll first ask Dr. Shailaja, please introduce yourself, that how anemia causes PPH. There are 5 mechanisms. One by one, all the panelists will answer. This is a question which was not there initially in the panel, but I have the answer with that. Please. Mike. I want all the obstetricians must know this, why and how anemia causes PPH and iron deficiency. Not just iron deficiency, anemia is severe spectrum of iron deficiency.
Anemia increases the heart rate and cardiac output, and increases the blood loss from bleeding vessels, and also has a hemorrhagic loss of blood causes a PPH. In that conditions, heart rate and cardiac conditions will be altered. For that, patient will have a hypertension, cardiac arrest, and other complications.
Fantastic. See, what happens is when the
blood flow from the bleeding vessels due to the reduced blood viscosity. So this viscosity depends on the number and the volume of the red cells. So blood viscosity falls with decreasing hematocrit. As you know, hematocrit is reduced in anemia, and this blood viscosity falling of the blood disease will increase the blood loss.
So you all see that how the tomato ketchup flows and how the Coke flows from the bottle. So that's the same mechanism here.
The platelet margins, so the increases the bleeding time. The normal flow of the blood, red cells and concentration cells, the vessels and the platelets are all concentrated in the laminar flow. The blood vessels usually, if it is ruptures, the platelet plug will be formed in the wall. The anemia disrupts this laminar flow because of this flowing. What will happen is the cells in the center will be flowing fast, and mainly the blood cells.
So thank you. See, the important is when the RBCs are full in number, they flow in the center, and platelets are at the periphery. When there is a rupture vessels, it is the sealing by platelets which happens, and that mechanism is lost when the woman is anemic. So laminar flow is normally center RBCs, sides the platelets. Now Dr. Likita, good morning, and please introduce yourself. How again anemia causes?
Hello, good morning everyone. I thank Tumkur Society for giving me opportunity to participate in this panel discussion. I am a consultant working at Hassan. So anemia may directly cause uterine atonicity. Iron is very essential for all these muscles and enzyme functions, which is with vital cellular functions, and iron deficiency causes muscle weakness and fatigue. So it also been suggested that anemia might cause atonicity, and it is because of impaired uterine oxygenation.
So you understand that every cell in the body, cytochrome oxidase is there for the mechanism, and this cytochrome oxidase, the coenzyme is the iron, and myoglobin is also containing iron. So when there is a deficiency, oxygenation is affected, myometrial function is affected, so direct impact of iron deficiency on uterine atony. So these are the fantastic 5 mechanisms. So that's why we not only should treat iron deficiency anemia, but also treat iron deficiency. Dr. Pandurangaya, can you tell what is iron deficiency, important roles of iron, and can we break that the vicious cycle which we will show you? Can you tell me what is the role of IV iron, please?
So mainly
iron.
Deficiency of iron is there's not enough iron in our body. So mainly the important role, the iron is essential for the hemoglobin. So it is helpful for oxygen transportations and erythropoiesis. So next is the muscle protein, that is myoglobin. It is also an essential. The next other is it has act as a coenzymes for certain enzymes, like for the energy productions, and also it is also help us for detoxifications and DNA synthesis and the cell proliferations and the growths. So this is iron is one of the important roles. Mainly the impacts, that is starting from the birth till the adult infancy, adolescence and pregnancies. So if it is any deficiency, either birth means if mother is anemic, definitely the baby is also anemic. So the growth, if iron is absorption is less, and again the adolescency will be she will be anemic. The pregnancy, before the pregnancy, if she is not anemic, then we can prevent all these things, the cycles.
See, we have a vicious cycle in LMICs, low and medium income countries. The pregnant woman is anemic. She gives birth to a baby which is iron storage deficiency. Baby may not be at that time anemic, but cord blood hemoglobin, iron levels are very low. And this baby, because breast milk doesn't have much iron, so infancy anemia, it becomes an adolescent anemia, adult anemia. She becomes again pregnant and again gives rise to a baby with iron deficiency. So can we break this, Dr. Pandurangaya?
So we can break this. The only thing is to prevent this before adolescency anemia, you have to prevent one, or the anemia prior to the pregnancies. If you treat,
I am asking this to audience. Should we break this or no?
yes,
We should break this. And see, that is the main motto of this is prevent anemia either prior to the pregnancy or early in pregnancy. See that the next generation is smarter and intelligent. Dr. Shailaja Bidri madam, can you please define and explain degrees of anemia? Explain the dilutional effects of pregnancy and what is additional requirement of iron during pregnancy.
Okay, sir.
We'll go one by one.
Anemia is defined as a decreased oxygen carrying capacity of blood due to decreased hemoglobin concentration or red blood cells. In this kind, WHO cutoff problem is 11.11 grams, and CDC is 11 grams to 10. And according to the classification, mild, moderate, and severe and very severe according to ICMR. According to WHO, only mild, moderate, and severe. And in this condition, ICMR according to mild 10.9 to 10, and moderate is 9.9 to 7, and severe is 7.24. Less than 4 we are taking as a severe anemia according to ICMR.
Very severe.
Very severe. According to same classification, mild and moderate, but in case of WHO, it is less than 7 grams.
Yeah, and
physiological, because of increased blood volume and RBC counts are less. Because of that, the disparity between the 40 to 50% and 18 to 20% of RBCs, disparity causes blood dilution that causes a physiological anemia.
Next point, the requirement in pregnancy.
Requirement is maternal is 500 milligram and fetus is 300, and by iron said is 200. Totally 1000 milligram required.
Prepared for 45 minutes and accordingly please follow that. I request you please. Dr. Likita Krishna, do you think diagnosis is challenge? How can we diagnose? And what is iron deficiency and what is iron deficiency anemia?
Yes, sir. Diagnosis is challenging because the patients are not regularly visiting, and they visit only during the pregnancy, not prior to that. Even if they are confirmed with pregnancy, they start their visit by 3 weeks. Only the educated group, they start preconceptionally, not everyone. So
no, even obstetricians don't start, madam. Don't tell that educated. Obstetricians themselves, when they are planning a pregnancy, most of our Indian women unplanned pregnancies. And so yesterday I told that also, marriages are legal in India, pregnancies are all legal. They should be counseled at the time of marriage, and they should visit before registration, how there are made marriage registration compulsory. The visit of evaluation of health certificate is a must. Please go ahead.
Diagnosis of iron deficiency anemia is mainly clinical examination with a detailed history clinical examination, and laboratory results. Laboratory test we mainly give for CBC. In that we get MCH, MCV, MCHC, and in iron deficiency, it is the serum ferritin which is reduced, and this total iron binding capacity is increased, and it is more than 400, and this saturation, transferritin saturation is decreased to less than 20%, and in iron deficiency anemia, hemoglobin is decreased, MCH and MCHC is decreased, and total iron binding capacity is increased, and the saturation, transferritin saturation is less than 20%. And the difference between iron deficiency and iron deficiency anemia is, iron deficiency is the condition where the stores are reduced, the total iron content in the body is reduced, and in iron deficiency anemia, because of the stores reduced, and gradually the erythropoiesis is reduced, and then the RBCs, all these RBC incidences, all this MCHC and HB reduces in the further later days, and it is called iron deficiency anemia.
Yeah, fantastically explained. See, iron deficiency is a spectrum of disease. Iron deficiency anemia is a severe spectrum of this. So please note that just anemia when there is already she is store deficient, she is also deficient with oxygenation. So that's the point we want to bring here. And also please remember that we did recently a study in the endemic areas also hemoglobinopathies are more because people are traveling and settling different places. In our own study, we found that 9% pregnant women had hemoglobinopathies, but of course we had more of thalassemia trait and thalassemia. We don't find sickle cell that much in this, and gluten allergy in this southern India is less compared to northern India, Rajasthan and Madhya Pradesh. So electrophoresis is better to do routinely in the first trimester. If you find a trait, our husband also need to be evaluated because you want to prevent thalassemia in the baby. So this is an important thing. I just want to convey that. SLFT, soluble transferrin, the receptor is the most important, and it is as equivalent to as you are doing the combination of TSAT testing. It costs around 1100, but in bulk it can come to 600. It's the most, it is not affected by infection. Ferritin is affected by infection. That is why our Indian women, they are usually with chronic urinary infection or chronic infections. There the ferritin level is raised. So that's why only ferritin we cannot take as marker unless we combine with HCRP or procalcitonin with that as a marker of infection. So these are the different level of spectrum we told. And also that, diagnosis of iron deficiency 30 nanograms per ml or you have to TSAT of less than 20. So please just don't treat iron deficiency anemia, treat iron deficiency. You want to prevent further problem. Dr. Mudnur, what are the broad principles of management of anemia?
So, management includes not only the obstetrician gynecologist, even our paramedicals also in PHCs and other places, they are involved, giving supplements and all. So there are so many aspects. First thing, any disease, we have to find the cause and treat it. So it holds good for anemia also. Any predisposing factors like deficiencies, and
yes.
infections, all those things has to be tackled first. Then we have to correct the cause. The iron deficiency is there. We have to manage by giving proper diet, and the dietary advice should be reasonable, and it should be considering the socio-economic state of the patient also. We should be very much practical in giving the advice. The main animal food like meat is most important source. In vegetarians, legumes are the best bet along with the green leafy vegetables. And a balanced diet is very much important. Then supplementing iron, all of us know that the oral iron preparations are there, the parenterals. And now best bet I feel is giving injectables may be a better solution for Indian pregnant women.
We will come to that.
Yes.
We will come to
Thank
that.
you. Thank you.
See,
Well,
important, Dr. Sunil Kumar, what are the modalities of treatment of iron deficiency anemia?
So what sir was telling about the first thing is that the food fortification and food modification, food which are like it has to be educated to the women that which are inhibitors of the iron absorption. That is also very important in not just prescribing the iron tablet because the Indian diet is mostly which contains the phytates. And added to that the tannins and other products and milk and dairy products which is taken along with iron tablets, and that is not used just giving iron tablets.
So you want to say that oral modality is there is a parental,
yes.
Rarely
and
you can use blood transfusion.
Yes.
Apart from the supplementary, somehow the food fortification is not very successful, though they have done with the rice, though they have done in the southern American countries, the maize, because that's the maize, and Africa, it was somehow not been very successful. Even flour fortification was not been very successful. What do you think are the challenges of oral iron therapy, Sunil Kumar? Because see, so many years. See, we started in 1964. We have not been able to conquer anemia, still it is increased. What are the challenges of oral iron, you think?
So one is that the compliance itself, the patient may not be ready to take it because of the GI side effects and the myth that is that's going to increase the size of the baby and that they will do the cesarean section. and of course intolerance and the method of administration. Most of the times we tell the patient to take it after the food, which is not a very good method for absorption. And the role of hepcidin, which is coming up, people have to know that what is hepcidin. Hepcidin is a small peptide hormone that is secreted by the liver, and this is this acts on the protein which is there on the macrocytes, which is there on the enterocytes and the hepatocytes. This binds to the ferro portion of the iron protein that is in all these cells, which helps to absorb the iron and helps in recycling of the old RBCs from the macrophages and helps in storage through the hepatocytes.
So the importance is, see, this is a hepcidin which proteins which actually controls the iron absorption and iron metabolism. So if the hepcidin level is high, which is indicator when you give oral iron, when the absorption happens, the hepcidin level goes up. Immediately you give in the evening, that iron will not get absorbed because this hepcidin lasts for more than 24 hours. You give oral iron, once it absorbs, the hepcidin level goes up. So next day dose, it will not get absorbed. So that our concept of daily dose, if you are giving oral iron,
and large
is not
doses
going to
also,
work.
and large
so
oral
you
doses
can give
also
either alternate day or twice a week. That's the principle I wanted to tell in this panel. Oral iron you want to give, you give either twice a week or 3 times a day, alternate day, but give it for the higher dose at a time, but they are associated with side effect. This is how you see the there is a high level of the hepcidin is in high iron level, inflammation, and the endocrino reticular stress factors.
Yes.
And the low, when it is there, when low iron is there, erythropoiesis is going on and hypoxia.
So
Pregnancy also reduces the hepcidin level,
yes,
but women are usually with the infection.
Especially
that's why
with patients with iron deficiency anemia, what happens? There will be decrease in hepcidin, which is but the body senses that there is iron deficiency. There will be hepcidin which is lowered, so that it increases the absorption and helps in breaking down the RBCs and releasing the iron to the circulation, and even the storage also increase. But what happens in the anemia of chronic diseases? There is a trapping of this iron into the macrocytes, so it will not be absorbed.
It's
neither
not
it is
released.
not
It's
released.
not released
So
because
that's a
of
functional deficiency of anemia.
Yeah. Dr. Mudnur, why parenteral iron now?
So,
see, if you imagine alternate dose or twice a week dose, can you meet the demand of 1000 milligrams in 180 days? It's
because
just
of
not
these
possible.
so many factors, deficiency in the diet and the type of diet we take, it is very, very difficult to give that much 1 gram of iron throughout the pregnancy. And also there is a storage problem is there. So it is better, and especially in moderate to severe cases, to provide parenteral iron therapies. There are so many preparations. Now nowadays,
so just to add on to what Subhash is saying, that is the why parental iron. Now first generation and second generation, there were risks involved, side effects were more, and there is a single dose were not available. Compliance of coming to 5 times with iron sucrose also was problem. Now there are single dose iron. Can you tell those? These are the Mudnur. These are the 4 single dose therapy available worldwide, but in India only top 2 are available. That's why I have put them in green. The white ones are not available in India, but in US all these are available. Single dose.
So FCM has become very popular. We can give 1000 milligram daily. 1 dose may be enough, and if there is a iron deficiency, we can give more also.
No. Sometimes we have observed in our AJOG just published in March says that even because by the time our woman, we did it in moderate anemia 7 to 9.9. When we have done this, the storage is already deficient and they are further anemic. So 1 dose, we found that it is less. We found that when we treated, the ferritin level in IV iron group and oral iron level in the cord blood was almost lower only. Yes. So that suggests that we need to add on the IV iron in maybe at 28 weeks.
Later on.
Our article I will share, and this presentation also will be shared to the organizers. Please, all of you can collect that. And Dr. Anita, why all parental irons are covered by carbohydrate? And what are the different iron preparations? Mike.
Carbohydrate shell stabilize the molecule and it helps to release the elemental iron in the slowly.
Fantastic. See, all irons, elemental iron, they are unstable. It has to be stabilized by using carbohydrate. That's why you have got sucrose, maltose, and derisommaltose. All these are there because the iron is covered by this carbohydrate moiety. So that also, as you mentioned very rightly, that it slow releases there. Can you tell the different preparations? I'll just run on these.
Yes. So most commonly we use iron sucrose. It is.
We are not using iron sucrose, madam.
Yeah.
5 doses
FCM.
we need to use. Only government is still recommending that. That also is coming down now. Second is, all I have mentioned is this ferric
FCM, which we
carboxymaltose.
can give in a single IV dose. Then we have iron isomaltoside, which is rarely used, and ferrimexyostol is not available in India.
Fermoxytol is not available, and there is a low
molecular iron
dextran. These are all being used. We work with who is called as Michael Orbach from USA, Washington University, who is a authority on IV irons. He uses all these 4. So I just want to say that there are 4 preparations. Out of that, 2 are available in India. And we did the trial with the 1 oral iron preparation and 2 IV preparation.
And we should remember that lower molecular iron dextron needs test dose, sir. Others,
That actually for the time, this thing, the ferric carboxymaltose, the derisommaltose, they don't need text. As per the drug information, it doesn't require the test dose. Can you tell Dr. Pandurangaya what are the contraindications and prerequisites to ensure safe administration?
Sir, mainly the parental iron is hypersensitivity or allergy to the drugs. So next comes the hemosiderosis. That is hemochromatosis, like increased iron in the body, like thalassemia major or hemosiderosis, all those things. And next is we'll get the other causes of anemia, like other than the iron deficiencies. So iron overload disturbs the utilization of irons. And also the chronic diseases and infections, autoimmune disorders and the drug specific.
Yeah, especially autoimmune disorders. See, there is a patient who is having asthmatic, or she has got some skin manifestations. Careful. You can give, but you need to be very careful. And please, the prerequisite is?
So prerequisite is first and foremost is we have heard that so many FCM deaths are occurred.
So many there
sir,
are
without that is sir, so many means the FCM which is carelessly is taken
I know one of the doctor,
inside
I don't
the
want
home
to mention which place and all, even though they had their own hospital, the person called the nurse with the drug to come and give it at home. And she had severe reaction and she succumbed to, before her husband, who is also a doctor, could not reach and revive her. So administer only when your trained staff is available and within the time schedule. And because if you give more than 45 minutes, there will be free radicals form. They themselves will cause the reaction. And resuscitation facilities must be available. That's why we did this study in community health centers where there is an emergency doctor. And there are drugs which we can tell you that they must be available. So these are some of the side effects which are common, less common, and there are rare. Rare is anaphylaxis. Out of the 3,000 infusions, we had only 1 anaphylaxis, which also was managed by our drugs which were provided. The 4 drugs you must keep in when you are giving infusions are the methylprednisolone, hydrocortisone, injection Avil. Along with that, you need to keep the H2 antagonists injection, the ranitidine or famotidine, and plus the adrenaline. So these must be kept in place along with oxygen, timer, everything should keep, because it should not go beyond 20 to 30 minutes of infusion. So these are some of the side effects. Dr. Shailaja, can you tell us what are the effects of fetal and infant brain effects on iron deficiency?
There are effects of iron on 3 stages, sir. First is fetal as well as infants and adolescent. In that condition, patient is a cognitive as well as developing disorders. Patient will suffer with anemia.
Dr. Anita, neuro consequences of iron underloading?
The baby will, the myelination is reduced, so the bonding to the mother is reduced, poor memory recognition, slower speeding of neuronal processing. If you take a long term, it will have risk of autism, schizophrenia and depression. So that hippocampus, everything postnatally also the baby will have iron deficiency anemia, the IQ will be less, so baby will be less smart, motor dysfunction can be seen in severe cases. Okay, socio-affective disorders also can be seen.
And please note that first 1,000 days, that's why the government has come, is 280 days or 70 days of pregnancy and next 2.5 years. These are the important for the fetal and new infant brain development. That's the time when if the baby suffers iron deficiency, you cannot say that the mother is responsible for not bringing an intelligent child. So I want you all mothers to spread this message that if mother is not iron deficient, her baby will not be dull. So dull in the sense, smarter or less intelligent. Look at this. If the woman has iron sufficiency, this is how the brain networking you find. They are broken networks of neurons. So you want this type of brain development or you want this type? Audience, please. Which one you want? So iron sufficient. Okay? One message from each of you.
So
I completed, and at the end I have a conclusion.
So messages.
One by one, please. And after that, madam, experts comment, please. Because
So
I have curbed a lot of these.
6 beneficiary we should keep in mind. One is child less than 5 years, more than 5 years, pregnant ladies, lactating mothers, and adolescents girls. And 6 strategies which has been told by Anemia Mukta Bharat. It is easy to follow. You give prophylactic iron tablet. You can make a digital hemoglobin testing in the community centers. You can add fortified. Fortified food is difficult to bring in the national programs. They are trying for that. And our aim should be to get the hemoglobin of 12 by the age of 12.
No, that concept is gone now. We want 15 or 14 at 12 or 14. We don't want 12 because 12 we have to add on that. So brief message, please. Next.
So preconceptional counseling and
I wanted this. Please understand. Pregnancy must be entered with the optimal state of health. Very good point, Preconceptional care we should in. And please understand your PHC medical officers, if you are, tell there that eligible couple survey happens every year. And 50% of these women will conceive. They are called as likely to conceive women. So we should catch hold of this. And at marriage, there should be registration. Somebody can give this to the DHO or DS, a proposal to government that I am a private man, so they don't accept easily. So, sir, Nagaraj sir, you all can, and Vidya madam, you are in Bengaluru. So you all, and Jyoti madam, please convince the administration to see that when they go for the registration, that marriage registration, they should be checked. That is anemia, iron deficiency, hypothyroidism, diabetes, because these are all the comorbidities which further causes anemia. Good point on preconceptional care. Next.
And sir, you have to treat early only during adolescent, not only pre-pregnancy.
No, that means
Adolescent,
preconceptional we are, at least by adolescent you do it, but if you, that's a fantastic thing which can happen. Because we did this for school-age children. We gave this oral iron, but it did not work. So my point is, anemia should be prevented prior to conception.
Prior to conception and during adolescent as well as during childhood also, because of cognitive as well as development.
Yeah.
So one new idea I want to bring, especially not in Bangalore and other places, where if the woman is brought
think
to...
that Bangalore rural is horrible.
I don't know.
Don't think that Bangalore is there are a lot of slum areas which are horrible. I am saying you this. I have gone through all the districts, maternal mortality. Bangalore urban is only doing well. Bangalore rural, slum areas, there are a lot of problems. And it is on par with almost Raichur. Don't feel anyone bad here.
There all authorities are catching the doctors for women's health. So I want to say one more thing. If the pregnant woman is having anemia beyond 20 weeks or so, husband and in-laws should be booked. They should. Why she is not treated?
I am not going to the police station or court, sir. Let's move to the next person.
Whole family should be involved. What I mean is,
Not
whole
like
family
a
should
dowry issue. I don't want that. Next.
What I wanted to give a message is that the government is doing so much, and so many pharmaceuticals have brought so much of formulations of different varieties and spending so much of money on that. But why are we not thinking about why it is not getting implemented? I want the message to be given to the next president, KSOGA, that we have to bring all such matters to why it is not getting implemented.
I am struggling, sir. I am meeting directors, secretaries of health on various grounds through various agencies. It's difficult to bring the change. Even with FIGO president, I had a lot of discussion in recent FIGO conference. The challenge is that one reaction here and there, it spoils. But we should ensure safe administration. That's what, if there is the organizers give a time, how safely we should give infusion, I can share that. If there is a time, it's not a compulsion, please, I can curb that. Next person to give message.
So mainly the dietary foods and as well as the drug, how to take drugs. While some people are taking calcium and iron together, or they are taking immediately after the food. All these things we have to counsel the patients.
Absolutely important. See, counseling and communication, they are the key aspects. The important message is, it's a misconception should be taken away. Counseling plays a vital role, especially when even giving IV iron or oral iron. Some amount of, you don't show only the heaven. You need to tell there is mild reactions which happen. Initially there will be fishbone reactions, the tightening of chest, throat and all. You wait for 5-10 minutes, it will stops and you can give that. Because suddenly if somebody is giving, they are scared in the center, so suddenly they stop. It's an expensive medication. And also one warning is, now the new spurious companies have also come up with the drugs. Some of them are made from cheaper countries. They are coming into market after the patency has gone. Be careful about this. Use in few patients, then say that you can recommend that. So infusion video is there, but I may not be able to give. But the message I want to give is, treat anemia before she becomes pregnant, number one. Whether you give it adolescent, because even after taking adolescent, she can become preconceptionally anemic. Because woman is menstruating, some of them have got adolescent menorrhagia. Prevent anemia for prevention of anemia-related complications in pregnancy. If we want our next generation to be smarter and intelligent, their mothers should not only be not anemic, there should not be iron deficient. Prevent anemia at every level. Let us make anemia-free India to achieve SDG goals well before 2030. Because two conditions are killing our women. One is anemia-related PPH and the second one is preeclampsia. If the woman's health is good, the uterine circulation is good, Vidya is here, preconceptionally, endometrium should be healthy. If the endometrium is healthy, the placenta will be well formed, which can be evidenced by the placental growth factor. And if there is a healthy placenta, preeclampsia is also less. So we can curb by single task. Treat anemia before pregnancy. Let's make anemia-free India. Let's make that our pregnant women are safer. Why they should not be like Sweden-born people? Because I used to say that Indian woman birth in India, is it a curse for a woman? I used to say when I was in 1990, 556 women we used to do. Today we have come down to 88, much better than many other countries. But we should aim to become less than 30. At least single digit is too far away. And for that, we should aim this anemia at every level to be curbed. Thank you very much for your patience. And ensure healthy mother and smart and intelligent baby by your actions. And not that, I am just now asking their comments. Experts, please.
So thank you for elaborative, Bella sir. It was very nice panel discussion. I am Dr. Sheila, working in professor as a Sri Devaraja's Medical College. Sir, it is situated in a rural place. Yesterday also I have seen women coming to me, term pregnancy with a 4-gram hemoglobin. She is in labor. So it was so difficult for us to treat. That's why 60% of the women or children are anemic. So we had to treat them early. Sir, one more opportunity I'll take in this, what I have seen in my practice. Sir, this empty pill, which is available as over-the-counter drug, and everybody is using left and right this drug, and they are becoming very anemic. So why can't we, this for MR, Foxy, BSOG, all those things, why can't you make it as a narcotic drug like that? So without license, that's what I want to convey my message to all the obstetrician and gynecologists. Thank you, sir.
Last comment.
Thank you, sir. I'm Dr. Uppala, HOD from Rajarajeshwari Medical College. Excellent panel, sir. All the expert panelists have explained all the etiology, different causes and management. What I would like to stress is a simple, complete hemogram with an MCV and a MCH will give you an idea about the etiology of what is anemia. We
Madam,
need not
I want
do
to
always
tell you, all the obstetricians are unaware of this complete hemogram and how to interpret.
in that MCV and MCH, sir.
No, I am talking about this. All I am a majority do not read about RDW. What's its implication?
That
what
will
is
give us
its,
the basic
so
idea
please
about the
understand, you
etiology,
can
sir.
make a fantastic
Lot of
diagnosis
difference
only
with the
from
basic
complete
hemogram.
But for that we need, I am generalizing, madam, please, don't. Jyotika, you are a very intelligent woman. I
And
cannot
among
compare.
the RBC indices, the least what we can do is an MCHC, because that will give us the idea about the amount of iron in circulation. At least one MCHC. And MCV and MCH will always give us the idea whether she is thalassaemic or an iron deficiency anemia. That
Even you
goes
can make a
way.
diagnosis of
And
hemoglobinopathy based on
RDW,
that.
which is seen in, which is very, very beneficial.
And Menger's index
And
also is calculated. on
Menzer
that.
index, and now the latest is MCI index,
Correct.
which is very, very powerful, sir. And a word about the hepcidin. Hepcidin assays are not specific. They're
We are not
specific for
suggesting hepcidin,
trimesters.
we are only telling that because of hepcidin effect, you should not administer
So
every
only
day or
diagnosis
2
should be
times.
based on your hemoglobin, serum ferritin, with or without your CRP.
And please
Only
don't give only
hepcidin
IV iron or iron. You have to give vitamin B12, folic acid and high protein diet. See, you want to really meet the requirement of 50 kg woman, pregnant woman protein, you need to eat 12 eggs a day.
But
How many
hepcidin
of
is
are,
helpful, sir,
capable?
in those cases where the serum ferritin, that is C-reactive protein, comes in the way. It is an acute protein.
So
So
that's
if the
why it
iron
is-
is normal and the ferritin is less, then you have to go for the hepcidin. If there is low hepcidin, then you are successful with oral iron treatment. If the hepcidin is high,
So
then
to
your oral
avoid
iron
that,
is not
madam,
going to help.
to avoid
You
that
have to
only
go
I
for
ask for
parental iron.
the soluble, the ferritin factor, SLP8R. So that's the message I want to give. If there
And
was
of
a
course,
question for audience interaction, I don't know if organizers allow 1 or 2 from the audience questions, we should, as a panelist, they should answer. Still we have time, man, I have taken that. Yes,
NGS,
yes.
sir, for hemolytic anemias, gene therapy and genome modeling for hemolytic anemias goes a long way.
Sure.
Next generation sequencing
Some people
also
want to
for
ask questions.
hemolytic anemias.
Please, Mike.
Before we take we have to keep all the consumables ready and then start, because we have got lot of cases where they have a problem with putting an IV line. The molecule is already instilled inside the infusion. It is almost 20 to 30 minutes. After that, there is the next duty, whoever is coming. So we have seen lot of cases where there's a reaction only because of the time lapse. So it is for the postgraduates, I think you have to give.
आपकी प्रेगनेंसी को कितना महीना हुआ है?
See, one second.
Last period date क्या है?
No, see, I was
After
just showing
asking for the last one.
1 second. There was a video of how to infuse. So
Yeah.
we didn't tell because of the time.
Yes, yes, sir.
Because there are, if somebody allows us, because this is a very important
Very
message
important
I want to
point,
give.
I think.
So if you
And
all
the
agree, I
dilution
can
also
show
is important, sir.
How
How much
to
milligrams,
infuse,
Yeah,
how
I
much
was-
to dilute.
how much to dilute,
That
that's
they
very-
keep it as a standard. Everybody puts in 100 ml, whether it is 500, 750
Hey,
or 1000.
no,
So it differs.
something wrong. This is about, I think you can have this fun video. If you don't communicate, video is not coming there. See, this communicates.
I'm
If
sorry
you
for
don't
triggering this
communicate-
question, sir.
No. So 1 second, escape. Sir, ನೀವು ಇದನ್ನು ಮಾಡಿದರೆ ಎಲ್ಲಿದೆ ತೆಗಿರೋದು ನಂದು ಹಾಂ ಸರಿ 1 second.
I know.
There, support and providing this opportunity. That's very important.
Thank you to our moderators, experts and panelists for such a dynamic.
Ellarigu namaskara. A very good morning. So we'll move to our next session, that is Nipunara Vakya. I welcome you all once again. So I welcome our chairpersons, Dr. Chandrika Muralidhar ma'am. Chandrika Muralidhar ma'am is the Managing Director and Consultant Obstetrician and Gynecologist at Jupiter Hospital, Bangalore. Dr. Sanjana Patil Talur ma'am, who is an Associate Professor in the Department of OBG at MR Medical College, Kalburgi. Dr. Sonia Mandappa ma'am, who is a Consultant Obstetrician and Gynecologist at Motherhood, Mysore. I invite Dr. Vidya Bhatt ma'am. Ma'am is a laparoscopic surgeon and infertility specialist at Radhakrishna Multi-Speciality Hospital and IVF Center, Bangalore. She is also the first woman gynac endoscopic surgeon from Karnataka to do live demonstrations throughout India. I welcome you, ma'am.
Without wasting much time, I think I've walked into the stage with the mic only because the next panel, seniors, graceful, talented and intelligent. So we look forward for their presentation. Over to you, madam.
Yeah. Respected chairpersons and dear friends, hysteroscopy, I think whenever I come to Tumkur, the topic of hysteroscopy is always there. And hysteroscopy is I think my heart lies in hysteroscopy, that is evaluating the uterine cavity. Well, this hysteroscopy has paved the path for me to AAGL, and I am in the SIG committee of AAGL. So why should we do hysteroscopy? For newer innovations, implement the quality care, reduce complications, avoid hysterectomies, and of course improve fertility. The recent advancements or the challenges what we have is in office hysteroscopy, then tackling a myoma, laser, where do we use it, embryoscopy, should we do or not, and cesarean scar section, cesarean scar ectopic. Do you have to do a robotic surgery for that, or can you tackle it hysteroscopically? And of course, adenomyosis. There's a lot discussion on the microwave ablation. Should you do it for a fertility woman or a woman with fertility, basically because her myometrium is going to get completely baked. So should you do that? So these are all some of the challenges which we face. Office hysteroscopy, you see and treat. I think I'll rush because 3 speakers are there and we have to finish it before the plenary, I think so. So where can you do this office hysteroscopy? Don't think that you can take a patient to do office hysteroscopy and start doing for a myoma of 2 centimeters. No. Even Dr. Bituki says that you can't do it for a myoma which is more than 1 centimeter. So don't have such ideas and don't wheel such patients to the OT or don't bring them into the office hysteroscopy center. But basically you can do the diagnosis, see before you treat, look at the polyps or prepare yourself for a hysteroscopic surgery. You can do office hysteroscopy, evaluating the uterine cavity before infertility you can do, and removing an IUCD. So many IUCDs we get which are lost inside the uterine cavity. So removing an IUCD, direct biopsy or pre-surgical planning, it can be done. So office hysteroscopy unit, it can be in your a small room with all these, the OT table and the monitor. But the thing is, it has to be very, very close to your OT. So whenever there is a problem, then please wheel the patient into the OT. We have been doing relook hysteroscopy also as office hysteroscopy. And in case you have done a septum or if it is Eschermann's, then just put in the hysteroscope, talk to your patients. Your unit either should be in the ground floor or maximum first floor. Within 5 minutes, you should be able to shift the patient to the OT. So in such cases, keep talking, keep asking her to look at the monitor, and you do office hysteroscopy just to know that there is a nice, beautiful cavity. The Princess, the slim resectoscope, we have a publication on the uses of resectoscope in Trocar journal, basically because the resectoscope is something, a beautiful instrument where you can do all the manipulations. The tissue retrieval system is now marketed so much, the intrauterine tissue retrieval system, but it is all for grade 0 myomas. If you want to treat an infertile patient, or if you want to treat somebody with a septum, then try using the thinner and thinner resectoscopes. Then of course, for polyps, polypectomy you can do. Basically, you can use scissors, and this can be done office, or you can do it under anesthesia. Polypectomy is the first surgery you start doing when you become a hysteroscopic surgeon. So it is very easy, very gratifying and satisfying. Imagine you remove a polyp in a postmenopausal lady and she becomes all right, and you're avoiding a hysterectomy. Or you remove a polyp and the lady conceives. So that is so gratifying. Endoscopy, of course, which came, it's not very helpful, basically because endoscopy is very expensive. This is the instrument used for office hysteroscopy. And this is our statistics. We have been doing office hysteroscopy since 3-4 years. Coming to the bipolar electrodes. The bipolar electrodes are now in vogue, basically because it is safer. You can use normal saline, and the sturdiness of the instrument is not much as compared to the monopolar. So some old surgeons like me still use monopolar. I have a monopolar unit in my OT and a bipolar. When I see a large myoma, I switch over to the monopolar unit. Only thing is you have to be very, very careful with your fluid management system, and you should have a very good anesthetist at the head end. So intrauterine morcellators or intrauterine tissue retrieval system, it is a blade. You know, it is a mechanical instrument. It is a blade where you can use the normal saline, and you have the rotatory and oscillatory blade. Where can you use it? This is our innovation. I would like to take a little more time in this video, basically because this is a grade 1 to grade 2 myoma, which is embedded in the posterior wall. And this lady was not conceiving at all. So what we did was, we injected vasopressin. We inject vasopressin for all intrauterine surgeries. And basically how we do it, we take the ohm pickup needle and we inject the vasopressin, 10 to 15 ml. There will not be any problems. And then what we did, we just made an incision over the myoma. And after making the incision over the myoma, we had to just shell it out. See, just make an incision and shell it out. So once you shell it out, so you get the whole myoma inside the uterine cavity. A myoma which was grade 3 to grade 1 becomes grade 0. So once it becomes grade 0, you just morcellate it and remove it, that's all. Or just use your intrauterine tissue retrieval system for it, and then it is done. So things become simple when you know how to tackle it. And this is our publication. Initially it was in press, now it is published. So it is safe. When you use a intrauterine tissue retrieval system, it is very safe. But what happens if you have something like this inside the uterine cavity? I won't go to this because I've shown a myoma. An extra, retained products of conception. See, something like this. I had bone specules inside the uterine cavity, and how am I going to remove it? I tried with the grasper. Every time I put the grasper inside, it started breaking. So this was a big challenge. So the moment it started breaking, what I realized was, I paid so much for the morcellator, I had paid a huge amount. So let me put this and try, and it did wonders. So that's how we innovate. You know, the company people do their instrument, but we have to innovate and we have to implement it in our day-to-day practice. And this is how I remove the bits of the bone which the morcellator or the tissue retrieval system just pulled it out. Laser, of course, lots has been spoken about the laser, but it cannot do much. It will just evaporate a small myoma and a septum. You can clear the septum with precision. Well, for that, people may ask you, why are you using such a costly instrument? Well, this does a very good job, but if you are in a hospital where the urologists use it, the plastic surgeons use it, then why not? You know, because it is going to give you a very nice septal resection. It is going to do a very nice uterine cavity, and all you have to do is just go and take the laser beam on the septum, and it keeps on cutting. This gives an exact or a very good precision. The endometrium is not damaged. There is no lateral spread, and you know how much the laser beam enters, maximum 1.1 millimeter to 2 millimeters, that's all. You have to do use diode laser whenever you are using underwater cutting, and look at the precision there. The woman can just go for her IUI or IVF in the very next cycle. Pros, of course, it is good. Cons, it is expensive and you have to use glasses whenever you are using laser. Embryoscopy, should you ever do it? Well, if you have recurrent implantation, recurrent pregnancy loss, and you want to evaluate the fetus, up to 10 to 11 weeks you can do this thing, embryoscopy. People have asked, well, we do by ultrasound. Why do you want to do a embryoscopy for this? If you are terminating it, then under ultrasound guidance, you plan to terminate. Put in the hysteroscope and look for more anomalies. You can even send the tissue for chromosomal array, but before that, you just see here it was just stored. I mean, we were told it was cystic hygroma. Once we put in the scope, we realized there was gastroschisis also, and one limb was absent. So all this information you can get. There are reports that you have to do it. Only in selected cases, you can go ahead and do embryoscopy. PRP for thin endometrium, this is very beautiful. I have a publication on this, intramyometrial PRP. When your patient doesn't conceive, when there is recurrent implantation failure, to get that 5 to 10% of satisfaction or pregnancies for your patients who are so desperate to conceive, you can do this intramyometrial or subendometrial PRP and inject the PRP fluid. We do stem cell therapy also like this, and our conceptions are better. We have an American publication on this stem cell therapy. Ovarian, well, I won't go into it. Robert's uterus, this is some really a dreaded thing which can happen. You can have a normal looking uterus on top, and there is a blind entry or a blind end inside the uterine cavity. You enter inside, you realize that it is a unicornuate uterus. Whereas when you put in the laparoscope, it is a normal uterus. So get an MRI, confirm that it is Robert's uterus, and then you just align the cavity. Well, you have 3 different varieties in this. One, a big cavity, sometimes a fibrous cavity without endometrium, and sometimes you'll have a cavity which has a small pocket of endometrium. All you have to do is just correct it by uniting it. Metroplasty, at times you have to become Michelangelo also when you are a hysteroscopic surgeon. You have a uterus which is so small, and how do you expect the woman to conceive? All you have to do is you make the cavity bigger. A tubular cavity, make it into a triangular cavity, and once you make it into a triangular cavity, put the patient on estrogen progesterone combination for 3 months, and then do your embryo transfers. What we see is unicornuate uterus. It is very difficult to get conception, but you make a triangular cavity and then the patient conceives. It is really gratifying, and we had this publication published in the Troca journal. It is in press. So hysteroscopic treatment for cesarean, sorry, I think I missed that. Previous cesarean scar ectopic. Ismocele correction, I won't go to that. Hysterolaparoscopic because of the paucity of time. Scar ectopic, yeah. See, I have seen people doing robotic surgeries for scar ectopic. Please don't do that extensive surgeries, and it is so expensive. And when you just put in the hysteroscope, before that do a scan and see the thickness of the myometrium over the scar ectopic tissue. Once you see that, and if it is around 3 to 5 millimeters, please put in a hysteroscope. And how beautifully, because this is all dead tissue, you have to activate the pedal intermittently. Intermittently activate your resectoscope. So I love this instrument. People are, the Europeans are saying don't use the resectoscope, whereas the Americans say use the resectoscope. Well, this is a beautiful instrument. Please learn the art of resectoscopy, basically because you can do wonders inside the uterine cavity. So intermittently, I'm removing the scar tissue and then activating my pedal. And then only when the tissue doesn't come, then I'm activating and then going deeper. And what do you have to do after this? Once you remove it, you're satisfied, please do a cystoscopy. And if you are a good cystoscopic surgeon, all my residents do a cystoscopy, basically because post TLH, I make them do. Look at the abdominal approach if you had gone, how badly it was adherent. We did a cystoscopy, everything was normal, and this was selected for AAGL presentation, this video. So, and adenomyosis, this is an adolescent girl who came with an adenomyosis with too much of white discharge. And people were like thinking, what is wrong with her? Then we realized there was an adenomyosis inside the cervical canal. All we had to do was remove it, and she has lost for follow-up now. No news, good news. And adenomyosis sitting inside the uterine cavity. Do you want to do ablation for this? No, don't touch the cavity. You know, the endometrium will get burnt. So don't do ablation. Just take the resectoscope, keep the setting low at 80 and open up that adenomyosis. It will align with the endometrium and put the patient on estrogen progesterone. The patient will conceive. And this is our publication on that. This is our publication in Trocar Journal. This is one more of our publication, and this is still in press, Trocar Journal. So with the advent of instruments and procedures, we have to learn the intrauterine secret, the intrauterine magic, and the intrauterine story. So please improve your skills and learn hysteroscopy. If you are interested, please come for my training courses. I'm marketing myself, but it is for the good. Please learn hysteroscopy and improve your skills. Follow us on this. Thank you very much for your kind attention.
As usual, wonderful presentation, ma'am. But I was in the academic wing of KSOGA, that is KCOG. Under her leadership and guidance, we did a hysteroscopic workshop at JSS Medical College 2 months back, which was a great hit, and we actually invite her again on and on to do such programs. And I should mention in this platform, she is the first woman gynec endoscopic surgeon from Karnataka to do live demonstration of this. And congratulations to you, ma'am.
Now many are doing. I think I just started it, that's all. Thank you. In case of DUB, dysfunctional, or AUB, the abnormal uterine bleeding, and if the endometrium is very thick, that time I put them on medroxyprogesterone acetate 10 mg TID for 3 days, followed by norethisterone 10 mg BD for 21 days, and then call them for a TCRE when I'm doing a transcervical resection of endometrium.
Okay.
There is another small trick. She comes with profuse bleeding and you don't have time to put the patient on that therapy. Just take your Carmen's cannula and under ultrasound guidance, suction everything. You will get the normal surface endometrium and then resect it.
Thank you, Vidya.
Thank you.
Thank you.
Yes.
Now I call Dr. Jyotika Desai, ma'am. She'll be talking about the endocrine disruptors in pregnancy. We keep getting, coming across these EDCs around us, and in pregnancy especially they'll be more vulnerable to the harmful effect of this, and we'll know more about by Dr. Jyotika. That disappeared. Anyway, I know about her. She is very dynamic.
Chandrika, we are already late.
No, at least one sentence I have to tell. She is very very well read. Thank you.
Thank you so much, Chandrika and Sonia. Thank you, Dr. Durgadas, for asking me to talk on my favorite topic, endocrine disruptors. Well, endocrine disruptors, are they a ticking time bomb? Yes, they are, but very sadly, nobody seems to realize it. So what are these endocrine disruptors? An endocrine disruptor is an exogenous substance or a mixture of substances that alters the functional capacity of the endocrine system and Thereby, it causes adverse effects in an intact organism, mostly human beings, could be animals, could be fish, could be anything, and the progeny. And this was given by the WHO. So why do endocrine disruptors matter? Why are we worried about them? Because they are, something happened, because they are everywhere, mind you. And very low doses can cause harm. You don't have to have a very high dose, small things. Then again, the problem is it's not like cyanide, that as soon as you take it, you die. No, this has delayed effects. It may take years for the effects to be manifested. Again, the effects on health can be irreversible. That makes them very dangerous. And lastly, the sad thing is that most of these effects are overlooked because we are not aware of them. So it's very important that we keep talking of endocrine disruptors. I would rather call EDC to save time, and we work upon it very seriously. So let us just talk about plastics, that's all. One of the worst endocrine disruptors. The worldwide plastic production is around 400 million metric tons per year. And do you know, almost 40% of this is used for packaging food and beverages, what we eat every day from the market, from anywhere. And these plastics do not biodegrade, and they remain for thousands of years before they get decomposed. Even our water bodies are polluted. You can see the oceans. The water bodies, how we human beings have polluted them. So where do we find them? They are found in air, water, soil, everywhere. In fact, they have become ubiquitous. So much so that we literally breathe, eat, drink and touch EDCs every day without realizing. Now where are they hiding? You have them in tap water, mind you. The pipes contain EDC. You can't change them, can we? So they are present in tap water, in processed foods, canned foods, the lining of the can, the lid of the can, pesticides, herbicides, insecticides, cleaning and laundry products, the comfort which is exhibited so much that contains EDCs in a very big way, plastic food wraps, storage containers, plastic water bottles. In spite of telling, I've brought a plastic water bottle here because I couldn't carry a metal one as I just lost it recently. Then again, non-stick food cookware. See, all of us have non-stick cookware in our homes. They are Teflon coated, and once the Teflon, just a little bit of a scratch, EDCs are released and we eat them. So be very, very careful with Teflon. Best thing is not to have them, have only iron vessels. Then receipts, all the thermal receipts which we insist on collecting, they are all coated with BPA, and BPA is definitely a very bad EDC. Then again, flame retardants, cosmetics, nail polish, nail remover, shampoo, conditioner, body lotions, creams, moisturizer, shower gel, name it and it has it. Anything which smells good has EDC in it. And then of course, birth control pills, yes, hormones also are there. They also can cause, they also contain EDCs. So how do we identify EDCs? Yes, this was one expert consensus statement which released that they have 10 key characteristics by which they can identify what EDC, which EDC is present in which substance. So I don't have to go through it. We just know that all the 10 characteristics are totally revolve around hormones, synthesis, transport, distribution, metabolism, etc., etc. So to make it very short, EDCs possess estrogenic, anti-estrogenic, androgenic, anti-androgenic and other hormonal effects which may impact reproductive, developmental and other health outcomes. They can cross the placenta, and now they have been implicated in the developmental origin of diseases such as obesity and diabetes. And again, epidemiological data says that we have all seen an increase in diabetes, in cancer, in infertility and in non-alcoholic fatty liver disease. You know, every scan report says fatty liver. Why? Because this is because it could be partly attributed to the in utero exposure to EDCs. And again, they also contribute to climate change because they have contaminated the air, soil and water, and they are causing lasting detrimental effects on our ecosystems. We don't know whether the volcanoes are erupting because of this or whether we are having so many floods and excessive rainfall because of this. Now, there are many types of EDCs. A very short this thing to tell you that they can be plant-derived. There are industrial chemicals. I'm not going into the names. PFAS, PHS, dioxins. Dioxins are there in sanitary pads. Please remember that. Very dangerous. Then again, PCBs. Then you've got household, and I've mentioned about the household consumable items. There you have bisphenol A, BPA, phthalates, perchlorate, dioxins. Perchlorate is present in leafy vegetables which have not been produced organically. Then of course medical supplies, intravenous tubing. Do you know that all the intravenous tubing which we use have EDCs? And again we are putting them directly into our veins. Then again gloves. We avoided COVID by using gloves, but by using gloves we have introduced EDCs into our system. Then again of course natural synthetic steroids and heavy metals. So now what is human exposure? The very first time they thought of EDCs was when they found high-level industrial contamination on the abnormal development of fish, aquatic animals and birds. But in the human problem was first discovered when the effects of DES, diethylstilbestrol, was discovered in the female offspring of women who took them during pregnancy. There were more than 10 million children and mothers who were exposed to DES from 1940 to 71, but it was only in 2000 that FDA banned DES. So you can imagine how many mothers and daughters have suffered, are still suffering, the progeny. So how do we get exposed? It could be because of ingestion, inhalation, skin contact, transplacental, mother's milk, and of course the intravenous route also, which I just mentioned. It can affect women and men, of course, women at all ages, intrauterine, adolescent, throughout reproductive life and menopause. And one thing which I needed to tell you is that it can affect through the hypothalamo-pituitary gonadal axis. So let us see what effects they have on the female reproductive system. We have all seen that there is an increased incidence of precocious puberty, premature menopause, polycystic ovarian syndrome, endometriosis, infertility and irregular cycles. All these, there are enough number of papers in literature to tell us that all of these can in part be attributed to our exposure in utero or otherwise to EDCs. Now just to show you, look at it, BPA, DDT and dioxin. What happens here? Both of them can give rise to decreased sperm quality, then DNA damage, and not only that, the sperm concentration, motility, morphology, everything is also altered. Are our semen reports which come abnormal nowadays because of EDCs? Well, we don't know. We have to wait and see. Now let's come to pregnancy. Yes, the detrimental impact on reproduction starts even before conception, affecting the fecundability, the fertility potential of both parents. They are particularly dangerous in pregnancy because the hormones are more unstable and vulnerable to their actions. They can be detected in all body fluids. They can also be seen in the placenta. Then again, they affect the developmental trajectory of the fetus or early programming and represent an important susceptibility factor for the appearance of NCDs during postnatal life. So during pregnancy, exposure can give rise to 3 generations being involved: the mother, the fetus, and the next generation through the germinal cells of the fetus. And all this is because of interference with hormone biosynthesis or metabolism. So what happens in pregnancy? How do they affect pregnancy? It all starts with the placental development. They reduce the placental aromatase activity, giving rise to a reduction in estrogen and progesterone. They alter the trophoblast development, reducing HCG production, and they also increase the apoptosis of the trophoblast. They limit the blood supply to both the placenta and the fetus, resulting in insufficient remodeling of the uterine spiral arteries with a lower placental weight, ultimately leading to fetal growth restriction-like and preeclampsia-like syndromes. In animal experiments, they have also found increased rates of miscarriages. So here I only mentioned about hormone, the disruption of hormones. But you can see here, EDCs can affect pregnancy, rather the fetus, through metabolomics, epigenetics, inflammation, altering the microbiome, increasing oxidative and oxidative stress. And what are the birth outcomes? Preterm birth, growth restriction, pregnancy complications like diabetes, small for date babies or even large for date babies, congenital defects, and the long-term offspring outcomes can be reproductive, cardiometabolic, and neurodevelopmental. So they have extensive effects on everything in the concerning the human organism. Exposure to endocrine disruptors during pregnancy is linked to increased risks of metabolic syndrome in the offspring, in the children. We are not talking of adults. So metabolic syndrome in the children also has been found to be increased. What about preeclampsia? Yes, there is an increased risk of exposure to EDCs and preeclampsia. We find because it interferes with placentation, it interferes with maternal endothelial function, increases the level of SFLT1, and then also the ratio of PLGF and SFLT is altered. Preterm labor, if the mother is exposed to EDCs, any form, you can see that the relationship of EDCs to preterm births is very high. With phthalates, they have seen it in 12 to 16% of cases, and with BPA levels being high in all 3 trimesters, it is positively associated with preterm birth. Not only that, if the preconception BPA level is high, the size of the newborn also is supposed to be reduced. Mind you, all these are with enough evidence and more. I've only quoted a few papers. What about GDM? Yes, they also cause GDM. How? They increase adipogenesis, causing excessive gestational weight gain, which contributes indirectly to development of GDM. Again, they also increase insulin resistance and beta cell dysfunction with impaired glucose metabolism, and it has been found that almost all the EDCs contribute to impaired glucose intolerance. What about growth restriction? Yes, fetal exposure levels of BPA show linear associations. So the more the exposure, the higher the incidence of fetal growth restriction. And early exposure to these chemicals have been linked to altered sensitization, trophoblast invasion, and spiral artery remodeling. Exactly what happens with preeclampsia. The same thing is seen with EDCs on FGR. This is just a picture to show so many epigenetic alterations which can happen with EDC on the fetus. One of them being FDR. Now there are other effects too. They can affect the neonatal thyroid hormone status, and in animal experiments they found that prenatal exposure to BPA at environmentally relevant doses is associated with ovarian cysts, proliferative lesions in the oviduct, because it's an animal, we don't call it the fallopian tube, cervical carcinoma, sarcoma, polyps, and of course breast adenocarcinoma. About congenital abnormalities, there's a very funny incidental finding here that only male babies are involved, not females. Surprisingly, the anomalies which are attributed to EDCs are hypospadias, cryptorchidism, testicular dysgenesis syndrome, and reduced anogenital distance. And all these, not only this, they also, we have already seen that they interfere with the semen parameters. Now this is just one EDC called bisphenols, and you can see the number of effects it can have on pregnancy, both mother and the fetus. So what about beyond pregnancy? We all know about the Barker's hypothesis of the developmental origin of health and disease, and now it has been seen that prenatal exposure can increase the incidence of obesity, type 1 and type 2 diabetes, cardiometabolic risk, cancers, and of course alterations in cognitive development and behavior. This cognitive development has become a very big issue. Are we producing a whole generation of morons? Look at this. Glycol ethers, DDT, and BPA, and perchlorate, all of them, there are a lot of studies to corroborate it. In utero exposure, yes, they all have cognitive difficulties in the fetus, in the baby. And not only that, the IQ is less, the social skills are poor. So all this adds up to what we can do to protect our future generation. So studies indicate all of us have detectable levels of EDC in our body fluids, and anything that promises to make our life easier contains EDCs. So it is time to act now to see that we decrease the effect, the contact of EDCs in our life and the lives of our patients, especially pregnant patients, because that makes a very big difference to our future progeny. So I don't want to go into the details here, but just mention avoid antibacterial soaps, avoid shampoo, body washes and conditioners, avoid personal care products that contain fragrances. Please remember, anything that smells good is bad. Okay? Then again, switch to organic cosmetics. Then the other thing is, buy and eat organic food if possible. Avoid beverages in plastic bottles and canned goods, unless they've labeled it as BPA free. And lastly, when you buy some food from outside, it comes in a plastic container and it is hot. That is when the plastic, the EDC leaches into the food directly, immediately. As soon as you get it, transfer it into a steel vessel or a glass vessel so that the contact is reduced. So to conclude, EDC pollution is recent, yet it spares no organism or environment. Their long-term effects, especially the multi-generational and potential transgenerational effects, remain underappreciated and very poorly people are not aware of it. By increasing awareness to the public and to the medical profession too, and initiating preventive measures, we can minimize the deleterious consequences of EDCs for all, especially pregnant women, to protect our future generations. Let us insist on stricter laws against the use of plastic. Maybe the answer lies in going back to our old Indian ways. So the goal is very high and we all have to work very hard to reach it, but let us start with the first step so that at least we will reach somewhere. Thank you very much.
Thank you. Nowadays we think that diabetes and even cardiac events, they are happening to even younger adults before the age of 30 years. So we were wondering why this is happening, and we were thinking maybe because of stress and all that. But I think this is also one of the important factors.
Yes, Chandrika.
Their mothers would have come across these EDCs, and now this generation is suffering. It can be that also.
Absolutely, it's right. It can contribute. It may not be the only causative factor. It lies with us.
It lies with us.
Yes.
So I think one mantra we can take forward is choose wisely and change gradually.
We have to, yes, exactly, Sonia. And we need to educate our parents.
Yes.
When we see diabetes, when we see growth restriction, when we see obesity, find out their lifestyle and see what changes we can make in their lives. Okay? But for that, we should do it in our lives
Yes,
first.
yes.
Thank you.
From adolescent to getting a feeding bottle.
Yes.
Till then, that
They
spectrum.
say the feeding bottles are BPA free.
Yes.
But there are other
Other
BPA
pigments.
varieties which are there
Yes.
and which they don't advertise, which are worse than BPA.
Yes.
That was a wonderful talk by Jyotika ma'am. Now I request our next speaker, Dr. Sampath Kumari ma'am, to take over. Ma'am is a professor and HOD in the Department of OBG at St. Peter's Medical College and from Chennai.
Greetings from KSOGA, madam. We have a national faculty here today amongst us, who's actually a vice president, Foxy 2022-23, a great academician, and a lot of take-home messages she's been delivering all through north, south, east, and west of India. Over to you, madam.
Good morning to all, and thanks to the chairperson for the nice words. Lot of information, north, east, west, she was telling. My main information is only adolescent health. Okay? See, today, my topic is what are the burning issues in adolescent health. We are talking about many recent things. But the adolescents, who are adolescents? They are neither children nor adult. It is in between childhood and adulthood. We cannot avoid them that they are children. And we cannot accept them everything what they tell as they are adult. As per WHO, the classification is early, middle and late. That is from 10 to 19 years. During the early, the spurt growth of the secondary sex characters and the middle adolescence being, they want to experiment. Sweet 16, always attracted by the opposite sex. And third, the late adolescents being their distinct identity. They have their well opinion and ideas. So whatever they decide, they think that it is the correct thing. It is our duty to streamline, because around 23% of population is adolescent. By 2030, it will increase to 40%. India is the country where there is more percentage of adolescent are there. These are all the challenges. 45% of the adolescent girls are undernourished. Now you had a wonderful talk by a panel by Dr. Bellad about the anemia. We are talking about anemia for more than 3 decades, but still anemia is the common cause for maternal mortality, around 60%, whether it is rural or urban. So it has to be corrected from the adolescent. We do not know when the conception will happen. It can be married or it can be unmarried. So always at the age of 12 years, the hemoglobin should be 12 grams. You cannot make that as a 15. It's very, very difficult. Last week also, I did the hemoglobin in one of the schools. Less than 60% of the girls were at the hemoglobin of 8 grams. And 20% of adolescent boys are also undernourished. And the early marriage, we talk about the POXO Act. Still the early marriage, less than 15 years is 26%, and less than 18 years is 54%. And sexually active, when you go for the school counseling, you have to talk about the sexual activity also. Previously, we used to talk about good touch and bad touch. Now it has gone, safe touch and unsafe touch. So always talk to them about even the contraception. The girl come to the OP and she is telling that I have my boyfriend, I don't want to become pregnant, I cannot live without boyfriend. In that cases, we have to counsel about the contraception. It is our duty to talk to them about the contraception and taking care of the POXO Act rules and regulations. And 59% of the adolescent know about the condoms and the contraceptives. And 4.5% are drug abuse. And the HIV new cases, 50% of the new cases is between the age of 10 to 25 years. Again, the adolescent abortion, after talking of the safe sex and the contraception, still the adolescent abortions are 1 to 4.4 millions. These are all the challenges. So the first is the nutrition. What about the adolescent breakfast? Many of them, 2/3, they don't take the breakfast. If at all they take the breakfast, it's mainly the fast food. So because if they don't take the breakfast, the carbohydrate metabolism will get disturbed, and that is one of the reasons for the obesity. And the breakfast, what we were taking, idli, idiyappam, uttapam, like that, that should be counseled for the adolescent. So the nutrition is during the adolescent only, 50 to 60% of the muscle mass and the bone mass happens. So if you don't counsel about the nutrition, the obesity. So counsel the adolescents not to take any snacks when they watch TV. Because what is the amount of food, the snacks they are taking, they may not be knowing. See, why I am talking about this obesity. If the obesity, BMI, more than 30, if not counseled, they are the 90% who is going to become PCOS. That PCOS nowadays, where rather than the girls, the mothers are very worried and they will go for the scan. But for adolescent PCOS, ultrasound has no importance. Only the hyperandrogenism and hyperinsulinism. So if you don't correct the PCOS in adolescents, they go for GDM and the GDM deliver macrosomia. This macrosomia baby again will become PCOS. So always counsel the obesity during the adolescence. The simple exercises, walking, swimming, cycling, these are all the exercises we counsel for everyone. But you cannot counsel this for a +2 student. So better to avoid the escalators, to avoid the lift, and use the staircase or do sit-ups. Whatever they are doing, they are reading, they can recollect and do the sit-ups 30 times. It will also increase the memory power. So 30 minutes exercise is really important. Anemia, you had the fantastic panel. We have to counsel about the iron-rich diet, colorful fruits and vegetables. If you don't counsel, what happens? With this anemia, she becomes preconception, she becomes married, and the maternal mortality directly or indirectly, 60% is due to anemia. So everything is to be counseled during the adolescent. Then this mental health. So again, the suicidal tendency with adolescents is about 40%. That too, with the 40%, The adolescent girls, 55% suicidal tendency and 45% with the boys. Failure. See, if they don't get the good marks in the physics or in the +2 exams, they immediately think, go for the suicide. So I usually tell the adolescents, when they are in depression and when they are mood disturbance, they should not decide anything. In the depression and anxiety, ask them to count them, close your eyes and count from 1 to 100. Again 1 to 100. I'll tell them, just postpone that suicidal tendency for few minutes. So when they close the eyes and count, they will become, it is only an instant. So they will change and the suicidal tendency will reduce. So the mental health is very, very important. The depression and anxiety, see, this is the 14 to 40% report suicide attempts. And after one of the schools, I did this counseling. And after counseling, if you go to the school counseling, every year you should go to the same schools. The students may be different, but they will know what will happen and the incidence of all will reduce. Then this substance abuse, because of this depression and the peer pressure, they are getting addicted to the, not only the boys, even the girls, smoking, alcohol, drug abuse. We have to tell the negative impact. You cannot go and tell, don't smoke, don't take alcohol. If you tell like that, adolescents always, they don't like advice, only informations. So if you go for alcohol, you will go for liver cancer. With the smoking, you will go for lung cancer. Drug abuse can produce any blood cancers. So the negative impact, if you tell, they will try to avoid. And such that we have to counsel even the parents and the teacher. Counseling is important for everything. The parents should take care of the adolescent. At least 10 minutes per day, they should spend for the adolescent. Always I will tell, the night dinner, all of them should sit together and have it. That is the time they can spend time with the children. So if the safe sex, if not practiced, again they become pregnant. If they become pregnant also, they do not know whom to tell, whether the adolescent girl can come and tell the mother that I am pregnant, I want to go for MTP. See, we cannot, always it is not the fault of the adolescent. It is the environment and it is the situations. So most of the 14% of the adolescent pregnancy go for preterm and 20 pre for miscarriage and 27% of abortion, and only 59% will go for the pregnancy. That too, the 16-year girl will marry a 30-year man. He may be knowing everything, but this girl, they may not be knowing about the contraception and even the STDs. As I told, 50% of HIV is only with the adolescents. So we have to counsel this. In spite of repeatedly talking this teenage pregnancy, the incidences, every time it is coming, but still the teenage pregnancy is going, as all of us know, it is near Dharmaburi, it is around 40%. About 16, I always focus on the teenage pregnancy. That is the burning issue now with the adolescent. About 16 million girls are aged 15 to 19 years, become pregnant, and 1 million girls under 15 age give birth every year. And this girl is, it is in Chennai. Near the Chennai, there is one area called Thoraipakam. This girl, the child which lies on her lap is her third baby. And she is only 20 years. So we are doing the counseling. In spite of that, with 20 years, she has done sterilization also. So repeated counseling. We should counsel the adolescent, and education is very, very important. 2/3 are sexually active before 20th birthday. 49 girls get married before 20. And 10 to 40 unmarried have unintended pregnancy. Always the pregnancy should be intended. It should not be unintended. Then only we can have this preconception counseling and all incidents reduced. 14 million children born worldwide is from 15 to 19 years. What is the cause for teenage pregnancy? Whether it is rural or urban, main is poverty. If there is a poverty, they don't want the children, that too especially girls, to go to the school, and they don't want to spend, they want to get married early. So early marriage. Next comes the school dropouts. If girl or a boy, mainly the school dropout will be girls rather than the boys. And the poor educational opportunities. Since they are not going to the schools, they lose the educational opportunities. And finally unemployment, they get married and they become pregnant. And the nuclear families. Now, the single parent, nowadays it has become very common. Single parent, only mother or the father, first marriage, second marriage, everything is going on. No care for the adolescents. And this abuse, as I told, this alcohol, smoking, this drug abuse is one of the reasons for the rape incidences and the pregnancy. and the early monarchy and the domestic violence. The sexual abuse, the girls, they don't come out. The sexual abuse incidence is not, prevalence is not reported because many girls, they don't come out and tell the incidences. They may be a close relative. They may be a close person next to her house, but she cannot come and tell about the sexual abuse. That is one of the reasons for the adolescents, and the poor access to health care. So they don't know where to get the contraception, whom to get the counseling. So these are all the causes for the teenage pregnancy. This is with the rape, alcoholism, substance abuse, social pressures and the low self-esteem, influence of the media. Whenever the adolescent is having a doubt, they don't come with the parents or the teachers. They will ask only her friend. But she may not be knowing. But without knowing, she will advise something and all. So the media is the best teacher for the adolescents. So rather than getting the information from the media, the parents and teachers should talk to them about all. Sex also. See, when we were adolescent, when in the media, if marriage function is seen, the next minute our parents will tell, go and bring water, because next thing will be the first night season. But now, one of the serial is going on. For more than 1 year, the first night is not yet occurred. But it is going on for 1 year. So how long we can tell? So it is the best thing to counsel them with the anatomical description, how the pregnancy can happen, how the ovum occurs, how the sperm comes, when the ovum and the sperm join, when they can become pregnant. It should be explained with the anatomical descriptions. Then only we can reduce the teenage pregnancy. So all of you will be aware of this word no. See, a girl, if a boy follows her or something, means she should try to tell no. No means no. So she can tell the valuable reason that I want to achieve these things. I have some commitments in the family. There are many things she can tell in the polite manner. And if at all that boy is interested, let her achieve her career and then she can get married. So the best thing is the girl should try to tell no whenever she wants to tell no. And these boys, all of you are aware of this Pinky movie. No means no. If the girl is telling, whether it is a girlfriend or a wife or the profession, if she is telling no means the boy should not touch. This is the incidences. The counseling is the only thing which will reduce the 2 minutes. I'll finish. This is from our Tamil Nadu Federation. We are doing the school counseling in the online. In the December month, we have covered more than lakh students. We can do the counseling, but it should be implemented. So what happens with the teenage pregnancy? The same things. The complications, you all will be knowing: anemia, miscarriage, PIH, and again the cephalopelvic disproportion. Incidence of LSCS will be increasing, and the girl may not be knowing how to strain. So there will be the traumatic fistula. Postnatally, again PPH and the psychological illness. She herself is the child. She may not be know to how to lactate and how to get over the baby. That itself will go for the depression. And similarly, the baby will go for prematurity, low birth weight, IUGR, and inadequate care. Neonatal mortality, again, the teenage pregnancy delivered babies are one of the cause for the neonatal mortality. And the breastfeed, it's very, very important. These adolescent girls, they don't know how to catch the baby, how to feed the baby. They can have the lactation counselor. Many people may not be affordable to have the counselors. So this better thing to avoid the teenage pregnancy is only counseling. These are all the statistics. In India, Lakshadweep is come, Tripura is number 1. The risk factors, the Muthulakshmi Reddy scheme. I don't know all of you in Tamil Nadu, whenever if a lady becomes pregnant, they will get 18,000 rupees. Antenatally 6,000, during intrapartum 6,000, after delivery 6,000 for lactation. But for teenage pregnancy, even this Muthulakshmi Reddy scheme is not given. So they do not get even this Muthulakshmi Reddy scheme money, but still the teenage pregnancy incidence is not reduced. So talk to them about the contraception. Everyone can give the counseling. The school teachers, mass media, health services, and the celebrities. If a celebrity is telling that use contraception, use this nutrition, use this, they will listen to that. So we can use them even for this counseling classes. And this is the recommendations. So you have to talk to them about all the contraceptive methods. The DMPA, previously they thought that the bone density will be reduced. It's not. As per latest studies, you can have even the DMPA for adolescent. Sexually active adolescents can have even the copper T. and the progesterone only pills. As far as possible, estrogen contained pills should not be used. These are all the recommendations. Multidisciplinary care, if they become the teenage pregnancy, in the all stages they should be given care. So the conclusion is educational program for children and adolescents. That is the only thing which will make all the burning issues in the adolescent will reduce. Programs to improve access to contraception and programs toward educating parents and the family members. See, we will tell the PCOS girl, don't take pizza, burger, pani puri. But the mother will be taking the pizza, burger and pani puri. So what is the point in telling the girls? The whole family should cooperate. That is the reason we will reduce the incidence of obesity. It is a multi-component program. Youth developing programs should be done frequently. Thank you. I take this opportunity to tell that I am contesting for Foxy President from South after many years from Tamil Nadu. So I need all of your support for this President. The election will be 2026, August 1 to August 20. My aim, first focus will be only on adolescent. Thank you.
And I think all the factors when we consider, the mental health comes first. Because recently I had a patient, both husband and wife were very highly educated, well off and all that, and they had one daughter, 16, 17-year-old, beautiful, again talented, and scoring 98, 99% and all that. She was taking PUC exams. On third day, she committed suicide. Till today, they don't know why. And retrospectively, if we think, I think we should not allow them to be on their own for a long time. We will not know what is making them become sad or whatever. So parents should be educated about all this, I think.
One incident I will tell, this is the last thing. In my college, our dean, her daughter is doing medicine, anatomy. For the first time she had some diarrhea or something, she didn't write the exam. Nowadays, within a month, they are conducting the second exam. During that anatomy exam, again she was not well and she didn't write the exam. Immediately, I told our dean that you please don't allow her alone, as she was telling. The same day night, she committed suicide. Only daughter, dean, educated, she is in the medicine. So the adolescents, they don't know. They are like glasses. If you counsel them and train them, you can make beautiful things. If you don't take care, it will be broken into pieces. So all of you from today, do a school counseling near your house, 30 minutes per month. You go to the same school. So unless the adolescents are educated, nothing will be reduced. PCOS, anemia, GDM, endometriosis, infertility, everything starts from the adolescent. Thank you.
Thank you. Thank you.
Madam, now every school and Madam, nowadays every school and college, they are wanting counselors, but they are wanting our speciality as counselors. So that is one we can register ourselves in each and every school, and as you said, consistently be in the same school or the college continuously and try to develop a bonding between the students. That is when I think they'll reach out to us first than the teachers or the parents.
Yeah, not be judgmental. Yes. And how she said, no advice, only show them the effects.
Give them the information.
Yes, information.
Her favorite talk. Let us listen from Dr. Shanta Kumari, her talk.
women who have a tendency to undergo a premature ovarian insufficiency. There are a lot of incidents of premature ovarian insufficiency. So there is a baseline FSH, estradiol, day 2, no recommendation for routine, because in earlier days, day 2 FSH, day 2 E2, all used to be done. Recent HRA guidelines say that please do not do these things. They have no role, not required, unless you want to confirm that it is a menopausal change only. Otherwise, there is no role of doing a FSH or other test routinely. AMH is good enough. So consider patient factors like age, BMI, previous ovarian surgery, genetic polymorphism like FSH polymorphism or anything else, other things. So just before you stimulate them. So these are important factors. So this is one of the most common protocol, that is a GnRH agonist protocol, which was used to be there 15 years before. When we were studying, this was one of the most common protocol, and most of the earlier publications you see, they talk about all the live birth rates and everything, all the complications based on this protocol only. So here you used to give an agonist initially and then start with the stimulation. Invariably HCG was the trigger here, and very high chance of OHSS. So this is no longer favored in the new ISHRA guidelines. So ISHRA guidelines say that you please go into a antagonist protocol only. So this is antagonist protocol wherein you start gonadotropins, and when the follicle size becomes about 12 millimeter, approximately 6 days and above, then you add a dose of antagonist daily. From then, that is the idea, because you consume less injections, lesser days, lesser complications. So it's a very beautiful protocol, and 99.9% of protocols today are antagonist protocol in most IVF units. Okay. So protocol selection, well, how do you select in both? So strong recommendation according to ISHRA is to select a GnRH antagonist protocol are preferred, because and comparatively more efficacy and lower OHSS risk. In predicted poor responders, either antagonist or agonist may be used, because here OHSS is not a possibility in low responders, because here you don't get many eggs. So here it's okay, you can do either of them. And pros and cons, agonist down regulation may yield more synchronized follicular growth, because you have given a OCP in the previous cycle, you have down regulated, there is a possibility that you will get a better synchronized follicles in especially low ovarian reserve patient, wherein the synchrony is not great. There is one bigger size, one smaller size, and day 2. So long protocol, sometimes the agonist protocol gives you a regular size or a synchronized size, which will help you in proper stimulation. And in those patients, since it doesn't make much difference, agonist can be preferred, because OHSS is not a possibility. So how do you start dose? So what is the dose I should start? I should start 300 IU, 200 IU, and what is the dose I should start with? So it's based on age, AMH, BMI, and prior response. For predicted poor responders, 150 to 225 is good enough, showed better estradiol response. So if the response, they are poor responder, up to 225 is what you can start with instead of 150, because here the response is going to be slow. And no benefit above 300. See, this one change I wanted to emphasize. Earlier guidelines used to say that maximum dose above which you do not expect a response was 450. Now it has come down to 300. Above 300, you don't make really much difference in dose. Some people give 600 international units of gonadotropin daily. So which is absolutely it is just like placebo above 300 IU. 300 IU is a ceiling above which if the follicle has to respond, it will respond. Above which it is not going to make much difference if I add 450 or make it 600. It's not going to make too many differences. So please understand this. So any poor responder also 300 IU is good enough. This is the last dose. Exceeding it is not good. So recombinant FSH or highly puritative FSH preferred over renal formulation in many settings, but then there is no concrete evidence to say that recombinant FSH is good or HMG is good. HMG also gives a equally comparable pregnancy rates. So this is one more Pandora box wherein pre-treatment or adjuvant treatment. So a lot of people use so many, if you see IVF center, there are so many things they give as a adjuvant. LH is given, the growth hormone is given, so many things are given. Most of them are absolutely not required. Earlier at least OCP priming we used to do. So even pre-treatment with OCP pills or estrogen in cycles actually even is not required. It is not going to give in much difference. In fact, some papers say that it is going to reduce the efficacy or even the quality of the oocytes. Progestin or progesterone pre-treatment used to be done earlier. So they used to give progesterone and before the cycle is started and then start the stimulation. Even absolutely that's also not required, not recommended. And add-ons like growth hormone, DHEA, testosterone, all these things are not required. In fact, some of the British guidelines are even put a red line on this. Don't do all these things like putting PRP into something, putting all these hormonal. None of them have any evidence. So much medication has been given unnecessarily, and totally these are not required. Pre-treatment add-ons have no evidence, and according to the recent ESHRE guidelines, it is not required and not to be done. So it's very important to monitor properly during stimulation. Best is what is your hand and your eye, that is your ultrasound. What you see is what you believe. You count your ultrasound machine, your follicles well, you see the follicular size, follicular number, which is good enough. Hormonal monitoring is optional, not mandatory as per guideline, because in previously guidelines or previous fellowship teachings, we used to have estradiol monitoring, progesterone monitoring, even on 6th day, 10th day, other things. It is outdated. You don't have to do any estrogen, progesterone or LH monitoring. It is not required. It's not going to make any difference if you are doing your follicular monitorings properly. Okay? And adjust gonadotropin dose based on the follicular response and monitor the early signs of OHSS risk. And trigger final maturation, leading follicles are 16 to 22 millimeter. You give SCG, a GnRH agonist or dual trigger. The GnRH trigger is preferred to reduce the OHSS risk. 99% of my trigger today is a GnRH agonist trigger, because I don't want any OHSS in my clinic. Anything about 10 follicles, I generally prefer a GnRH agonist trigger. Even dual trigger has a higher chance of OHSS, so I don't prefer it. Luteal supports, generally macronized progesterone, vaginal macronized progesterone is good enough. No additional progesterone is required. The oral dydrogesterone, according to new ESHRE guideline, has no much of a role. So almost it has lost the ground in this new ESHRE guideline as per the luteal support. The vaginal macronized progesterone is good enough. If supplementation can be done by subcutaneous or intramuscular route. For the past 10 years, I have not given any intramuscular injections. Either subcutaneous injection once in 3 days along with the vaginal, that is good enough. You don't need any other support, because little support is required. It has become a big market and it's not required all the time to give too much of progesterone. And dydrogesterone was discussed and controversial, and guideline flags recommendation of the dydrogesterone. And identify and prevent OHSS, because GnRH agonist trigger will help you. Mild stimulation or lower gonadotropin will help you. Freeze-all approach is the best, wherein this is more physiologically we can transfer the embryos. Careful fluid management to avoid HCG is required. You can see this is how you should identify. This is a low ovarian reserve, and here there is a good ovarian reserve. You should make out by ultrasound only whether my patient has a good ovarian reserve or a low ovarian reserve. If low ovarian reserve, lower response and higher cancellation rate is expected, please counsel. It's always important to counsel the patient properly before you proceed, so that you are safe. Patient spends a lot of money. So poor responders, above 18 follicles generally considered as a higher response, and you have to be more careful. Use agonist trigger compulsory. And in poor responders, dose stimulation, that is dual stimulation, can be tried, and adjuvants not recommended. Please do not use any of the adjuvants. There is no use, there is no role of this. Use of mild stimulation or modified protocols can be done, because it doesn't make much difference whether you use mild stimulation or moderate, because it's not going to give much oocyte yield, because oocyte yield will be less. So you personalize the individual controlled ovarian stimulation based on AMH, AFC, BMI, and now the EI integration is coming slowly into this, and imaging data analysis is being done, and there is some lack of some quality, high quality RCTs in poor responders and adjuvants. Still it's going to come. So see, now if the patient is 32-year-old, normal ovarian reserve and first IVF, definitely go for antagonist protocol. No need of anything else. If lady is already 40-year-old and poor responder, low AMH, in this consider mild stimulation or a dual stimulation. Don't go above 300 IU, because above 300 IU of gonadotropin, it is not going to help. So this is the message I want to clearly convey. If it is PCOS or a very high risk of OHSS, avoid a high dose, just start a low dose and use agonist trigger. This is a kind of thing. So this is the difference between 3 protocols. So down regulation in agonist protocol is not required in most of the patients. OHS risk is lower in antagonist, and monitoring is moderate, and cost is little lesser in antagonist protocol compared to the agonist. So this is a comparison of all the three protocols. So trigger, you can use HCG, you can use agonist, and you can use dual or combined trigger. More chance of hyperstimulation if you are using a dual trigger and agonist trigger to prevent OHSS. So OHSS needs to be taken care. I'm done. So freeze-all strategy is more important when the high risk of OHSS is there, and you can freeze the embryos. Don't do fresh embryo transfer. And oocyte yield per stimulation cycle. This is a key performance indicator. Maturation rate, fertilization rate, cumulative live birth, and OHSS incidence per cycle needs to be checked. And implementing this, the variation in resources, lab quality, clinical experience is more important, because in IVF lab, getting embryologist, lab maintenance, everything matters. Patient compliance, monitoring is more important, especially they are coming from far places. Cost constraints in low restricted resource settings are more important, because patients are not affordable. Standardizing the protocol across center is important, because I have a chain of 110 centers. So whenever I see there is so much of a difference happening everywhere, every day we monitor. So these are difficulties of standardizing the protocols. So this is a simple algorithm how the things are done, and this is a summary. So individualized control volume stimulation, use AMH or AFC for prediction, antagonist is preferred, and avoid overdosing FSH, monitor and adjust, use safer triggers and freeze all, luteal support, and just a micronized progesterone is good enough. Thank you again, and this is my number. If you are not on my WhatsApp group, please send me a WhatsApp. I'll add to my WhatsApp group wherein we discuss some infertility cases. Thank you again for giving some extra time, madam. Thank you.
Thank you, Dr. Mahesh, for throwing a clarity on the new HRA guidelines. But what I believe is protocols are, since it is a new one, I think a lot of RCTs, as you said, the outcome of it has to be, furthermore research has to be done in this. So anyway, we'll see later. Maybe in the next conference we'll come to know whether this guidelines is of going to be improve the outcomes of the IVF patients. Thank you.
Thank you, madam. Thank you very much.
Dr. Mahesh, it was very informative, and a new recent advances is required for the PGs that you have told. And one more question for me. If the patient is having irregular cycles,
Yes,
so you have told you are not supposed to use the OC pills, then how to tackle?
Generally, we wait for the cycle to occur. Whenever it occurs, then we start on the second day. We wait for the cycle. We don't hurry with it. Whenever it happens, generally physiologically it will be normal. Then we can start. So there is no need to induce into it.
Can we, to regularize the cycle, can we give the OC pills or?
We can give, madam, but only thing, it is not always necessary. Especially when you are doing IVF, we wait for the cycle. Once it starts, we will give it. So even if you regularize it, again it's for only that month. Again it's going to be irregular. So instead of doing any hormonal variation, we just wait for the cycle to start. Once starts, then we start with the stimulation.
Because most of the PCOS will have the irregular cycles,
Yes,
and
that's
with
right.
they
Sometimes
will come
2
with
months.
a history of amenorrhea,
Yes,
so many
yes.
months. That's
So
why I
unless they have a very chronic, like long-term amenorrhea above 3 months, then we induce. Otherwise, most of them will have within 2 months. So in those patients, we wait for the cycle and then start.
Okay, sir. Thank you, sir.
Thank you.
Thank you. Yes, ma'am.
Yeah.
Time not into IVF. When you give an trigger of HCG, would you give anything less than 10,000?
Yeah, most of my cases I give only 5,000, not more.
Okay.
Because that's good.
How do you decide whether you want to give 5,000 or 10,000?
10,000 is generally when I give. See, only thing is HCG is a urinary product. So sometimes this is not a consistent capability. So if I am giving 10,000, I give 2 different brands. So that if one is not working, the other will work. That is the idea of giving 10,000 for me. Or sometimes I combine a recombinant with a HCG, this urinary HCG, because urinary HCG like urinary HMG are not predictable in response. Some batch to batch variation will be there. One suddenly doesn't act. In IVF cycles we can accept. In IVF cycles it's expensive. Already injections is taken. Since we cannot take here, so if I am giving 10,000, there will be 2 different brands, or one recombinant and one 5,000.
2 different brands of 5,000 each?
Yes.
I see.
Yes, because
Achha, it is a brand that you are looking at, and
the whole
not so
batch
much
only will change, because if that batch is faulty, if a good 2 also, 3 also, it's going to be faulty. So I want, that's what I don't want to take a risk in IVF. I give 2 different brands of HCG so that at least one works.
I see. Okay.
Thank you, sir, for the talk and updating the guidelines as my co-chairs have said. But I think in present-day medicine, it's more important to individualize treatments in all spheres, because you look at the patient and then you see what suits that particular patient. And of course, you have years of experience and you will be able to, follow that. Thank you, sir.
And that's why it doesn't make too much. I'm telling you, too much of protocols are not there. There are only 2-3 protocols. Little bit variation. 90% of the patients fall in that category. So it's not a rocket science that how we perceive that there are so many protocols. They are theories, but what 90% of the time to use same protocols with little dosage. This new ISHRA guidelines has made our life much easier. Above 300 IU of injections, there's going to be no much difference. So even the dose is now limited. So that has been made much easier and patient friendly, I feel.
I think if there are no more questions, I think thank you, sir. It was a good session.
Thank you.
Thank you so much, sir. Now I request Dr. Nagalakshmi Madam to kindly present a memento to Mahesh, sir. Sir, can we volunteer? Went out. Okay. Ma'am, can we start the session, the first session? Okay. The first speaker of today, we would like to call upon Dr. Mangala Devi, consultant and infertility specialist at KC Raju Multi-Speciality Hospital, Bangalore. Welcome, ma'am. Madam will be talking about immunization schedule in pregnancy, the cost effectiveness. Over to you.
Good afternoon, everybody. I would thank the KSOGA team for inviting me over here to give this talk. So today I'll be speaking about an important topic, that is the cost effectiveness of the immunization in pregnancy. As we all know, India is a highly populous country with 1.4 billion, and this population is considered as our economic dividend. So whatever affects the population, be it disease or even disaster, this is likely to have economic implications. So as doctors, we would want to reduce the economic implications as much as possible. And how best can we do it? But with the use of vaccines. As has been evident during the COVID time, vaccines have gained prime importance in our practice as well. So when we come to adult vaccination, vaccination during pregnancy is an important topic, because pregnancy and infancy are periods of increased vulnerability to certain infectious diseases, which can lead to significant morbidity, mortality, and long-term health complications. So in this case, maternal immunization has proved to be a safe and effective strategy that protects both the pregnant woman and also the newborn through the transfer of passive antibodies via the placenta. So the core question here is, beyond the clinical effects of maternal immunization, is it also a sound economic investment? So how do we measure the cost effectiveness of this immunization? There are several methods, some of them being the cost benefit analysis, the cost utility analysis, the dominant strategy, or the societal versus the healthcare perspective. So we use the cost benefit analysis quite commonly. Here we compare the monetary cost of an intervention to the monetary value of its benefits. So for vaccines, these benefits often include not only the averted treatment costs, but also reduced lost productivity and savings from preventing long-term disability. So why is immunization in pregnancy cost effective, especially in our country? It prevents life-threatening diseases, it reduces healthcare burdens, it improves birth outcomes, and of course the economic impact in terms of productivity and quality of life, like I already said. And we also take into account the cost of delivering the vaccines. So during pregnancy, certain vaccines are considered safe. Most importantly, tetanus and TD, which we use nowadays, hepatitis B, influenza, and meningococcal and rabies are also effective. During breastfeeding, immunization is safe, and physicians should reassure their patients that no vaccines are contraindicated during breastfeeding. However, when it comes to pregnancy, we have seen that TT has played a very important role in eliminating the tetanus in India since 2015. So WHO had reported that neonatal tetanus kills around 200,000 newborns each year. Almost all these deaths occur in developing countries. So the estimated cost per life saved is very low. It's under rupees 100 per dose, with high returns in terms of lives saved and reduced neonatal ICU admissions. This has been integrated into the UIP program and thereby ensuring wide coverage. So TT, if we see, the cost is rupees 5 to rupees 400. It is in fact free in government programs. The disease prevented, of course, maternal and neonatal tetanus, whose treatment cost itself can range anywhere between rupees 10,000 to even 2 lakhs, depending on the ICU care, ventilation, long hospital stay. So the takeaway here is that a rupees 5 or 10 vaccine can prevent a rupees 2 lakh ICU bill. So we would all agree that it is a very cost-effective intervention. So of late, there has been a lot of emphasis on the use of TD and even Tdap. So this protects newborns from pertussis, importantly, which can be fatal in early infancy. So whooping cough is, as we all know, very severe and fatal disease in newborns, and they are too young to be vaccinated. So maternal Tdap vaccination provides the crucial passive immunity that we are looking for. So analysis globally show that Tdap vaccination in pregnancy is highly effective and thereby reducing the need for hospitalization and intensive care. In low and medium income countries, the cost effectiveness is particularly strong, which have in areas with severe pertussis burden. However, it is seen that in places where there is high infant vaccination coverage, the incremental cost effectiveness of maternal immunization may not be viewed as a cost effective measure. At best, it can be viewed as a complementary strategy. So the adoption of Tdap in India is still limited because of the cost, and it is gaining traction in private healthcare settings. So like I said, in the case of tetanus toxoid, Tdap, the cost is rupees 900 to 1,600. It prevents, along with the whooping cough, tetanus and diphtheria as well. The treatment cost, if they contract the disease, range from rupees 5,000 to 1,50,000. So infants most often need NICU admission. So maternal vaccination shields newborns from severe illnesses. So this is the takeaway, and it is very important for us to inculcate into our practice. Influenza vaccine, here again, influenza is a seasonal disease, but when it affects pregnant women, it can cause severe illness and usually leading to hospitalization, more importantly, preterm birth and fetal distress. So young infants are at high risk but cannot be vaccinated, leaving them vulnerable during the first few months of life. So in high-income countries, especially an analysis done in the USA found that maternal flu vaccination was highly cost-effective, even though the outbreaks are seasonal. It became cost-saving as the prevalence and severity of the flu increased. In low and middle-income countries, it is not cost-effective if we think of only the vaccine-based specific effects alone. However, if we think broadly, and if we include non-specific effects such as the preterm birth rates, there is a significant reduction in that, and thereby the strategy becomes highly cost-effective. So the impact here is it reduces the risk of severe respiratory illnesses in pregnant women and newborns, especially during the flu season. However, the challenges are the seasonal availability, and as you know, the antigenic profile keeps changing. So the cost per dose here is rupees 700 to 2,000. And the treatment cost could range between rupees 1,000 to rupees 3 lakhs, depending on whether the disease is mild or severe and whether they require ICU admissions. So the takeaway here is, again, the influenza vaccination prevents hospitalization and protects both the mother and fetus. So hepatitis B is again an inactivated subunit or recombinant DNA vaccine where 3 units are highly effective. In pregnant women, it is stated that especially those at high risk can be vaccinated. The high risk population includes women with multiple sexual partners, those who abuse or injectable drugs or whose partners have a history of drug abuse, those who need regular blood transfusions, or those who have liver disease, chronic kidney disease, women traveling to high risk countries, and who have risk of contact with body fluids like doctors, lab staff, nurses, or even if they are a household contact. So the hepatitis B vaccine can again cost between rupees 40 to rupees 800. So the treatment cost here is, in case of acute infection, rupees 5,000 to 50,000, and in case of chronic infection, rupees 450 to rupees 1,500 per month for antivirals alone. And this is a lifelong therapy. Coming to COVID-19 vaccine, so during COVID-19 epidemic, it was seen that vaccination was highly effective in reducing the severity of COVID-19 infection, hospitalization and death. Protective antibodies were found in the umbilical cord blood and breast milk, which shows that there was protection to the neonate as well. The cost per dose was ranging between 225 to rupees 1000, and the treatment cost came anywhere between 5,000 to 5 lakhs. I think this is a underestimation, because some hospital bills went up to 10 lakhs, 20, 30, and many had to sell their belongings as well when ventilatory support was needed for long term. So the takeaway is that vaccination, even in such a special situation, prevented severe illness and the high treatment bills. So this is a summary of whatever I've mentioned so far, and we would all agree that vaccines play a very important role, not in just reducing the clinical implications, but also in, and they're cost effective, and also prove to ease the economic burden of the country. So meningococcal vaccine is not generally given. If at all, it is recommended in some women who are at increased risk for meningococcal disease. The meningococcal conjugate vaccine using A is usually preferred. The Men-B vaccine is generally deferred unless the individual again is at high risk of that particular strain. So pregnant individuals should receive the Men-A vaccine if they have not been previously vaccinated. Rabies vaccine, as we all know, can also be given in pregnancy. It is usually an inactivated vaccine and can be given as pre-exposure prophylaxis in high-risk populations. Passive immunization through administration of rabies immunoglobulin is also advised in cases where it may be necessary. And the post-exposure prophylaxis is also given as per the dose schedule that is mentioned here. In low risk, 5 doses, and in high risk also 5 doses have been given on the days that I have mentioned. But in high risk, we also combine it with the rabies immunoglobulin. Respiratory syncytial virus has been adopted in a lot of Western countries, and Indian government is also thinking of adapting it in pregnancy. And respiratory syncytial virus, as we all know, is a cause of severe lower respiratory infection, and especially in infants under 1 year. And it is seen that this is a dominant strategy, meaning that it not only saved costs while improving health outcomes, but it also prevented hospital admissions, emergency room visits, and deaths. So this is a FDA approved report on the approval of the RSV vaccine in pregnant ladies. So it is seen that the recent cost-effective analysis found that the year-round maternal RSV vaccination program was a dominant strategy compared to no intervention at all. And it also resulted in an increase of 551 quality of life analysis by preventing 38% of hospitalizations and 34% due to RSV of deaths. However, this vaccination is quite expensive. So the adult vaccine is costs somewhere between 30 to 40,000 rupees, and it is currently being given only in the elderly population, those above 60 years or immunocompromised individuals in India. So some of these are some of the this is a table showing the vaccines of that are recommended in pregnancy. I just spoke about those. So generally, it is much more better that the vaccination should be given at a as in the preconceptional stage, so that the planned conception occurs, and a lot of the vaccines which are contraindicated in pregnancy can be taken as well. Now, cocooning is another method which it's a very simple method which is adopted in most Western countries. What they do is they immunize all the contacts of not just the mother, but all the other contacts, the family members of the infant, that the infant is likely to come in contact with, and thereby contract the disease. Especially the influenza vaccine is given to all the contacts. So some of these vaccines are contraindicated in pregnancy, so I am not touching on these. Most of these are live attenuated viral vaccines, and the risk here is purely theoretical. Not all, I mean, it's been not advised, but in case there's a risk for the mother of contracting the disease, then it has been advised that we should still go ahead and give this vaccine. There are some special vaccines which are given in special circumstances, such as the hepatitis A, B, this whole list is there. So depending on the circumstance, we can give these vaccines. But the cervical cancer vaccine has been advised to give this vaccine in the postpartum period immediately after delivery. The polio vaccine, the injectable polio vaccine has been advised, and that again in special circumstances, unless the mother is at high risk of contracting the disease, we don't really give either OPV or IPV in India. So benefits immunization in pregnancy is an economically sound decision, and the evidence shows there's a clear positive return on investment. It is a dual benefit strategy, so that it protects not just the pregnant woman but the newborn as well. And healthcare systems and policy makers should prioritize universal access to recommend maternal immunizations. And TT remains to be the most cost effective due to the low cost and high coverage. Influenza and Tdap also offer high health returns. And in future, it is better to integrate maternal vaccination into existing antenatal care. And it is also important to expand public-private partnerships which can enhance uptake and cost efficiency. So in conclusion, immunization in pregnancy is an economically sound decision, like I said, dual benefit strategy. And preconceptional immunization of pregnant women to prevent disease in the offspring is preferred to vaccination of pregnant women. And the theoretic risks of vaccination of pregnant women with killed virus vaccines have not been identified. Vaccination of women during the postpartum period, especially for rubella and varicella, should be encouraged. Women susceptible to rubella should be vaccinated with the MMR on postpartum discharge. Whether live or inactivated vaccines are used, vaccination of pregnant women should be considered on the basis of the risk of vaccination versus the benefits of protection in a particular circumstance. Thank you.
Dr. Mamta, nicely you have covered all the immunizing part. And the only one thing I want to express is usually in PHC and village, they only know about the TT and Tdap. The other vaccinations and other immunization, they are not much aware of that. And you have to educate the ASHA workers and other ANMs. What are the immunization things are there in our country?
That's probably because, madam, it's not available as part of the universal immunization program in as per our government schedule. And I think that's probably because of the cost of the vaccines. But hopefully if they undertake it at a large scale, maybe they could reduce the cost. But when you think in terms of disease burden, it is a cost-effective strategy. Like I said, Government of India is also contemplating including these.
Yeah, because all expects all free immunization. Public wants all the free immunization. They want to ask about the HPV vaccines also. They will take into consideration for the freeness. So many things they have. So anyhow, you have covered almost all the thing. Good talk.
TT has not been completely replaced with TD. It is they advise that we can continue with the TT injection where possible, and ideally TD is to be given between 28 to 32 weeks, 36 weeks, sorry, 32 to 36 weeks. The last trimester is what they advise. And at least 1 month prior to the date of delivery is given in some papers.
In all the government setup, TT is not supplied at all.
One dose of TD is sufficient is what is being given.
TD is what is supplied because this is the WHO recommendation. And because diphtheria is still persisting in some of the countries, and immunization. And another thing is, regarding
as per what I read, madam, 2 doses of TT had to be given. 1 dose as soon as the patient comes to the antenatal clinic. The other dose is 4 weeks later. And the WHO has recommended a 3rd dose at 6 months later, or in the 3rd trimester where you can give TD.
Yeah, and then regarding RSV,
and 1 dose is sufficient, they've written. And once the child is born, even once the baby is born, delivery happens, if we have not immunized, to give TD at just after delivery, immediately after delivery, to the mother. Sorry, you're saying something. Respiratory, RSV.
Yeah, RSV. Does it provide the same kind of antibody protection to the neonates like influenza or...
It is believed to provide a very good profile of protection, but the cost of the vaccine is very prohibitive.
Is the adult vaccine available in India?
It is available. It is available. Like I told you, it's very expensive.
Even pediatric vaccine is extremely
No, ma'am. I think
expensive.
a lot of studies have been done. Even we in JSS, we took up a study giving it to the mothers. Pregnant woman, we gave RSV vaccine. It was available. So they found it is effective, but yet to be... It has to come in row into row list. Because of the availability and high cost, people are still considering...
Actually, when I checked online, most of the websites showed 40,000, 30,000 range. Only one particular website said 800 rupees. I don't know how, genuine that is.
But it is yet not in practice.
Okay. Coming back to TT and TD, according to the GOI guidelines, TD has to replace TT. But whatever stock of TT is still there, that has to be finished. After that, it will only be TD. And the other thing is TDAP, not just TD, TDP.
Yeah,
TDAP
TDAP.
has to be given in every pregnancy, regardless whether she had it in the previous pregnancy or not. Then again, if it is the first pregnancy, like how you said, at booking, TT or TD, whatever is available in the institution. Second, after 4 weeks. Then again, TDAP at 28 to 36 weeks. But if she comes after 3 years, she has one child, para 1, and the child is 3 years old, more than 3 years old, then you repeat the whole schedule. One, second one, and the third one. But if the child is less than 3 years old, then you give only one at booking and TDAP at 28 to 36 weeks. They are the Government of India guidelines.
And regarding the vaccines, you said postpartum, the most important thing we should remember is to tell them about contraception. Because we should at least advise the contraception when they take these rubella vaccine and, the HPV and all. So it's very important, even though we could catch them at that point, we have to also advise contraception. Because sometimes they do not follow up. Some of the patients, they don't come back for their 6 weeks follow-up. So we have to advise and sensitize them on the harm that these vaccines can do if they conceive in their lactation. Yeah. Whatever form of you have to individualize.
They have to use contraception, avoid pregnancy for 1 month.
Yeah.
And usually immediate postpartum period till at least 6 weeks, we avoid them not to have any intercourse. So that way it should work out.
No, but
Hopefully.
MMR for the rubella vaccine,
1 month,
I think
only
it's
1 month. Everything
it's
is 1
more
month.
than 6
No,
weeks.
no.
And it's given as 1 month.
No, CDC is 1 month. CDC says for rubella, for HPV, all of them only 1 month.
Yeah, and influenza definitely is very expensive because the RSV vaccine, no? Yeah. So it's very expensive, and I think we cannot adapt it in all spheres of practice. I mean, in patients who are of higher socioeconomic status, they can afford, but it's very difficult to adapt it into the universal immunization.
And especially even the antigenicity of that also keeps changing, they say.
Because of the seasonal.
Yeah.
See, in
Influenza
that
vaccine.
season, we get a whole crop of patients coming with, upper respiratory infection. We just give them oseltamivir, and then they respond very well. And we do the testing, but we do not, just because one patient has tested, we can't vaccinate the whole, crowd who comes.
Madam, I have a question. In case one patient, while taking HPV vaccine, if she becomes pregnant, how to counsel them? Like, is it advisable to?
There's no need to do anything. You just have to complete if you've given 1 dose and they become pregnant, you complete the rest of the vaccination schedule after delivery. And there's no need for termination.
No, a
of
single dose is
pregnancy.
enough now, HPV. That's what the latest is only one dose is sufficient.
No, how to counsel the pregnant lady that, like, is there any effect from the vaccine to the fetus?
No.
There's no rule and no
No,
need to terminate.
as they told.
Couple of days ago, Tamil Nadu government has introduced a free vaccine for 9 to 14 years in government. In that, they have made it very clear not to worry about if you had one vaccine and you find pregnancy positive, that there is no problem for the baby. The second dose will be given post-delivery. Since the Government of India has come with very clear guidelines, your worry about one vaccine is taken care ethically by the government guidelines. You can take a copy of it from GOI and give it to the patient. Spite of it, if she wants termination, it's for social reasons. Nobody can prevent a person. I am stressed, I want a termination, she can undergo termination. Okay? Scientifically, it is not required. Am I clear? Yes, that is all gone, Amma. That is all gone. No, you tell them that you are in the 2010.
2025 we have changed. Okay, you tell them like that. We have to know how to counsel these patients.
Thank you so much, Mangala ma'am, for your talk. We'll have the question and round session round after the session, since we are going in short of time. I would like to call upon our second speaker, Dr. Charmila, Director of Aditi Hospital, Trichy, and Vice President of Foxy 2024. She has been honored with Dr. Meheru Honshita Award, Mrs. and Mr. Pandit Award, and Dr. Datta Award for Best Publication. Over to you, ma'am. Thank you.
Thank you so much. Respected chairpersons, friends in the audience. That is one of the best talks, I would say, on vaccination. Dr. Mangala Devi did such a beautiful talk. And now mine is a little different. It is on RH isoimmunization, the current practice. We have to think that this injection came almost 55 years back, 1968, and it was approved for use in RH negative women to prevent sensitization to the blood group RH antigen after delivery. But still you have to remember it is resulting in almost 160,000 perinatal deaths and almost 100,000 cases of disability annually, and that is only a 50% reduction related to the era before the immunoglobulin administration. So as practitioners we are lacking somewhere, and this high burden of a preventable disease should be considered completely unacceptable according to a statement made in 2013. The reasons for why this immunization schedule is not being followed is maybe an insufficient supply, cost considerations are there, ignorance, because sometimes the practitioner can forget, the patient can forget to administer the injection when needed. There may be a lack of access in certain areas, and probably using products that do not have a tested therapeutic efficacy may all be contributing to this number, so much perinatal morbidity for a disease which is totally preventable. So there are some questions which are there in RH negative pregnancy. I'm not going to go into the basics of that, but these questions a clinician always thinks about when separate. But in the second pregnancy, all the morbidity starts, and that's because the baby's fetal RH positive blood is being attacked by the maternal RH antigens, and that is the reason why these babies have morbidity and sometimes rarely even mortality. But remember that not all mothers respond in the same way. There's something called a hyper-responder, there's something called a hypo-responder, and there's a non-responder. And actually only 16% chance is there if anti-D is not given. So sometimes you may even escape when you don't give the anti-D injection at the right moment. But remember, there is a group of patients who are hyper-responders, and that is almost 10 to 20% who will have a massive response even if only a minimal amount of the maternal blood has gone, minimal amount of the fetal blood has reached the maternal circulation. But there are good ones, the hypo-responders, where that is also in 10 to 20%. Only when a large amount of fetal blood reaches the maternal circulation, then they have a response. And there is a good group, which is the non-responders, who do not respond to the RH antigen when it enters the maternal circulation. And this mechanism, we know how anti-D works when there's an RH negative pregnancy and you're giving the mother the injection. It's an antibody against the D epitope present on the fetal RBZ. So when you give this injection as a passive injection, it coats the D epitope and it prevents the interaction of the maternal immune system with the RH positive antigen. And 300 microgram of anti-D injection, when you give it, will neutralize almost 30 ml of the fetal RH positive blood, and that is equivalent to 15 ml of packed fetal RBZs. There are several preparations available, but now it's the monoclonal and the polyclonal preparations which are available. And when you want to see the differences between both of the preparations, polyclonal preparation is derived from sera of immunized human beings. So there will be a mixture of antibodies with affinity for a wide range of antigenic epitopes. It's very difficult to manufacture in large quantities, very difficult to provide consistent batches, and the chance of transmission of infection and harmful proteins, the prions can be transmitted, can cause actually diseases in the recipient. And that's why this newer drug, the recombinant, the monoclonal preparation is very good, because it is prepared by the clone of a single hybrid cell formed in the laboratory by the fusion. And the advantages are it's specific, it's consistent, it's uniform, and it's very safe from transmission of viruses and harmful proteins. And that is a drug which is now available in the market as anti-D. And what are the recommendations for giving anti-D as a prophylaxis according to NICE guidelines? According to NICE guidelines, you should check the blood for antibodies before you give anti-D at 28 weeks. and it's usually given around 28 weeks. But if the mother comes for her first visit even after 28 weeks and she's an RH negative individual, you should give anti-D. And suppose she's got any sensitizing even during the pregnancy, like a antepartum hemorrhage, or she's had some procedures done, you will need to give an anti-D at that point of time. But usually it's a postpartum dose which is given after the birth of the baby, and when you should take the cord blood and the maternal blood and should check for a fetal leak to quantify of how much of anti-D to be given. That is usually the optimum way of giving anti-D. And suppose you detect a very large feto-maternal hemorrhage, you may need to give a higher dose of anti-D. And this is the recommendation by two different groups. The American college says that you need not do an indirect Coombs test before you give anti-D, in contrast to the RCOG, because they say only 0.099% will become immunized before 28 weeks. So there's no need to check for the antibody titers. But the American Association of Blood Banks says very clearly, do an ICT before you administer the anti-D. And what about the missed doses? Remember, the RH antibody titers will be seen very soon after an anti-D injection, but it will be weekly positive. Half-life of this injection is for 16 days, and only very low titers will be seen at birth. And that's why giving an antenatal dose may not be enough, and you need to give an additional postpartum dose once the baby is delivered within 72 hours of birth of the baby, if it is RH positive. And remember, you will see the anti-D antibodies for 6 months after birth when you give these injections. And suppose ICT becomes positive after 6 months, remember it's due to sensitization. And suppose you have given an anti-D injection for a sensitizing event during an antenatal period, and the delivery occurs within 3 weeks of that injection, you need not repeat the dose again unless it is a large feto-maternal hemorrhage, where you may need to calculate and give the anti-D again. And suppose you have missed the dose, remember, if you have not given within 72 hours of delivery, at least give it till 28 days of the event, because that can also be helpful to the next baby. And what are the intrapartum precautions you will follow in an RH negative pregnancy? There should be a consultation with a neonatologist. Do not give methergine or like drugs which can act very fast on the uterus, uterotonics at the delivery of the anterior shoulder. Oxytocin will be good enough. And suppose you need to do a manual removal, do it very, very gently. Do not traumatize much. And suppose the mother needs a blood transfusion, use RH negative blood only. And early clamping of the umbilical cord is usually indicated in an RH negative pregnancy. And always leave a long length of the cord, about 15 to 20 centimeters in the baby. The postpartum precautions, the neonatologist should be involved. The baby's cord blood should be sent for ABO RH typing. Direct Coombs test should be done. Hemoglobin, bilirubin levels in the peripheral smear should be done. And if the baby turns out to be RH negative, each presentation, you should give an anti-D. Intrauterine death, whether in the second or third trimester, warrants a anti-D injection. And abdominal trauma, you have to give anti-D to the mother. And this is the dose which is usually advocated by the different guidelines. The postpartum prophylaxis uniformly by all the guidelines is 300 microgram within 72 hours of delivery of the baby. Regarding sensitizing events, there are like differences in the guidelines. That is, if it's less than 12 weeks pregnancy, the dose advocated by American College is 15 to 120 microgram. And if it's more than 12 weeks when the sensitizing event is happening, it's 300 microgram. RCOG differs a little, and they say they give it as in international units. So it's 250 international units for a pregnancy which is less than 20 weeks. And if it's more than 20 weeks, they give a dose of 500 international units. But there are different sensitizing events, and that's why the dose actually varies. Suppose it's an abortion, there's only a 5% chance of sensitization, and that's why they say 50 microgram is quite enough. But if there's an invasive fetal procedure, the chance of sensitization goes up to 11%, so you will give a dose of 300 microgram. In antepartum hemorrhage, 300 microgram stat should be given, and it can be repeated 12 weeks later if the pregnancy lasts that long. That is because she can still need a dose during a postpartum period, because the dose may not be enough to cover the entire period of pregnancy. And suppose there's an external cephalic version, it's better that you give a 300 microgram dose, even if it's a 6% chance of sensitization, because it's a term pregnancy. So when will you estimate the fetal maternal hemorrhage before you give a prophylactic dose? These are the conditions where you will have a higher chance of the fetal and the maternal circulations actually combining. So that will be intrauterine fetal demise, an abruption placenta, a bleeding placenta previa, and a manual removal of placenta, all warrant that you estimate the fetal-maternal hemorrhage before you give the prophylactic dose. And how do you calculate? You will do the Rosette fetal RBC screen for the fetal-maternal hemorrhage. Once you screen and you identify that there's been a hemorrhage, you will do a Klehoff-Beckett test to quantify the RBCs in the maternal circulation. You will estimate the volume of fetal-maternal hemorrhage, and then you will calculate the dose and give, and that should be given within 72 hours of delivery. And this is how you calculate. And if you calculate that the mother needs 5 vials, you can give it IM dose, but beyond 5 ml, you cannot give RH immunoglobulin as an IM dose. You may need to give an IV dose, and you can give it 8-thali IV until the total dose is given. And but remember, it's not so common, and usually it's only 0.7 ml that the transfusion, usually the fetal-maternal transfusion is usually only 7.7 ml, and that is your regular dose will usually correct that. And very rarely you will have the transfusion exceeding 10 ml, and that happens in only 1% of the cases. And suppose the baby is immunized and the mother is immunized, and then what happens? Then you have to monitor the baby by doing an indirect Coombs test, and you have to follow up once in 4 weeks. And suppose the titer levels remain below the critical value, you can go up to term and deliver the baby. But if it turns out to be above critical levels, then you have to manage it as an affected pregnancy. And because you have to remember that the baby may go for a fetal anemia, fetal hypobilirubinemia, and both these are neurotoxic to the baby, and that's why you have to be very, very careful in managing these children, these neonates. And because the clearance may be problematic by the placenta, and that's why you have to be very careful. And remember, it's actually not, there's no intravascular hemolysis in the baby. It's actually an extravascular damage to the RBCs happen in the extravascular space, and that's why immature erythroblasts are produced, and those cause the maximum damage. And when you have an affected pregnancy, you have to check the titer values, as I said, till 34 weeks, and after that it will be once in 15 days. And once the critical titers are reached, previously we were doing the amniocentesis, taking out the amniotic fluid and doing the Lilly's curve and all that, that has gone out of the picture. Now postgraduates will be very easier to follow up these pregnancies with a serial MCA Dopplers, and you have to done it once in 1 to 2 weeks. And suppose it turns out to be more than 1.5 mom, you will need to do a chordocentesis. And in chordocentesis, the PCV is less than 30%. This is an indication for an intrauterine transfusion. And suppose there's a previously affected baby, you can do a cell-free DNA nowadays to check the baby's Rh antigen status. And if it's Rh positive, you should start your MCA Doppler even at 18 weeks, once in 1 to 2 weeks to follow up these babies. The indications for this type of monitoring is a previous perinatal loss due to hemolytic disease, a previous need for an intrauterine transfusion, or there's a need for a neonatal exchange transfusion in the previous pregnancy. This is the algorithm which is usually followed when there's a sensitized Rh negative mother. And the recent advances, non-invasive fetal RHD genotyping is quite safe, and you can do it even without an amniocentesis. Nowadays, point-of-care tests are available, which can be done rapidly for determining the Rh status. A lower 50 microgram dose can be given for first trimester abortion, and the concept of partial D and weak D antigens have to be considered because they can also form anti-Rh antibodies. The take-home messages will be every woman of childbearing age should have her ABO and Rh types done at first contact. And now in India, we still do the husband's Rh status, and we do not follow the Western criteria of not doing. We do it and to check out whether the husband is positive or negative. A single postpartum dose may be inadequate in case of severe fetal-maternal hemorrhage, or may need to repeat the doses. And please consider giving even after a postpartum tubal ligation nowadays, because they can have a new partner or they may need IVF, and then you should not land up in a problem. Thank you so much for a very, very patient hearing. Thank you.
Thank you, ma'am, for a very informative and very clear. I think Rh negative pregnancies, we teach our students like it is like mathematics.
Yes, ma'am.
It is like the guidelines are so. Please introduce our first speaker of this session.
On November 1st, for everybody to be okay, ಎಲ್ಲರಿಗೂ 70ನೇ ವರ್ಷದ ಕನ್ನಡ ರಾಜ್ಯೋತ್ಸವ ಶುಭಾಶಯಗಳು for this session. Thank Tumkur Society as well as KSOGA. Without wasting much time, I would like to introduce Dr. Padmini Prasad Madam, who everybody knows, the renowned. Every time we have Madam's talks, and
It's okay.
okay, Madam. Without wasting much time, I will hand over the mic to the Madam. Thank you, Madam.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಎಲ್ಲರಿಗೂ ಕರ್ನಾಟಕ ರಾಜ್ಯೋತ್ಸವದ ಹಾರ್ದಿಕ ಶುಭಾಶಯಗಳು. Wish you all a very good afternoon, and I would like to thank KSOGA for giving me this wonderful opportunity of knowledge sharing and enlightening sessions and such wonderful speakers and good information. So now this is altogether a different topic or a different field, which many, even the doctors, the professionals, are not so much maybe aware of it, a part of it, but they are not so much concerned about it whenever they are treating the woman or the couple. That is the field of sexual health. Sexual health and reproductive health, they are intertwined very close to each other, and reproductive health is a part of sexual health that gynecologists should know. Sexual health and function are important determinants of quality of life. Sex is not just about 3 letters, it is about 3 words: health, happiness, and harmony. So, when you are giving a quality of life to your woman, it is extremely important, because nowadays, with increasing awareness, education, employment, and economic independence, and the woman has become thinking individual and demanding individual. So you may be getting patients who are having sexual concerns. Many may present directly, or most of the time they present indirectly with different symptoms, different gynecological problems, so that so many times you will not be knowing what she is talking about and what is her concern. So it is important to diagnose, counsel, and treat her for giving the quality of life for the woman and her partner and to the relationship. So today I am talking about female sexual dysfunction. So before you understand about dysfunction, you should also be knowing about what is the normal function. So few words which we use, and what is the normal sexual response in a woman or in the couple with the sexual excitation, that if you are aware, then it is easy for you to detect the sexual dysfunctions. Sexuality is defined as a central aspect of being human throughout, and it encompasses sex, gender identities and roles, sexual orientation, eroticism, pleasure, intimacy, and reproduction. Sexuality is experienced and expressed in thoughts, fantasies, desires, beliefs, attitudes, values, behaviors, practices, roles, and relationships. While sexuality can include all of these dimensions, not all of them are always experienced or expressed. So sexuality is influenced by the interaction of biological, psychological, social, economic, political, cultural, legal, historic, religious, and spiritual factors. So it is not just a simple thing, and it can, many things have got an influence on the sexual functioning. According to WHO or the WAS, the sexual health is a state of physical, emotional, mental, and social well-being in relation to sexuality. It is not merely the absence of diseases, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, and violence. So sexual rights of all individuals should be encouraged and respected. Because sex is, most of the time, this is used as a slang or derogatory term, or thought to be obscene or unparliamentary words. So it has to be given the respect and the dignity as far as the sexuality and relationship is concerned. Sexual health is for procreation, recreation, and relation. It depends on a complex interplay of physical, psychological, and emotional factors between two persons. It is coordinated by the neurologic, vascular, and endocrine systems and influenced by family, society, and religious beliefs. So anything, a disease, an operation, surgery, medication, or even the social factors, cultural factors can affect the sexual functioning of an individual. So what is this? So to understand the dysfunction, first of all you should understand the sexual response cycle and what it is. It is nothing but the sequence of events that occurs in the body in response to any sexual excitation, either sexual fantasy, masturbation, or intercourse. There are both genital and general changes, and the main events will be vasocongestion all over the body and neuromuscular tension or myotonia. So the events include the excitement phase, plateau phase, orgasm, and resolution. So the different phases include the desire, that is the willingness to participate, arousal, which is in the form of genital swelling and lubrication, and intromission, which is the vaginal penetration or insertion of penis in the vagina. Orgasm, it is the climax, it release of the build-up of sexual tension. So this is a different figure in the Master and Johnson about the female sexual response and also the male sexual response. There are varieties of the female sexual response compared to the male sexual response. So what is female sexual dysfunction then? Any disturbance or disorder in the sexual functioning in areas of desire, arousal, penetration, and orgasm which causes distress to the woman or to her partner is called FSD. According to sexual response cycle of desire, arousal, orgasm, and vaginal intromission, there can be dysfunction in any area like desire disorder, arousal, orgasm, and sexual pain disorder. So this will help you to know or to pinpoint where exactly is her problem. So this disorder, according to definition, should be present for at least 6 months, and it should not be due to any other medical or psychiatric disorders. And the classification is done according to Diagnostic and Statistical Manual of American Psychiatric Association. But the present classification as DSM-5, they have merged hypoactive desire disorder and female arousal disorder into female sexual interest and arousal disorder, and orgasmic disorder is placed as such. The dyspareunia and the vaginismus are merged into genitopelvic pain penetration disorders. These are the other dysfunctions which you may not be. So as I told you, it has to be present for 6 months, at least 75 to 100% of frequency. It should cause significant distress, and the exception is substance abuse. So how common it is? Female sexual dysfunction is very common, nearly 43% of all females. High incidence is present in infertility clinics and menopausal clinics. So it is very important for you to take the history and make sexual history a part of overall history. Women do not complain. Either they think it is normal or don't express because of shyness or embarrassment. What is libido? We usually use this word. This is desire for sex, an appetital drive likened to hunger. It is the willingness to participate in sexual activity. It is the desire can come from sexual thoughts, dreams, fantasies, or partner stimulation. And few examples just to understand. Suma and Satish are married for 4 years. Satish has a complaint that Suma has no interest in sex. Even if the frequency is very rare, 3 to 4 weeks or even sometimes 6 months, they say, she reluctantly participates in sexual intercourse. So he is complaining of the sexual disorder for the wife. And Geeta complaining of burning during intercourse. She has no interest in sex. She often quarrels with her husband Prakash. That is an indication of dyspareunia. And Leela worries that she has not enjoyed sex from the time of her marriage. She does not feel it as pleasurable as it is described by her friends. So this is an orgasmic disorder. Vinod and Veena, they are married for 5 years. They came for treatment of infertility. Veena complains of pain during coitus. So it may be one of the reasons, that is the sexual dysfunction causing infertility, and most of the time the vaginismus. Kamala has stopped menstruation since 4 years. Her husband has a complaint that she does not cooperate in sex. He is frustrated. So menopausal sexual dysfunction is very common. So this sexual desire disorder, any of these disorders, they are the persistent problem, persistent or recurrent deficiency or absence of sexual desire or receptivity to sexual activity that causes marked distress or interpersonal relationship. So this desire, basically some may be biologically having less desire or constitutionally less desire, or there can be reasons for having less desire in the sexual. It can be physical causes, psychological, general ill health, depression or psychiatric diseases, and some drugs and the hormonal status, and difficult interpersonal relationship or the aging process. So some have positive effect on the desire and some have negative effect on the desire. Positive effect like affection, trust, favorable atmosphere, good relationship, receptivity, intimacy, and some good hormonal balance. So how do you evaluate this? So a good history is extremely important. Physical examination, hormonal study, thyroid, prolactin, some of these high prolactin and the thyroid problem, they can reduce the desire. And the treatment, basically for all these dysfunctions, the basic treatment is first of all the education, clearing myths and misconceptions, and telling the proper way of going into the act, the counseling, lifestyle changes, stress management, rest, because these days it is very common with the stress and the working hours of long working hours for women and the couple, the desire will be cut down, and some of the medications can help them, and also sex therapy. So arousal disorder, as I told you, if there will be inadequate genital swelling lubrication response that causes marked distress, and similarly some of the factors have positive influence, some have negative influence. And in any of these disorder, even in the arousal disorder, that may be due to inadequate stimulation by the partner or any local problems which causes decreased lubrication. So again, education, counseling, and some of the lubricants and moisturizers can help in these conditions. And for the orgasmic disorders, again the recurrent, persistent or recurrent delay in absence of orgasm after a normal excitement phase, causing marked distress or interpersonal difficulty. So this also has to be seen with a proper history. You can diagnose this and see whether there is improper technique, and so many times there will be inadequate knowledge and the husband also does not know so much how to take her to the orgasmic level, how the clitoris stimulation and the physical stimulation. So these things can be told to them during the counseling hour. And if there is history of sexual abuse, a proper counseling, and male problems have to be treated like premature ejaculation and also erectile dysfunction, that also can reduce this. They can cause either the desire disorder or orgasmic disorder. So again the management issues like education, counseling, and masturbation training, so that she can understand how she can stimulate and that she can translate into the coitus. The pain disorders either in the dyspareunia or vaginismus, and vaginismus is extremely common, and every gynecologist should know how to diagnose this, because it does not go just by advising her to relax and give some lubrication or KY jelly, lubric gel. So that has to be seen. For the dyspareunia, where is the dyspareunia? At the entrance in the superficial, or in the after the penetration of the vagina, or it is deep dyspareunia due to pelvic causes. So the treatment depends on what exactly is the problem, any infections, hormonal problems, menopausal problems. So proper treatment has to be given depending on the situation where the dyspareunia is. So this is the dyspareunia, and the vaginismus, it needs a proper desensitization procedure, giving awareness and the self-dilatation, self-awareness, relaxation techniques, Kegels exercises, and also slow dilatation up to the dilatation up to they can use the dildos or the dilators. So this is the one. So perimenopausal, because of the estrogen deficiency and the changes in the testosterone levels, so there will be some problem. GSM you all know, so I will not go into the detail of it. So these are the basic causes of female sexual dysfunction. It can be non-organic like social, cultural or psychological. Organic causes in the form of developmental problems, medical problems, surgical problems are due to medication. And so many times the ignorance and inadequate knowledge is extremely high. Myths and misconceptions or unreasonable and unrealistic expectations. This has become very common these days. Day-to-day stresses, lack of time, exhaustion, lack of communication, lack of privacy, all these things can also lead to this dysfunction and also the male sexual dysfunction. So why should you treat the sexual dysfunction? What are the effects? Low self-esteem, sense of futility, frustration, psychological problems like anxiety, depression, worry and unhappiness, marital disharmony, disturbed interpersonal relationship, quarreling, arguments, infertility, which is the most important thing. It can lead to divorce, and it can also cause dysfunctions in the male because of the female dysfunction. So history taking is very important. In addition to all the other history, the sexual history, and the 2 minutes. So the examination like external genital examination, per speculum, pelvic examination, all these things will lead you to some form of some understanding of the disease or the cause of the disease. And lab studies depends on, you have to tailor it according to the symptoms, and also some of the hormone testing is very important. So the medicines, some of them can be given orally like anti-anxiety drugs, antidepressants and hormone replacement therapy, flibanserin or the female Viagra, bremelanotide, sildenafil, testosterone in different conditions where these things can be used. And also the local medications like estrogen cream, lubricants, moisturizers and anti-infective agents, nitric oxide gel and vaginal sildenafil. These are locally used medications. Counseling will definitely help. I was telling you all this time. Sex education, removing myths and misconceptions, and these are Splicit and Master and Johnson, some of the behavioral therapy, relationship counseling and also mindfulness. So these are newer methods where if there is any surgical indication needed like pelvic floor repair, hymenectomy, Kegels exercises, vaginal rejuvenation which has come in a big way, Botox injection, PRP etc. can also be tried in some of the conditions. If no etiology is discovered, provide education, enhance stimulation, eliminate the routine, provide distractive techniques, encourage non-coital behaviors, minimize dyspareunia. But never forget the partner whenever you are dealing with female dysfunction. Male point of view also has to be seen. Male sexuality is equally important and the dysfunctions have to be treated. Ensure that the partner is healthy. Women's sexual problems may be viewed as women not getting what they want. What women want? Women want consensual, mutually satisfying sex. Women want relationships. Women want self-love. Women want time. Women want sexual health and liberation. Thank you very much for the patient hearing.
Thank you very much, madam, for elaborative talk. To brief
this session, Dr. Dharmanand sir. He'll be speaking on the role of immunology in implantation failure.
Dr. Dharmaja sir, he is a consultant in Rema Care Center at Bangalore. His field of special interest is autoimmunity, reproductive immunology and chronic pain. He was the immunological past president of Indian Rheumatology of Immunization Association. He is a specific he is a specialist in committee chairman of Icon Society 2026. He has produced multiple publications. He is very popular. Over to you, sir.
Thank you very much, ma'am. And thank you very much, KSOG, for this kind invitation. I'm the only odd man out here who is probably not a gynecologist here. if I say pregnancy is a autoimmune disease, you would be surprised. It's not a disease, but it's an immunological state, an altered immunological state. So one way of defining pregnancy is it is a paradoxical state of controlled active immune tolerance towards a semi-allogenic fetus, but simultaneously maintaining mother's immune competence. So if everything immunity is suppressed, the mother will get serious infections and might suffer. So that is the delicate balance the immune system has to achieve to enable a pregnancy. And the key battlefield is maternal-fetal interface, that is placenta and decidua. So the body, the immune system or nature, whatever you call it, has evolved multiple cloaking mechanisms to protect the fetus from the maternal immune system. It has to be cloaked so that it is protected, is in a cocoon without getting attacked by the disappearing here. So what happens? Decidua is a immune rich tissue. So if you look at decidua, particularly in the window of opportunity period, it is immune cell rich, and the majority of the leukocytes are decidual or uterine NK cells, and compared to the peripheral NK cells, which have a very strong role in antiviral immunity, the uterine NK cells have low cytotoxicity. They have more immunomodulatory and remodeling role. They secrete cytokines which facilitate spiral artery formation and immune modulation there. And NK cells also, this keeps going out, cells express inhibitor signals. Say NK cells have to interact with the fetal antigens, and if it binds to a antigen which can be stimulatory, which is there in the upper part of the cartoon, the NK cells can be stimulated and cytotoxicity can be initiated. So NK cell generally express more inhibitory signal which binds to the fetal non-classical HLA antigens, and the NK cell activity, cytotoxicity is suppressed. And also cytotoxic or CD8 T cells. They also in the uterus, they have lower base levels of cytotoxic molecules like perforin and granzyme enzyme, which are the ones which go and kill. The T cells go and attach to the target cells and inject perforin and granzyme, which kills the target set. That's a viral infected cells in a usual scenario. And down regulation of classical MHC, HLA, usually most of our cells express HLA A or B, and but the fetal cells exhibit more of HLA C or E, G, F, which does not stimulate the immune system that well. So this happens in the trophoblast. So trophoblast also is an active player, and the macrophages which are present in the uterus has got a M2 phenotype. The M1 phenotype is an pro-inflammatory phenotype which is there circulating in our body, which works in an autoimmune or infective situations. But M2 has got a regulatory and anti-inflammatory phenotype. They secrete, say, cytokines which are generally immunomodulatory. So they promote a tolerogenic environment. And also Treg, for which I think that Nobel Prize in Medicine is given to somebody who has discovered the T regulatory cells and its mechanism. So T regulatory cell gets expanded in decidua and in the blood as well. So the T regulatory cell is the opposite of the active cells. They have a regulatory role, down regulates the active immune system, and if a good amount of T regulatory cells also protects one against autoimmune diseases. So one example is if you have a good gut bacteria, if you are having a good like a fiber-rich diet, an anti-inflammatory diet, T regulatory cells are upregulated compared to people who take a lot of processed food. Their Th17, which is a pro-inflammatory cytokine, is upregulated. So that is the importance of T regulatory cell, which is being explored as one of the treatment options. And also another player is CD4 cells. CD4 cells are the ones which stimulate the immune system. The antigen is presented to CD cell, and CD4 cells produce cytokines which is very important in infection protection against infection and also in autoimmune diseases. But the HLA has to be presented to T cell by the antigen presenting cells. So you need another stimulus. The another stimulus is required for the T cell to be activated. So the trophoblast express PD1, and which is an inhibitory signal. So even if an antigen is presented to T cell, the presence of a PD1, if it binds to the T cell, there is an inhibitory signal. So the T cells doesn't get activated. So in that way, the fetus is an active player in making the mom's immune system to adapt to itself. So it produces like downregulation of class 2 HLA antigens in the trophoblast, which leads to less CD4 activation. And also, it expresses non-classical HLA. The classical HLAs are much robustly recognized by the maternal immune cells. But the fetus suppresses the classical HLA expression and produces a non-classical HLA in the cells. And also, the presence of this engage inhibitory receptors in uterine NK cells, macrophage and CD8 cells. So when these interact, there is a local tolerance. So you don't produce cytotoxic cytokines, they produce immunomodulatory cytokines. And also trophoblasts produce IDO. IDO is indolamine dioxide, which depletes the tryptophan, tryptophan is required to produce serotonin, which is crucial for cytotoxic T cell and NK cell activation. So by suppressing that, you reduce the immune cell activation, and also it increases the apoptosis of the cytotoxic cells by expressing some of the proteins in the trophoblast like TNF-alpha, FASL, trial, etc. So they produce apoptosis. Even few immune cells try to escape and try to attack. There is a protective mechanism inbuilt in the fetal tissues as well. And they also produce anti-inflammatory cytokines like TGF-beta, IL-10, etc. And upregulation of the complementary regulatory proteins. When they are upregulated, complement activation is also suppressed. Complement activation is one important tool by which the immune system attacks any tissue. In addition to what happens in the trophoblast and what happens in the maternal immune system, there is a systemic shift, not only in the uterine milieu. The CD4 cells change into Th2 phenotype from Th1 phenotype, which is the dominant phenotype in normal situation, non-pregnant situation. And T regulatory cell is dominant compared to Th17, which is again an pro-inflammatory group of cytokine, not cytokines, T cells, which produce pro-inflammatory cytokines. And also you all know about the hormonal shift. Progesterone is the most important immunomodulator, which drives many of the positive facilitating immune changes in the uterus. So, and HCG also promotes deregulatory activity and also encourages immunotolerance. So, active immune recognition and accommodation happens in the maternal-fetal interface. And how does this system go wrong? For some reason, whether there is due to systemic inflammation or due to an autoimmune disease, there is an increase in uterine NK cells, and cytotoxicity of uterine NK cells can increase, which can result in cytotoxicity towards the embryo. And the Th1, Th2 balance, which should happen, if doesn't happen, again it promotes cytotoxic and pro-inflammatory cytokines and hostile environment. And the T regulatory cell, if it doesn't increase, again immune implantation can fail. And mismatch between the HLA from the trophoblast and NK cell KIR receptor mismatch can result in poorly regulated DNK cells and leading to NK cell, leading to implantation failure. Other mechanisms are presence of autoimmune diseases. The most popular one, which all of us know, is antiphospholipid antibody syndrome, which is more likely to produce recurrent pregnancy loss rather than implantation failure. But it can also may directly affect the trophoblast function and can induce a pro-inflammatory state. Presence of antithyroid antibodies and ANA, though they are non-specific, they may correlate sometimes with immune dysregulation. And take it from me that most of the patients who have antithyroid antibodies, most of the patients who have ANA will have normal deliveries. So it is not a bad thing. All our SLE patients will have ANA by default. Even if we don't do anything, most of them deliver normally. Only people who have active disease or presence of APLA go into reproductive failure. So the presence of ANA doesn't immediately reflexively should make you to think of steroid and immunosuppressives. And alloimmunity is again the failure to mount an alloimmune response to the maternal system, no blocking antibodies against the paternal antigens. And when you do cross matching, high degree of cross matching, that means HLA between parents are similar and they have poor prognosis. The lesser the matching, there's a better prognosis. And of course, endometrial infections can also produce implantation failure. What are the tests we do? Endometrial immune profiling is probably the most effective tool. It can assess the current status, immune status of the endometrial tissue. Particularly, it is done during the mid-luteal period. And of course, you can look for infections by staining for CD138. And the role of alloimmune genetic profiling is still evolving. Autoantibody testing in the form of APLA, ANA, and antithyroid antibodies. And it is suggested to do peripheral blood NK cells in addition to uterine NK cell is invasive procedure. Peripheral blood NK cells is easy. Though most of the guidelines discourage us from doing it in a selective situation where you have ruled out all the embryo, local causes, structural causes, then there may be a role for testing these cells and also look for Th1, Th2 profiling. So having said that, only two tests have got a actionable test, endometrial immune profiling and antiphospholipid antibodies. And interventions, you all know, steroid is the most popular intervention. It reduces the cytotoxicity of NK cells, reduces the inflammation, and it is given around the ovarian stimulation, early luteal phase, and if pregnancy is achieved, then it is slowly tapered over 3 months. IVIG is again where there is immune activation is documented. IVIG can be useful. It again, the mechanism of action is it can provide the maternal blocking antibodies surrogately, and T regulatory cell is promoted and NK cell is inhibited, and you have to start before FET and repeat after a conception. Intralipid is an alternative, cheaper alternative to IVIG in very similar indications. GCSF is nowadays used to enhance the endometrial receptivity and thickness, and it also shown to improve the T regulatory milieu in the uterus. And tacrolimus is a new kid in the block, and particularly when you document increased Th1 response in the system, you can use tacrolimus to control the immune activation, and there are anecdotal reports about successful outcome. And the most popular drug used by the infertility specialist is hydroxychloroquine. It is safe. It is used. Definite indication is in refractory antiphospholipid antibody syndrome, lupus, congenital heart block prophylaxis in women with anti-Rho, anti-La antibodies. And apart from that, its role is really not sure, not clear, because it is used because it is safe. Most of the rheumatologists or immunologists whom you send, they would give because they have to give something. So HUQs have become popular, but at this moment, the results are very ambiguous. We are not very convinced that it makes a difference, but if at all you want to start at least 3 months before your IVF procedure, because it takes 2 to 3 months for the immune system to be changed little favorably by hydroxychloroquine. It's not a short-acting drug, it's a very slow-acting drug. And low molecular heparin I won't discuss, we all know about it, but apart from APLA, its role is very doubtful. And LIT is again vaccinating the mother with paternal antigens to facilitate blocking antibody production and Th2 shift, and it is also shown to improve the T regulatory cells and inhibitory NK cells. But still we don't know who is the right candidate. Maybe people who have high HLA cross matching, or in the sense if the mother and father are more similar HLA wise, and absence of antipaternal antibodies, if MLR reaction. So all these things can be used. But choosing the right candidate for immune intervention is still a work in progress. I think we have to rule out all other causes before thinking about these interventions. And the ideal candidate is not clearly defined. Maybe the future, is the last two slides, the future could be look at everything. This is one study which is called optimum strategy. They looked at everything. They did a hysteroscopy, endometrial biopsy, immune profiling, and they did a culture, endometrial culture, looked at the vitamin D, Th1, Th2 cell ratio, and thyroid, and thrombophilia screening. And whatever is present, they have addressed it. So with this, like a kind of a global approach to the patient, so when everything is tackled, they have reported, this particular study has reported much better outcome. And the endometrial immune profiling, I think all of you should slowly take up this. This is one actionable intervention after you have ruled out the other embryo causes, fetal, endometrial causes. If the endometrium looks like overstimulated, that means Th1 dominant, high set of immune NK cell population, then we can use immunosuppression, IVIG, prednisolone, intralipid, anything will go. But and if it is low immune activation, Th2 is low immature NK cells, low recruitment NK cells. Here the endometrial scratching and exposure of seminal plasma and kind of what PRP, whatever you inject into it, that could stimulating the, causing some irritation to the endometrium so that it produces active immune cells there, may facilitate implantation. So these are the few things I can share here with you. It is an exciting time for reproductive immunology compared to probably the talk I had given 15 years before in a conference, similar conference. The content is totally different. So we know much more now. People have understood now. This is the first step. Once you understand the immune basis of the illness, the solutions will start coming. And at this moment, maybe Apla syndrome has got a definite treatment profile. Maybe the endometrial immune profiling is coming up, which we can offer a potential solution. So at this moment, all other things which you use should be offered as an experimental basis rather than a standard of care. You need probably an informed consent and patient education, and patient stratification is important. So 46-year-old woman, obese, 36 BMI, husband is 50 years, they want us to do the immune profile. Probably it is the age and obesity may be the dominant features. You do all the immune profile, it may not be helpful. Even ANA comes positive, they want to give steroids, immunosuppressions. Because the couple is desperate, the gynecologist becomes desperate, then leads to over-treatment. So my suggestion is to do collaborative research, and please don't do harm. No harm. Thank you.
Thank you very much, sir, for your excellent presentation. The immunology subject itself is...
And how long we can continue, when to stop?
Yeah, so depending upon what the indication is, the dose is 6 milligram per kg body weight.
Okay.
So for 300 to 400 milligram would suffice most. Maximum is 400.
Per day.
Maximum is 400 per day. And unless the woman is very 40 kgs or something like that, 200 milligram is enough. Otherwise, somewhere between 300 milligram tablets are available. So anywhere between 200 to 400 will be the dose, 6 milligram per kg body weight. Start 2 or 3 months before. How long to continue? If the patient has got a lupus, antiphospholipid antibodies, or some known autoimmune disease, continue throughout. If you are giving it only for achieving a pregnancy, maybe after 3 months we can taper it off.
Okay.
Because it's a safe drug, people would err to continue, I guess. Because it also has got anti-clotting help and yes, but there is no, I mean, it is convention, but it is no defined role. How when to stop? Whether it does it make a difference if you stop after 3 months? I don't think it's been regularly studied, because we use it in SLE throughout, APLA throughout. If you ask a immunologist, say it's safe, madam, you can continue. So you would have continued. Then it has become a habit. So that is how it is happening. And you teach your students, they are going to do the same thing. So it is more going in that line rather than based on any definite research.
In such proved cases, do we have to continue even after delivery, sir?
Yes, yes. And it's a pregnancy safe drug. You should not stop. Lot of times when you have a lupus, sometimes gynecologists stop hydroxychloroquine. That results in a very bad flare. For lupus, hydroxychloroquine is the #1 drug. Like forget about mycophenolate, azathioprine. It seemed to be the most effective drug. The stopping definitely people flare.
Do we have to do ECG?
No, ECG is not required. Like ECG, unless you want to give long-term other drugs which can prolong the QT interval, like azithromycin or some of the antifungal drugs you give long-term. Pardon? No, that happens after almost 10 years of regular usage. Immediately some people have a little flashy light. When you go out in the driving in the night, they will see little colorful, like a VIBGR kind of image. But that is harmless. But the problem occurs if they continuously use for beyond 5 years. That should not be a problem for an obstetrician. That's a problem for us. We use it for years. No, we are using it for pregnancy indication, no, ma'am. So using for 1 year, you can close your eyes and don't even check eyes. We are going to use it for 5 to 10 years, 20 years. So we have to do, after 5 years of usage, every year I have to do an eye checkup to prevent a hydroxychloroquine ophthalmopathy.
When given the choice for HCQS and tacrolimus, which one do you prefer, sir?
Given a choice, hydroxychloroquine is always safer. Maybe if you document very high NK cells and if you do a Th1, Th2 profile, if it is very high, tacrolimus is likely to be more effective. If that is going to be the cause for pregnancy loss, then tacrolimus is more likely to be effective.
Thank you, sir.
Thank you, sir, for that stimulating TR, ma'am. She will be speaking on the second trimester abortion in scarred uterus.
Hello. And the last topic, as she said, is going to be delivered by Dr. Sudhatia, Banupuram Matha. Okay. The challenges and solutions.
Can I start? Can I start?
She's her area of interest is high-risk pregnancy, adolescence, and preventive oncology. Positions held. She has done several publications, and she has gone into many national and international journals, UG and the PG, external and not able to see for pre-paper and poster presentations. She has done many achievements and many accolades to her credit. Over to you, madam. You can start your topic.
Thank you very much, Chairperson, for that kind introduction. Without wasting my time, let us know about the termination of pregnancy. What are the issues that we face? What are the challenges and solutions when we terminate pregnancy in a scarred uterus? So in this session, we are going to learn about what exactly is the difference in first and second trimester, what is the pathology of the scar, what does the law say about second trimester abortions, what is the amended MTP Act, why is there a raised rate of termination of pregnancy in a scarred uterus. We'll also learn about what are the various methods for termination of pregnancy in second trimester and the exact challenges a clinician will face. And let us find out what are the solutions. At the end, we will have some take-home messages. So, at the background, abortion scenario. Abortion is a common health intervention in India and globally also. About 61% of the unintended pregnancies and 3 out of 10, that is about 29% of all pregnancies, they end in induced abortion, which are wishful termination of pregnancy by the women. Globally, about 73 million induced abortion are seen per year, and 1 out of 2 they end up with unsafe abortions, which is the situation yet in India, and which most of the government hospitals, those who are working in government setup, we face this situation daily.
So abortion accounts up to 8% of the maternal deaths due to unsafe or complications of abortion and its related problems. And 10 women reportedly die due to unsafe abortions every day in India according to NFHS 5. So an access to safe and legal abortion is an essential part and a reproductive right of every woman. If the services and intervention are done appropriately, it can reduce maternal morbidity and mortality. And moreover, the MTP Act has been amended in 2021, which empowered women to access abortion services even in the second trimester and also beyond 24 weeks. And various amendments have been done, we'll know it later. There is no upper gestational age upper limit for termination of pregnancy when the indication is fetal congenital malformation, which is lethal. The morbidity and complications of termination of pregnancy go on increasing as the duration of pregnancy increases. So in the last decade, there is a rise in the number of cesarean deliveries, which has increased worldwide, and these women might come for termination of pregnancy, posing a challenge to the consultant, and he has to adopt various strategies to overcome this. So this briefly tells what is the difference between a first trimester pregnancy and a second trimester pregnancy. In the first trimester of pregnancy, the the fetus is very small. There is no bone ossification, the head is not big, and it needs less cervical dilatation. There is a short induction abortion interval. That is why there is less amount of pain, less duration for abortion to be completed. There are lesser complications, less bleeding, less pain, and there is no hospitalization stay for a longer duration unless it is complicated. Whereas in second trimester, this is not the scene. The fetus is grown already, the head is ossified, the thorax is ossified, the bones are already calcified, they are longer. Hence, cervical dilatation has to be greater, which needs uterine contractions which are repeated of a higher intensity, and the cervical dilatation has to be higher. So, naturally the induction abortion interval will be higher, the pain duration will be more intense and higher, the complication rate are also higher, and there is a longer duration of hospital stay. And because the placenta is already grown and it is well anchored, the chances of incomplete abortions or retained placenta are also higher. So let us know what happens for the termination of pregnancy in a scarred uterus. Scarred uterus or transmural uterine scar is a woman who has an incision on the uterus one or many times, and subsequently she becomes pregnant. And cesarean section is the most commonly performed operation on the uterus. And complications of termination of pregnancy in such a woman who already has a scar are hemorrhages, scar dehiscence, rupture of the uterus, then secondary abdominal pregnancy, which is very rare, and hence such cases need special attention. MTP is an integral part of reproductive health right of a woman. Since incidence of cesarean delivery is increasing, there are more and more women coming for termination of pregnancy willfully after they are aware that they do not need the pregnancy due to some indication. So because scarred uterus are higher, termination also higher, and nowadays there are good techniques to detect the fetal anomalies also. And because of relaxation of the MTP law, there are additional indications added where termination can go up to 24 weeks and also beyond, where the consultant is safe to perform termination. So there are various indications, we already know them. So that is a summary of the previous slide. The additional indications are if she is a survivor of sexual assault or rape or incest, if she is a minor, change of marital status or she is divorced, women with physical disabilities under Disabilities Act 2016, then if she is a mentally ill woman who cannot look after herself, has a serious mental disability, and fetal malformations which are of substantial risk and they are incompatible with life, or the child which if it is born, it is going to be seriously physically and mentally unable, and they can be seriously handicapped. And women with pregnancy in humanitarian settings like a cyclone or a famine or some disaster or a war, in such situation also the government declares it. So in such condition they can undergo termination of pregnancy, but up to 24 weeks only. So what are the challenges? The challenges which I felt are mostly the client selection and counseling. So we have to give more time, because we have told that already complications are higher, the duration of hospital stay is higher, the cost incurred is higher, complications like rupture of uterus are also higher, and the client becomes hostile or she becomes impatient once it crosses 1 day or 2 days. They don't want to, so they start pestering the consultant that she has still not aborted and they want to go home, and such situations we see. So client selection and counseling is very important, and we have to know the indication, properly assess it and document it, because many times it could be a case of sex selection where they have come for termination of pregnancy, especially in the second trimester. So you have to be very careful in selecting the client, find out what is the indication, and also find out whether fetal anomaly is a lethal anomaly. Your counseling should also tell them about, counsel them about the post-abortal contraception, because this is very important, because there is a chance of conception again, and which they don't want to continue. So the incidence and recurrence might happen. So incompleteness, hemorrhage, perforation, injuries and scar adhesions, sepsis, surgical intervention needed, and need for blood product transfusion are higher, and sometimes if it ends up with a serious complication, then ICU stay might continue. So hemorrhage during MTP is controlled when it can be controlled by various types of uterotonics, and if we have to find what is the cause of hemorrhage, is it a coagulation abnormality, is it retained products of conception, or is there an organ injury or a vascular injury, accordingly it has to be dealt. Replacement of the blood has to be done. Sometimes if a serious hemorrhage is there, MTP protocol has to be initiated. The second complication is incomplete abortion, common after 14 weeks, and here the administration of misoprostol vaginally or orally about 400 micrograms, which can be given by any route, and this can help in completion. And sepsis, unless we maintain aseptic precautions, it can lead to severe sepsis. And one big question here is the issue of a live fetus. So if there is a live fetus after a termination of pregnancy, then there is a issue of who should take care of the baby, what is the expenditure incurred, and this should be dealt before starting the procedure with a prior counseling and how to deal with the baby. And you can also offer feticide methods followed by, so there are various methods are there followed by MTP. So PCP and DT legal issues are serious issues where the doctor can be penalized. So we have to be careful whenever we are attempting a second trimester abortion, and where you cannot believe anybody or the client also. So various methods are available. By seeing the slide you can make out. Various drugs are available, single drug, multiple drug, combinations, and mechanical with medical. So various combinations are available. The commonly used, safe, easily available drug is misoprostol and mifepristone. Especially in the government setup, it is freely available. Various dosages are given. That is what this is telling. Other methods are the prostaglandin F2 alpha, extra amniotic PGE2, and mechanical methods like cervical double balloon, a bougie insertion in the form of a Foley's catheter retained for 24 hours, followed by other methods of oxytocin. So all various methods are available, they have been studied, and their efficacy is also studied. So you can adopt some method, and sometimes when one method fails, you can change over to other method. So all these studies are telling misoprostol dose if you are giving has to vary based on the duration of gestation. So up to 20 weeks, you can go up to 800 micrograms, but once it crosses that, the dose has to be reduced but it has to be repeatedly given. So many studies are there which have proved the efficacy of various drugs. The next challenge is hemorrhage. I have already talked about it. Next challenge is a resistant cervix. Many times in a scarred uterus, the cervix refuses to dilate. So whatever you give, whatever oxytocin you give, cervix will not become soft, it will not open. So even Foley's catheter insertion might be difficult. So in such conditions, cervical priming, various drugs are available, mechanical and osmotic dilators are available, catheters are available. They can be used for 24 hours. Followed by that, you can start the next dose of oxytocin drugs. So combined methods for cervical priming are slow in induction abortion interval with high success rate and low complications. Hysterectomy is chosen only when if there is a serious comorbidity, or if there is a failed other method, or if there is a complication that has occurred, or women desires that she does not want conservation. So in such conditions, it can be resorted to. The next most important complication or a challenge is a low-lying placenta and PAS, the diagnosis which you already know. But before, when she comes for a termination of pregnancy, the location of the placenta, the adherence of the placenta, the invasion of the placenta has to be confirmed. And one more advice here is, you should scrutinize their previous records. Sometimes it can be a complication of previous surgery, sometimes it could be a rupture of the uterus, sometimes it can be a weak scar where there is an extension. So always scrutinize their previous records and then make the decision regarding the method for termination of pregnancy. The management of PAS is as in any term pregnancy, we have to follow the triple P procedure where placental location has to be done much earlier, and stepwise either devascularization or uterine artery embolization have to be done, or a ureteric stenting. This all depends upon the nature of invasion and severity of the invasion. But here a multidisciplinary team approach has to be done, and readiness for a MTP protocol and also ICU facility are mandatory. So all second trimester abortions should be done in the hospital after explaining that there will be a longer interval of termination. And the incision during PAS, termination of pregnancy when you are operating, it has to be preferred on the upper segment, either vertical or transverse, or a higher lower transverse incision where you avoid the placenta. And if she is willing for conservation, then placenta, prior facility for reducing the blood flow like uterine artery ligations and embolization prior and uterine stenting, and then you can conserve the uterus, you can excise the part of the myometrium surgically and then repair it. If she is not willing for conservation without disturbing the placenta, hysterectomy has to be performed, baby has to be removed, and then you proceed with hysterectomy. Then rupture of uterus is the next complication. So in rupture of the uterus, a repair has to be done, but one thing is, you should be very suspicious. So the consultant has to be very suspicious, and periodically they have to check the uterine contour, the scar tenderness and presence of free fluid, and sudden disappearance of the pain. So unless you are cautious and unless you confirm progressive cervical dilatation, don't go on repeating oxytocin of any variety. So in such cases, a slow dilatation followed by a oxytocin or oxytocin infusion helps in success, which is safe, but it is a long procedure. So to conclude, medical and surgical abortions in second trimester appears safe in termination of pregnancy, and the risk increases as pregnancy advances. A patient-centered counseling acceptable to both parents and the consultant is a key for success. Evaluation of pregnancy scar is a must by available resources. Then mifepristone misoprostol abortion in women with prior cesarean delivery is generally safe and effective. Then lower repeated dose of uterotonic and periodic assessment of progressive cervical dilatation is a key step to avoid disruption of the scar. Sometimes there can be cervical tear, annular tear of the cervix also. That is why periodic assessment of the cervix the softening of the cervix has to be confirmed before proceeding with the continuation of oxytocic drugs. Pause after prior cesarean delivery, termination of pregnancy requires a close, collaborative, highly experienced team and thoughtful planning based on client needs. So misoprostol, mifepristone are not contraindicated in scarred pregnancy, and selection of the client and following standard GCPR are mandatory, which saves the consultant. Then choose appropriate method of termination of pregnancy and adopt as far as possible the combined methods in a scarred pregnancy. Then women should be closely monitored during and at least 48 hours after the termination of pregnancy, and continue with post-MTP counseling for contraception. And we should be always prepared, planned to address complications, and always do a hospitalized management in second trimester scarred pregnancy termination. Documentation is a must, which saves all the doctors. So maintain all the documents, consent forms, counseling done, consents, and retain the forms and photos of the fetus also if it is a fetal anomaly. Thank you.
PG at Fortis Hospital, Bangalore. At KC General Hospital. Ma'am has served as the chair-elect in ICOG 2024 and as a vice president at Foxy 2014, a leader who's... Yes. Dr. Yashita ma'am is a consultant, is a professor and HOD at Jain Medical College, Belgavi, a dynamic clinician whose dedication and insight bring immense value to this discussion. May I now introduce our experts, Dr. Lipakshi BG sir and Dr. Shiva Murthy sir on the stage. Dr. Lipakshi BG sir is a professor and head of Department of OBG at Shimoga Institute of Medical Sciences in Karnataka. And Dr. Shivamurthy HM sir is a professor and HOD in the Department of OBG and vice principal of Subhaya Institute of Medical Sciences, Shimoga. May I now welcome our panelists for this topic, Dr. Srilata ma'am, Dr. Lata V ma'am, Dr. Veena Kirti ma'am, Dr. Sushma S ma'am, Dr. Chaitanya Indrani ma'am, and Dr. Aishwarya Durge. Dr. Srilata S ma'am. Dr. Srilata S ma'am is a professor and HOD of the Department of OBG at ESIC PGIMR, ESIC Medical College and Hospital Rajaji Nagar. Dr. Lata V ma'am is a professor and HOD of the Department of OBG at Basveshwara Medical College and Hospital. And Dr. Veena Kirti ma'am is a chief consultant in Department of OBG at Kangaroo Care Hospital, Mysore. Dr. Sushma S ma'am is a consultant obstetrician at Mansa Hospital, Chikbalapura. And Dr. Chaitanya Indrani ma'am is a associate professor at MVJ Medical College, Hoskote, Bangalore. Dr. Aishwarya Durge ma'am is a consultant OBGYN, laparoscopic surgeon and infertility specialist at Oasis Fertility, Banjara Hills and Sri Manju Hospital in Hyderabad.
I remember that. Yeah. So, Yashita.
It's a different presentation. I'll connect my laptop.
Yeah, let us connect.
Greetings from Anugrah Maternity Home and Jain Medical College, Belagavi. I'm sure all of you would agree with me that beginning of a new life should be a joyous occasion for a woman and her family. But most of the times it is not so, and we end up in this stressful, chaotic situation, especially in the operation theatre when there is a case of severe PPH. Ordering blood, getting many things organized. So many workshops are taking place, with so many conferences, so many new interventions for the management of PPH, but still, hemorrhage is still the leading cause of maternal mortality, not only globally, even in India. So PPH still accounts for about 35% of the maternal deaths worldwide, and almost there is one death occurring from PPH every 2 minutes. So 2,60,000 maternal deaths in all LMIC countries, 30,000 maternal deaths per year in India, and the maternal mortality rate of India still stands at 88 per lakh live births, and in Karnataka it is 57 per lakh live births. So definitely I'm sure you all will agree with me that prevention is definitely better than cure. So how do we try to prevent? Though we know that any woman can develop PPH and she can succumb to PPH, because this is the only condition where you don't have much time. Because once woman goes into a irreversible shock, she cannot be resuscitated. So time is very important here. So ensuring hemoglobin of 11 gram prior to delivery, active management of third stage of labor. I'm sure all of us are practicing active management of third stage of labor. Use of heat stable carbetocin if available, or oxytocin, it should be kept at a temperature of 2 to 8 degrees. Many a times when we are into research where we visit many of the hospitals, especially in North India, where we find this oxytocin outside. It is kept outside. So it's literally like just giving saline. So we should ensure that if you're giving oxytocin, it needs to be stored between 2 to 8. And if heat stable carbetocin is available, definitely that's a good choice. And use of emotive bundle. Now what I'm sure everybody knows about this emotive bundle. Emotive study was a WHO study. It was mainly designed to see if introduction of early detection, the use of, it was a test for early detection, because the problem with PPH is it goes undiagnosed because most of us don't do a quantification of blood loss. So here it is early detection of blood loss and intervention with the WHO motive bundle, the PPH bundle simultaneously, not sequentially. So that was the WHO study where emotive, where E stands for early detection. So early detection needs, blood loss needs to be quantified. It's always better to quantify, and I'm proud to say that the Brasvi drape was designed at our own research unit way back in 2003 when we did the misoprostol study. So it's an under-buttock calibrated blood collecting receptacle where there are calibrations at 300, 500, yellow and red mark. Anybody can see, and it can be used even in home settings. Early detection of PPH, uterine massage, use of an oxytocin drug, and use tranexamic acid. Tranexamic acid 1 gram in 10 ml over 10 minutes. And of course, IV fluids, especially the isotonic crystalloids, and examination to find out what is the cause of PPH and tackle accordingly. Now this must be implemented as a bundle simultaneously, and they found that definitely it was helpful in reducing the incidence of PPH and also the maternal morbidity and mortality.
So as Dr. Yashita told about the PPH, so happen to acknowledge the World Health PPH Day, which was declared at Cape Town on 5th of October. So it is declared as World PPH Day. That is to bring, sensitize everybody, not only the doctors but also the public, because as we have maximum deaths due to, and the revised guidelines of WHO are released. I will share it with all the societies so everyone can go through that. And as she mentioned about oxytocin, carbetocin, and misoprostol dose for prevention is 400 to 600. That is the dose which is given. And another thing that is assessment of blood loss has to be taken seriously, and the bundle approach, which is very, very important. Okay. So the guideline which has been released, I think all of us must go through that. Now the case scenario, there is a case scenario here. She is a patient who has just delivered vaginal delivery para 2L2. She delivered at a PSC half an hour back and was brought to casualty in the early hours of morning with complaints of severe vaginal bleeding and following delivery. She was agitated, pale with cold extremities. Her pulse was 120 beats per minute, blood pressure 70/50, respiratory rate 32, and SpO2 was 92%. Her shock index was 1.7 and modified shock index was 5.2. So, Dr. Srilata, now the patient is brought in this condition. What do you think? What class of hemorrhage shock is she in?
Maybe there is a blood loss is more than 30% where the patient has gone to the tachycardia and there is an hypotension and cold extremities. So there is a blood loss is more than 30%.
So what class of hemorrhage it is? Class 3 it will be. It is class 3 where you will get the patient in this condition. So accordingly, if you know that, you can see the color coding also which is given there. Okay, so she comes almost nearing red, right? Red zone, moderate. So that means you have to act quickly. There is no way that you can wait here. Coming to the shock index, Dr. Lata, and its significance.
Shock index is heart rate divided by systolic blood pressure. If it is more than 1, it indicates severe blood loss. So better is modified shock index.
Yeah, that is the next question. So the shock index, which is for pregnancy, we will take it as 0.7 to 0.9, which is again included in WHO guideline revised. More than 1, your patient is in shock. And the revised definition, like earlier we used to say that we should wait up to 500. Now, irrespective of the hemoglobin of the patient, your alert line is 300 ml. So when you are assessing the blood loss, your alert line is 300 ml and action line is 500 ml. That means you are alert as soon as the blood loss is 300 ml.
Madam, even the trigger for PPH in emotive bundle, it's not only when there's a blood loss of more than 500 ml. It is when on clinical judgment, you are there, you have conducted delivery. When you see that uterus is atonic, patient is pouring, irrespective of what it is, you have to activate the emotive bundle. And if it is 300 ml with again clinical judgment, you have to activate the You don't have to wait for 500 as a cutoff for PPH.
Yeah. So the clinical definition is if you find that the patient is not stable, she has hypotension, tachycardia, all these things, that means your patient has developed PPH. So earlier we used to say, forget about the blood loss. Anemic patient will not even withstand the 300 ml blood loss. So clinical condition is also taken into consideration. Yeah.
Dr. Lata, can you just tell us why modified shock index is superior to shock index?
Yeah, in shock index, we take systolic blood pressure as a denominator, whereas in modified shock index, we take diastolic blood pressure with plus mean arterial pressure, which is diastolic blood pressure plus 1/3 of the pulse pressure. This is more accurate because this gives more accurate indication of cardiovascular compromise.
And it also tells us what is the amount of blood and blood products we require. So instead of waiting, when a patient comes in, if you just calculate the shock index, you'll know what you have to arrange and what you have to organize.
So this chart clearly shows that I think we should have it in our labor room because you may not be there. So if it is, I mean, they have just assessed that how much blood products were given. Mild shock also there was a need to transfuse, and when there is a severe shock, which is the shock index is more than 1.4, the mortality is very high and even multiple units are given. It must be not be only PRBC, it will be according to the protocol. Yeah. So Dr. Veena, when we are rushing IV fluids in this scenario, what precautions we need to take to prevent complications?
One is we have to make sure resuscitation methods are all in place. So make sure you have a large bore IV cannula placed and assess the amount of the blood loss. That is very important. And also vitals to be monitored. Plus the urinary output and everything has to be monitored. So before you can arrange, and if you feel she is already going into shock, then start resuscitation with the IV fluids before the blood products arrive.
Yeah, that is particularly the isotonic crystalloids.
Yeah, isocrystalloids can be started.
Yeah. So immediately we can just give 3 times the amount of blood loss. We need not worry. And the IV fluid of choice are always the isotonic crystalloids. It is better than the colloids and not hypertonic crystalloids. So isotonic crystalloids are the IV fluids of choice. It can be given 3 times the amount of blood lost, and minimizing crystalloids will give us lesser complications and better survival.
So our motto should be to arrange for blood and blood products as early as possible. We should not be giving too much because that will cause again dilution and that can lead to dilutional coagulopathy. Okay. Dr. Sushma, the next question is for you. So we rush the fluid. Should we try to bring the blood pressure to normal?
we should aim at keeping the systolic blood pressure around 80 to 90 mm of mercury, so that the exsanguination is not too much. At the same time, organ perfusion of the important organs are also looked after.
Yeah, because what a problem it can cause is it can dislodge the clot which is forming. Okay. That is too much of IV fluid. Okay. So again, you are giving too much IV fluid thinking that her blood pressure should come 100, 110. That is not required. Yeah.
So Dr. Sushma, how low should the blood pressure be kept before the harm outweighs the benefit?
Systolic of around 80 to 90 permits the accurate, the nearby what we, it prevents the exsanguination as well as maintains the organ perfusion, and also helps in clot formation. Dislodgement is also prevented, clot dislodgement.
So we should never get the blood pressure more than 100. So the systolic blood pressure should be maintained at 80 to 90 till the major bleeding has been controlled, or a MAP of, we need to maintain the mean arterial pressure between 50 to 60. Dr. Indrani, we have ordered blood as an emergency and it is still yet to arrive. Patient is continuing to bleed and we need to prevent hemodynamic collapse. So what should we do?
If you have the balloon tamponade, we can go for a compression or aortic compression or bimanual compression, or we can go do a uterine suction tamponade, or if you have an NASG as a temporary measure, we can use it.
Mic to hold. So that means as it is a refractory postpartum hemorrhage now, it has not responded to your earlier management. So you will have to use all these non-surgical methods. Once again, you can mention that is tamponade methods, like balloon. You can use
suction tamponade is there.
Also, and NSG garment. And if you still find that the patient's blood pressure is low, then you can start the noradrenaline drip. See, most of the time, we don't think about it. You may have to shift the patient sometime because, the perfusion will not be there. The kidney perfusion will not be there. Until the blood and blood products arrive, you can start a noradrenaline drip. Okay, you can. We have anesthetists. You can take their help and then start that. At least the patient blood pressure will be maintained. So many times we have seen this problem when the patients are referred from one place to another. By the time the patient is bleeding, they have applied anti-shock garment, they have started 2 IV lines and then they shift. But what is happening? On the way she bleeds and she dies by the time she reaches the facility. So we can start. Yeah.
So this patient is in severe PPH. She definitely requires a massive blood transfusion. So Dr. Indrani, can you just tell us what is this massive transfusion protocol?
Massive transfusion protocol is defined as if you are entirely replacing one volume of blood in 24 hours, or 10 units in PRBCs in 24 hours, or 50% of blood volume in 3 hours, or 4 units of PRBs in 1 hour.
Yes, absolutely correct. So can you tell us what is the optimal ratio of blood components when you're giving a massive blood transfusion?
FIGO says 1:1:1 ratio. So till if you are not having the lab facility, we can start 4 PRBCs is to 4 platelets is to 4 FFPs, and give 10 units, that is 2 pulls of cryoprecipitate. If you have the lab facility, immediately depending on the lab parameters like PT, fibrinogen, you have to supplement the components.
Yeah, but I think till the report comes, as you know that she is in class 3, you don't want her to go to class 4
Class
also,
4, yes.
because again she will go into a state of shock. So it's better you give 1:1:1, because getting cryo, practically we have to talk, and cryo we don't get 2. Usually we ask for a pool. Okay,
yes.
so that pool will be either 5 or 10, and then only it will suffice.
And one more thing, ma'am, I want to add on. Why do you give in this ratio is because to meet the physiological composition of blood. And one more thing is we should not let the patient go into the triad of acidosis, coagulopathy, and hypothermia.
I would like Dr. Shivamurthy as an expert, if you would like to add anything. Your experience, blood transfusion. We said 1:1:1 is the one. You can sit and answer. You are an expert. A mic for the experts. They are giving another.
Thank you, madam. In our practice, we practice 1:1:1 till that
fibrinogen levels are known, this should usually say bring up the patient to a manageable level, not the ultimate one. Yeah, we follow. We assess the loss of blood volume and we replace 1:1:1. So that, as Madam has clearly told, it will be a physiological composition of the blood components.
So you have the cryo facility also?
Cryo
it
facilities
is available?
are there in our hospital. In Shumaga, I think sir will agree with me. And we have got a chain of blood banks in Shumaga. Wonderful thing is to have that one. Subbaya and Shumaga Institute, and two are one Rotary, one more there. We are all interrelated, madam. We have got phone numbers of each and every one. And if it is there nexus, we are going to ask them.
No, is the cryo available?
Available, madam.
Oh, very good.
Our hospital is available.
Okay.
Yes,
yeah,
madam. That is
in
wonderful. Yes.
Medical college also
Yes,
it's
madam,
available.
it is available.
So, because all the medical colleges still don't have the facility because it is a question of storage.
Madam.
And the cold storage required for a cryo is different than the other blood products. And again, the electricity problem is there. You have to you need a generators which are working for 24/7. So because when we are doing the death review in Karnataka, we came to know all these problems. We had discussions with blood bank people also. So they said we cannot have, because our blood bank is not supported by all these methods, so we cannot keep the cryo. So these are the problems.
Separate power plan for our hospital, madam.
Yeah.
A special blood bank.
Yeah. So why I am bringing out, because this is Karnataka. We are in KSOGA, and right now we are focusing on reducing, and our health minister has also told that preventing the preventable is our motto, and the preventable deaths should come down to zero.
Yes,
okay.
yes,
and I must acknowledge Dr. Lepakshi is sitting here, and we know that now after we started this, he can tell what is happening in his hospital, because you know we have to learn from each other. Yeah.
We have got a very good blood bank backup, and also we are in coordination, working in coordination with even the other Rotary and one more. There are 2-3.
No, I want to listen to the success story of your hospital.
Madam, after the mortality meetings, we sensitized all the staff, both doctors and paramedical, so that it's a teamwork basically, and it's a coordination of doctors and the paramedical staff there, because just the doctor team cannot do everything. So, and nursing staff, they're really the backbone of the ICU.
I don't know about previous, but at least recent 3-4 months,
the mortality has come
there
down.
is not a single maternal mortality in that hospital.
For almost last.
So I think, they are really geared up now. Yes.
We had 3 PPH cases in the past, say, one year or so, and all the 3 revived, madam. No mortality at all in our hospital.
Yeah. Next. Yeah. So this is the, you can say, massive hemorrhage. We have to stop the bleeding. Whatever Dr. Indrani you mentioned, like we'll have to do all the measures to stop the bleeding. We can do aortic compression. If the patient is thin, it is easier, and all other. And you will have to replace. So administration of crystalloids, after that you give all your blood products. So you have to prevent coagulopathy, because that can lead to fibrinogen
One point,
deficit.
madam. It is the preparedness of the team before these things happen. We should expect them. And we have to be prepared, manpower and all the infrastructure. Then only the management, it gives wonderful results. Yeah. We can't do at the last moment, rushing and all. Yeah. So,
so, Dr. Aishwarya, how do you prevent coagulopathy in this scenario?
Ma'am, as we discussed, the coagulopathy can be prevented by giving blood products in a component ratio of 1:1:1. And if needed, we have to add up with cryoprecipitate pools, or if possible, a fibrinogen.
So that means you don't wait. Yes, Dr. Indrani? Yeah. So you don't wait for the reports, your coagulation profile report also will take 1 hour to come. So you know the amount of blood loss, so you have to start giving whatever is required. Yes. Yeah. Yes. Yes, we are coming to that. We are coming to that. Yeah, we'll come to that.
And so PTANR is one we usually practice in our hospital. PTANR, we send it there. Meanwhile, it comes, we are getting all these components.
Yeah.
So preventing coagulopathy is very important in the management of severe PPH to prevent mortality. So Dr. Srilata, can you tell us what are the point of care tests to detect coagulopathy?
Usually we will do that PTA, PTT and INR, and then that fibrinogen level of FDP. So those tests to be done. And then about this thromboelastography is in a test where it will tell about the platelet function as well as the fibrinolytic activities. And with this help, at least we can prevent it further damage, and we can treat.
It helps you to know that which products you have to give.
Yes, ma'am.
Yes,
We
Isran?
can actually tell which is at fault. Whether it
There's
is the
platelet
maximum clot strength, or is it the time to clot, or whether it is maximum. We need the.
No, that's why,
PPT,
madam, it is tells about the platelet function or fibrinolytic activity.
Yes.
So
And all the components which can we replace it.
Yeah, so that is how it is useful.
Here,
But you know, unless and until, except it is available with the people, those who are doing the liver transplant. Even it is available in Victoria, otherwise it's not easily available. Most of the multi-speciality hospitals, it is available where they are doing the transplants.
Clot observation test is one
Yeah,
more.
we are coming to that. I know your experience, yeah.
So the point of care test one is test that is thromboelastography and the rotational thromboelastography. So this is a simple way of assessing many parts of the coagulation. So it's a simple way of assessing many parts of the coagulation cascade from primary and secondary hemostasis to the fibrinolysis. So it assesses the overall process of blood clot formation by measuring the viscoelastic properties of a whole blood sample. So it gives a real-time picture of how a clot forms, what is its strength, and how it breaks down, helping us to guide the treatment of PPH. So here, blood sample is placed in a cup with a suspended pin, and as the clot forms between the two, the resulting tension is measured and plotted on a graph to generate a clotting profile. So this is how you get the report. So you have the R time, that is the reaction time, which tells us the time elapsed till clot initially forms. So if the R time is elevated, this implies a deficiency in the clotting factor. So practically it tells us what you have to give. So replace them with fresh frozen plasma or cryo. K time is the time elapsed till the clot reaches a fixed strength of 20 mm. So if K time is elevated, it tells us that fibrinogen is low. Replace with FFP or cryo. Angle, there's an angle which tells us the speed of fibrin accumulation. A low angle implies low fibrinogen. So replace with cryoprecipitate. And the maximum amplitude is the highest vertical amplitude. So low MA implies a qualitative or quantitative defect in the platelets. So replace with platelets. And lysis at 30 minutes, it tells us the percentage of amplitude reduction 30 minutes after that. So it measures basically the fibrinolysis. So if it is high, you treat with antifibrinolytics like tranexamic acid. And similarly, the same principle is there in rotational thromboelastometry also. So when fibrinogen levels are very low, it indicates that woman is 100% leading to massive hemorrhage and DIC. Lab estimation of fibrinogen, though we have this tag at our own KLE hospital, is available in the liver transplant. So practically, to take the sample, go, run and get the reports is going to take time. So is there a simpler way to estimate the fibrinogen levels, Dr. Lata?
Definitely, madam. This thromboelastography and all, it is not available except in Bangalore and other cities. So we will have to decide on based on PT, APTT, and these levels should be maintained less than 1.5.
Yeah. Are you, have an experience of doing the point of care test? Like we used to do the clot retraction test.
Yes,
yes, the clot observation test.
Observation test that can be done.
So this has been validated also, and there is an article in FIGO by Dr. Nalini Mishra. So you have to draw 2 ml of venous blood, transfer it into a glass tube or a vial, and hold it in a closed fist to keep it warm. After 4 minutes, tilt the tube to observe whether a clot is forming, and then every 30 seconds until the blood is clotted, and the tube can be turned upside down. And the test is stopped if a solid clot fails to form by 30 minutes. We don't have that much of time. We will have to assess her early. So if it is up to 11 minutes, it is equivalent to a fibrinogen value of more than 3 grams per liter. So we are happy about it. If it is more than 11, equivalent to fibrinogen value of 2 grams. But if it is more than 30 minutes, or if it goes beyond 11 minutes, you know that the fibrinogen level are very low, less than 1 gram, and your patient will need either cryo or fibrinogen. Yeah. But I think now most of the labs, we can get a coagulation profile done. And by the time if you get the INR and the APTT levels, we know. Okay, so that is the way you can do it. I think as a postgraduate, at least most of the seniors will agree here that we used to do that by the patient side. Okay, so what is the pregnancy specific DIC score, Dr. Veena?
Yeah, this is to detect the DIC in PPH cases. So it involves three components: the platelet count, prothrombin time, and the fibrinogen level. So all these three are required to give us a proper score to detect the DIC.
Yeah, so mainly the main thrust is on the fibrinogen level, because if the fibrinogen level is low, then your score is high. So that itself tells you that this patient has a low fibrinogen level, because the other DIC scores are not so helpful, because there they take PT, APTT, INR and all that. But here fibrinogen is taken into consideration in this score. Yeah.
So Dr. Sushma, can you just throw light on how do you replace the clotting factors in PPH?
As we started with the ratio of 1:1:1, that is packed cell RBCs and platelet concentrate and FFP. The packed cell will raise the platelet count by 8 to 10,000, and then FFP will raise 2.5 gram as compared to fibrinogen level of 20 and cryoprecipitate of 15. FFP, if used in high volumes, will lead to dilutional coagulopathy by itself. So we have to use it by reassessing the patient, seeing that the PT is maintained less than 1.5 times the normal.
So the message is that it's not that you should not give FFP. FFP will be easily available. So first you order FFP only, but your patient goes on bleeding, that you know that her fibrinogen is low, even from the point of care test. So you will have to give either cryo or FFP. But if it is between 7 to 11 minutes, she do not require FFP. There is no active bleeding, but you can keep it ready. But if there is an active bleeding, then you will have to re-evaluate. This is according to the clot observation test. If it is less than 7 minutes, you do not request. You know that the patient has lost blood, you can give her PRBC and then you can wait. But if she stops bleeding, then you don't have to give. Because that is 1000 ml blood loss we were talking about. That means that comes to class 2. Class source will get it, you get it reimbursed. Those who are from your government, I would like to tell them that don't hesitate. You order it, you get it, you save the patient. Under JSSK, you can get it reimbursed. Okay, even if you are getting the blood from the private blood bank, next day you can tell your administrators and higher ups that we have used it. They cannot say no to you. Our main motto is to save the mother. At any cost, we should see to it that we are giving her proper treatment. Relatives will not be available. You may have to use your staff, or you have to have a MOU with private blood banks, so that your ambulance, one attender can go and bring the blood. Even in private also, all of us have to gear up, all the more you will have less hands there, you may not have. So as Dr. Shivamurthy mentioned, that you should have number of all the blood banks. It's very true. Okay, this blood bank, it's not available, you have to contact other. The preparedness is very, very important, which also he mentioned. Yeah.
So we know that fibrinogen is one of the important to manage severe PPH. So can you tell us if human fibrinogen is available and how it is used?
Yes, madam, human fibrinogen is available. It comes in an injection form of 1 gram injection, and cost is approximately around 12 to 14,000 rupees.
So it's a vial.
Yeah,
you have to dilute and put it, that powder form, in the 50 ml. So
Yes.
it is 50 ml. Suppose you have calculated it, it is 60 milligram per kg, it is given as 70 per kg body weight. At least minimum, if you have given cryo and FFP, you will have to give 2. So you don't have to take another 50 ml. You can add this to that 50 ml only, and you are giving only 50 ml solution.
grams.
So the another gram also can be added to that. There is no risk of reactions or trolley or anything as you are giving this. Okay.
So Dr. Srilata, can you tell us what is the role of tranexamic acid?
See, tranexamic acid is an antifibrinolytic active. It has got an antifibrinolytic activity. So with that fibrinolytic, it is acting especially on the small capillary oozes, and it will help to control the bleeding. So usually it will give as one of the treatment nowadays is in the WHO. According to that, it is a treatment for PPH. It has to be given as in 1 gram in almost 30 minutes. Second dose, it can be repeated. One study says it's 1 hour, and other people will say that it's after half an hour. So it has got a role.
Whenever we give tranexamic acid, it needs to be given 1 gram in 10 ml over 10 minutes. And if you want to repeat, it has to be repeated after 30 minutes.
Madam, EMO2 trial given robust evidence that we can repeat it if the bleeding stops and restarts within 24 hours as well. We can
within 30 minutes you can.
Yeah, but you can repeat it again.
Repeat it.
Yeah, you can repeat it again.
So if at all it has to be given within 3 hours of delivery, otherwise it has no role. So it has to be given 1 gram in 100 ml NS over 10 minutes. Rapid infusion can cause hypotension. So many times anesthetists are very reluctant to give this on table, especially during C-section. So if bleeding continues, as we said, a second dose of 1 gram can be given. So we can see that the 70% improvement in survival rates when you give tranexamic acid immediately. Every 15 minutes delay, there is a 10% decrease in the survival benefit, and after 3 hours, it has no benefit. I think currently there are other modalities also. Dr. Lata, can you tell us what is the role of this recombinant activated factor 7A in PPH management?
So the role of recombinant activated factor 7A is as an adjuvant. It doesn't replace uterotonic drugs or hemostatic drugs, but it can, when there is continued hemorrhage, in spite of uterotonic drugs and hemostatic drugs, you can consider the recombinant factor.
But what are the prerequisites, suppose if you want
to
give?
It has got certain prerequisites, because temperature should be more than 34 degrees and pH of the blood should be more than 7.2. Platelets should be more than 50,000 and the
fibrinogen
level should be more than 3 grams per cent.
That means you have already given the transfusions, and now you can cut down, okay, and it can also control the bleeding. Just to share with you, there is a Foxy Focus which we have come out for the management of severe PPH, where we have mentioned about factor 7, because there are two states, Rajasthan and Bihar, it is available in government hospitals. And there are totally, till today, there are 34 cases of PPH where they have used factor 7. Most of the cases were of pass. Okay. The benefit is, like when they are shifting the patient, they have given one dose and then they have shifted the patient. At least till then the patient was not bleeding and she reached the facility, and they were able to save all these patients. It is available with the government in these two states, and they are able to save. I know that there is still not a recommendation as such. Even WHO does not still recommend. In WHO recommendations there is revised also, there is fibrinogen and cryo, but factor 7 we will still need more robust. I must tell you that there was a professor from Koppal here, I think he left. I think they have the experience of using in 2 cases. It was used in Koppal and they could save the patients. I remember during the review I heard from them. So I know it is again very expensive. It will cost 45,000. Most of the time it is not available, but there are cases where they have used it. Yes.
Just for the benefit of the audience, the recommended dose range for the treatment is 60 to 90 milligram per kg body weight administered by IV bolus injection. And you expect the result to be seen as early as 10 minutes, and a second dose can be administered based on the clinical response of the patient. So it is a quick reconstitution. It is a low infusion volume. That is another advantage, where you can give it rapidly, and it is mainly to be given when the uterotonics fail and not when the patient is already in DIC. I think this question already she has answered. So there are various studies which have shown that. Okay. So Dr. Veena, can you tell us what is the role of POCUS in PPH? Point of care
ultrasound. This is a good tool to assess the amount of blood loss, and also to rule out any retained products within the uterine cavity or in the lower genital tract. And it also gives us we can measure the inferior vena cava measurement to know the amount of the blood loss patient has had. So it is more a precise way of assessing the amount of blood loss.
Yeah, I think IVC diameter and its collapsibility. Actually, the people, those who are in ICU are trained about that. So when you are doing a focus, you will have to see everything. So first you see the pump, that is heart. So suppose if your patient is in irreversible shock, you will see that the left ventricle is really contracted. Okay, if it is dilated, it can lead to pulmonary edema. So first you look at the pump, then you look at the pipes. Pipes is vessels. Okay, for PPH you will have to look at the inferior vena cava, and third is tank, that is the cavities. You may have a case of ectopic pregnancy or even a HELP syndrome where we have a bleeding from the liver, hematoma and all those things. So when we are doing focus, we will have to look. This picture is showing B lines, that as diagnostic for pulmonary edema, but in PPH you will have to look at the collapsibility of the IVC.
Dr. Aishwarya, can you tell us what are the other minimally invasive recent advanced techniques in controlling hemorrhage?
Madam, usually when the medical managements are not working and we need to buy more time for the patient, these minimal invasive techniques like uterine balloon tamponade can be used. Those can be the routine condom catheters which are prepared there, or the commercially available kits can also be used.
I know that most of the people are using suction cannula. Can I know? Yeah, Dr. Virendra is there. I think balloon tamponade is being used more effectively, as well as Dr. Jayaprakash. Yes, balloon tamponade. Yes, and yes, yeah, I am coming to that. Yeah, so we have different types of cannulas also. So that can be used either SR or Panikkar cannula. I know the JADA system is there. I have attended, but it is very expensive, and I think we have our indigenous sufficient equipments which can be used, the vacuum devices, and maybe we will get a hemostatic pack. This is a hemostatic pack where the uterus can be packed. Those days we used to pack with 6 meter long gauze or something, but this is hemostatic where we can...
Currently intrauterine packing is not recommended. There is no evidence, and it should not be done.
Yeah. So that is the action. As it is hemostatic, it also needs removal. And now coming to our indigenous Dr. Ramlingappa, who has invented those clamps which can be applied vaginally to clamp the uterine arteries. Okay, and I must tell you that I went through an article of ACOG, and I saw the reference where Dr. Ramlingappa's and Dr. Paili's name was mentioned in that article, and really felt proud about it. And even Dr. Paili also has the vagina. I don't have the clamp, but I had a patient of acute inversion of uterus where I had to replace. I put the balloon, but she was bleeding, so I applied with whatever sponge holding forceps we had. We don't have to worry about the ureter. Ureter is not placed in the endopelvic fascia. Only thing is, if you want to apply it on the left side, you pull the cervix to right side. So the uterus falls away. So you take it to opposite side and then you put the clamp. You are away from the uterus and ureters, and you can keep it there. So these are the paracervical clamps, and I feel that you should make it available to us, Dr. Ramlingappa. Okay. So, and this is the aortic compression, again the aortic clamp which Dr. Paili has introduced. I think again he has produced a case where 39 cases of PAS where not a single transfusion was given. Okay, so I know we are very hesitant to use, but in Bangalore, Vani Vilas Hospital, they are using it, and they find it very helpful. You are also using it, because I know very well that Hubli also you get so many cases. Yeah, and all other depends on the availability. Yes, cases of PAS, when we are handling, we have the facility of interventional radiologists. So we do try to prophylactically put the catheters and the balloon so that we can control the bleeding. And surgical techniques, I think all of us are aware about. There are different methods, but the main motto is to control the bleeding, whatever you are using. Either you are using Heymans or your B-Lynch or cervicoischemic, uterine artery ligation, internal iliac artery ligation, and all that. Yes.
I think so. The main aim would be at the end to prevent this triad of acidosis, coagulopathy, and hypothermia as a result of massive blood loss. So actually, we need to have more medical management than just rushing in for emergency peripartum hysterectomy and massive blood transfusion. So these are the protocols.
Yeah, this we had released in LDI, that is Leadership Development Initiative of FOXI with FIGO, And we have come out, I have shared with the panel, and they can share it with that, and I will see that how I can share with all the societies. So that is nothing but because vaginal delivery, your protocol is different. For cesarean, your protocol is different. Where cesarean, you can fast, you can just do the compression sutures and all other surgical methods, and vaginal. So all the more everything gets delayed in vaginal delivery. Your decision making is important, and so the correction of hypovolemia is very important in vaginal delivery. There you have an anesthetist at the head end. Here you don't have hands also, so we have to be more prompt, and readiness is the key.
So finally, the take-home message would be ensure HB of 11 gram% by 28 weeks of pregnancy. Practice active management of third stage of labor for all laboring women. Activate the E-motive bundle. Point of care coagulation tests in PPH. Transfusion of FFP cryo and platelets along with PRBCs to prevent coagulopathy. Use of fibrinogen concentrate and recombinant factor 7A when uterotonic fails in management of PPH.
Thank you.
Just on the lighter note, so the message is counseling and communication is very, very important. Not only in severe PPH, in any case for that matter, counseling and communication is very, very important. Thank you.
The PPH bundle has two aspects, clinical and non-clinical.
Suddenly she had a syncopal attack, so the duty doctor was called. Then FHS had disappeared, and patient was pale, and there was free fluid. The abdomen was tense. So suspecting, I suspected liver rupture, probably hematoma must have ruptured. So immediately she was shifted for laparotomy. Uterus, the fetus, dead baby was removed. There was no abruption. Uterus was absolutely contracted and fine. But later when we found almost 4 liters of blood was there in the peritoneal cavity. So when after suction we tried to trace the area, we found that the splenic vein had dissected, which caused such a huge hemoperitoneum. So a splenectomy was done. We even presented that in CPC. The vein was massively dilated and that had ruptured. So like we should not think of only obstetric causes in such condition. This woman was given 21 units of blood replacement. She walked out of the hospital on the 22nd day.
I had the same experience, thinking it is an ectopic I opened. But there was a history of trauma by husband. She had a splenic rupture. Surgeon was on call, so we called the surgeon immediately and did a splenectomy. Another case, again opened as an ectopic, that was a vessel on the ascending colon. Because she was again pushed, wow, we heard today Dr. Shantakumari's talk. She was pushed, she fell on the corner of the dining table. And she had the rupture of that vessel and again had hemoperitoneum. So as you said, hemoperitoneum requires, I think, okay, as you said, there was no bleeding from liver. But the another modality is you have to pack. Yeah. You can't control that bleeding. You have to go on replacing the blood and blood products and pack the abdomen. That pack can be removed afterwards. So you have to just
pack. Here it required because a vessel tear was there. Yeah. So we could not do that.
So the packing is also the another. Now the cell salvage we don't have. The packing is also there. All those modalities are available abroad. But packing still we can do because so many times we'll get a cases of help where we can't do anything. So packing of the abdominal cavity
that works in hematoma, liver hematoma. This was a spontaneous rupture of the splenic vein because of the aneurysm.
Yeah, thank you. I thank all the panelists, okay? And I think it was a good exercise for all of you. They kept on asking the questions. They got the questions just 36 hours before. So I think they must have been really guessed.
Vasudeva Murthy, ma'am, Dr. Nagesh ji, to kindly take your seats on the dais. Dr. Madhu K.N. sir is a consultant of the situations. Dr. Jayaprakash B. Patil sir is a senior consultant at Betadur Advanced 3D Laparoscopic Center. Over to you, sir.
Thank you. Those will speak for me as it is a video masterclass. When I wanted to prepare this talk for difficult situations, I asked my OT assistant, get me difficult cases where we had difficulty to operate. So he gave me some 15 videos, out of which 10 were endometriosis. So he thought that was the real difficulty. So then I had to explain him. And deliberately, I also discussed with Virendra sir that I left out the endometriosis from my talk, because again it will become a masterclass on endometriosis rather than difficult. So non-endometriosis, common difficulties we face as a common gynecologist who is dealing with the total laparoscopy hysterectomy, I have tried to cover. So most of the time it is the lack of anticipation, improper workup and overconfidence which leads us to trouble. I used to have this problem as a freelancer because you don't have a control what kind of case is posted. They will only tell, sir, bulky uterus, you go and see it is 26 weeks. So these are the problems, because this will not happen if you have done a PV yourself. And I have had situations where it was see a cervix, they have not even bothered to do PV. So these are all the problems, okay. And once upon a time, Ashish Kubde sir told me, the one who would be able to operate cases with prior surgeries, any surgeries, whether it's a previous LSCS or whatever, and endometriosis, would actually do the best possible practice. So nowadays, obesity is more of a common thing rather than a rule. So those days, obese patient, 100 kgs means we used to be like little ready. But now, every week I have at least 1 or 2 patients who are above 100 for either cesarean or for lap surgery or for endometriosis. So before we actually enter the abdomen, we need to plan our entry. Okay, what is my capability as a surgeon? What is the case I am dealing with? Do I really need help? So there is no shame in taking the help. If you think this is beyond my capabilities, please do take help and go ahead. This is a old video. See, there is almost like a postmortem incision from top to bottom. So we have to plan whether you want to go to. I usually do direct trocar entry. Whether you want to go with Palmer's or Jain Point, or whether you want to go with Hassan's open method. Cochrane does very clearly say that the incidence of bowel injury has nothing to do with the way you enter. You can still injure the bowel even if you do open method. So absolutely it is your. Second thing, I could not find a video where after entering we put an we put an accessory port, put the camera from the other port and see whether we have entered safely or not. It is possible that we have gone through and through the bowel, not realizing that you have injured, and you complete the surgery, come out and patient develops problem after 3 days. This is another old video by my friend Anil Magdum. See, they have entered, they know that their entry is safe, but what is happening here is, you have bowel adherent to anterior abdominal wall in between the camera and the specimen. Okay, so there are 2 ways of approaching this. Either you do proper adhesive lysis with an accepted chance of bowel injury, which you should be able to suture, or completely avoid and finish your job, which is hysterectomy, and get out, because she doesn't have any bowel symptoms. So it depends on the scenario. Nowadays, bowel, what I have found over these 15 years is, any surgery which was done as a pediatric, in the pediatric age group, for perforation or appendix or whatever, they cause terrible adhesions. So we need to be really, really careful going with our entry. Okay. So this case was completed by Anil without actually touching the bowel. So this can also be one strategy. Not necessarily that we show our heroism and try to do complete adhesive lysis and do it. So as you can see, just he is trying to avoid and go and operate. See, he is making windows between the loops of bowel and finish the job. This is my own case, not very uncommon also. You have complete, you don't see uterus at all. Whole bowel is sitting in the pelvis, very bad adhesions, probably PID. So don't get stressed out seeing at such adhesions. Start from the easiest point. Go slowly, go by millimeter, and it is the surgery is the play between traction and counter traction. So give traction, give small cuts, and the gas will do the rest of the dissection, and you will be able to decide where you should cut next. So go slow. Once you completely take the bowel out of the pelvis, then you can proceed with the hysterectomy. This full video is there in YouTube. Those who are interested can go to my channel and see this full video. Sorry? Yes, ma'am. Yeah. See, if it is a bowel adhesions, if you don't expect a very stubborn adhesions, it is always better to use a cold scissor, because you don't expect a bleeding in that fibrotic tissue. So, and in case you cut the bowel also, it is easier to suture if it is a cold scissor, because you are not put the thermal energy which can destroy more than what you actually see. Now see, it's a large uterus with a previous cesarean. Now the bladder is doubled up. It is a doubled up bladder. If we think that the bladder is way down and start dissecting in between, you are in trouble. So always go layer by layer, go millimeter by millimeter, whether you use harmonic, whether you use bipolar, whether you use scissors, whatever. It's all about layer by layer dissection. Have patience. Once you are in plane, then the dissection will be done on its own. It goes like a magic. If you can see the bladder, so slowly putting down, you can see another layer of fat there. I always have to go below the fat. So fat belongs to the rectum and fat belongs to the bladder also. So Mullerian tissues, that is the uterus, cervix, does not contain fat. Okay. So once you start doing it, another lesson from this case is how we manipulate the uterus to get the best traction. So whether you are comfortable with the uterine manipulators, whether you are comfortable with the myoma screws, it's up to you. We are trained by Dr. Hafiz Rahman and Anil later, so we are more comfortable with the myoma screw. It gives the best possible traction. But having said that, it is absolutely, you are this thing, there are people whom I know, they don't use any manipulator, they use the other assistant's hand as a traction and they do active surgery. Okay. These big uteruses have a lot of bleeding from the venous side, so the specimen side. So it's a venous bleeding. You don't have to get really worked up and then start cauterizing everywhere. You see, once I have done this, I have gone to the lower part of the uterus to give the good traction. The rule of thumb is, you put the myoma screw where you are operating, the area where you are operating. So it is simple. So again, I am coming back to the bladder. Bladder was totally drawn up, pulled up. Give a good traction and counter traction and keep doing the dissection. So this is the trick to deal with the large uteri. Another word of wisdom by my mentor Ashish sir, he said is, uterus को छोटा करना बहुत आसान है जेपी, पोर्ट ऊपर डाल ले वो छोटा दिखेगा. You go up, the uterus will start looking smaller. So you will be able to approach this thing. If you put the same port positions and start working up, you are at the face of the fibroid and you will not be able to this thing. One last, I'll just freeze a frame for a minute and then see. There is a bleeding from the vault. Never ever go and put your bipolar there. I have burnt my finger, had a ureteric injury. Always ask your assistant to pull it to the other side, then only do minimum bipolar. Very important. If you think you are close to ureter, it is okay to take suture. Just suture and forget it. Okay. This is the so-called the lateral window. Just remember, you identify the uterine vessels. Go anterior to the uterine vessels. You are in the virgin space. Simple. God has been very kind to us. So, though there are adhesions everywhere, there are always a free space to find and go and negotiate our surgery. So, once you are in that space, you see that yellow fat, be happy. You go below that yellow fat, and as you can see very nicely, now I am confident, just start cutting it. Okay. These type of cases are not common. Actually, they are more common. You see the whole uterus is completely adherent to the anterior abdominal wall. Now, what I usually do is, first I detach the adnexa. So once the adnexal detachment gives me way to both anterior and posterior broad ligaments. So you open the posterior, finish off, go anteriorly, find the way like you do for lateral window technique, and once you are done, you know that you are nowhere close to the bladder. Just keep cutting the fibrous tissue. You will be done with this. Whether it is 1 cesarean, 2 cesarean, 3 cesarean, 4 cesarean, doesn't matter, as long as you follow the strict principles of the surgery. You enter the space. That is very, very important. Nowadays, the most important investment you would ever make is in the imaging system. We cannot say that, okay, I will do only diagnostic scopies and then later I will buy bigger one. No, you don't buy a car, delay your purchase of whatever car or whatever jewelry or whatever. Buy a good imaging system. Invest in the technology. That's all. Now this is a cervical fibroid. I operated this case in JNMC some 2-3 years ago. Bella sir had invited me. It is a, many people get nightmares about cervical fibroid. Actually, it is the easiest thing to do. First, visualize the, how much time I have? 2 minutes, okay, sorry. So, first visualize the ureter, okay. You don't have to dissect it. You have to have a map, where is the ureter. So, start operating like any other case. You stay within your boundaries, that is the broad ligaments, and start detaching the pedicles as you would do with any case, because you know where the ureter is, and simply you proceed. Okay, I'll just show you. Push the bladder down. This whole video is there in YouTube again. See there, this is where my ureter is there. I know. So that is the uterine vessel. So I am way away from my ureter. So I can completely block it and doing it like any other case. And in the end, what I do, sorry, I am unable to fast forward. Just how to do colpotomy. We put a sponge and a stick in the lateral fornix, elevate and just open the vagina, and your hysterectomy is done. Actually, in JNMC, I told Metgood sir, if you want, I can show this as a vaginal surgery because it is easier to do vaginal surgery than this thing. Illa ninaga lap madak karadini, nin lap madantandi hedru. So I had shown this case. So this is another unexpected thing. This lady had some 2 or 3 babies, but it was not diagnosed. It was operated somewhere else. It's a bicornate uterus with a non-communicating horn. She had lived through that. She had babies also. Then when I go inside, I see that there is one non-communicating and there is a communicating, and there is only single cervix. So we removed en masse. Okay. Okay, how to deal with the bleeding? As I said, large uteruses will have lot of venous bleeding. So don't get worked up. Don't get tensed. So there is a bleeding, okay, take your time, do the suction, identify where the bleeding is coming from. For venous bleeding, go towards the specimen. If you keep buzzing on the pedicle, you will never achieve this thing. First, cut off the arterial supply. Once you cut off the arterial supply, go towards the specimen, do the proper buzzing, and it will stop. Okay. So this is with my Spanish friends. Only 1 minute, sir. The extreme right one is Santiago Domingo. He is the one who taught me advanced surgeries. He always says, JP, opening abdomen is not a sin. So conversion is a courage. You should be able to explain the patient that, listen, I had to open you to save you from extensive bleeding or whatever. Unfortunately, I could not get a video where we opened, but then any difficult situations, if you think opening will save our life, please go ahead and do it very fast. Okay. Most of the videos are available in my YouTube channel. Just type at JP Betadur, you will get my channel and you can watch. I have made playlists for the ease of this thing, so you can watch all those videos. So thank you very much.
Thank you, sir, for the nice cases, not nice, for showing the difficult cases and the practical tips. The dictum is the good clinical examination, triaging and planning, teaming. Teaming up is important, as you said. Don't be heroic. So always take help if at all needed. Thank you so much, sir.
Our last speaker for the day is Dr. Gayatri Karthik ma'am. Ma'am is a professor and head of Department of OBG at Manipal Hospital, Bangalore. She is also the co-founder of Mother and Child Clinic at Indira Nagar, Bangalore. Ma'am could not join us in person, unfortunately, but we are delighted that she will be joining us virtually. Please join me in welcoming her.
Good evening, everybody. Am I audible?
Yes, ma'am. Yes, ma'am.
Great. First of all, thank you so much. I would like to thank the Scientific Committee of KSOGA for having me. Unfortunately, I could not make it to the event. And a special thanks to Dr. Saraswati for having made this last-minute arrangement for me to speak virtually. And a very happy Rajyotsava Day to all of you. I would like to bring greetings from Manipal Hospital, where I work. And my topic for today is to talk on robotic myomectomy. Fibroids, as we know, come in all shapes and sizes. And the treatment, surgical management includes myomectomy and a hysterectomy. So myomectomies can be hysteroscopic, laparoscopic, laparotomic, robotic assisted, and so are the hysterectomies. So the question is, why robotic? Robotic surgery has many advantages. It is a cutting-edge technology. It's a 3D high-definition camera that we use with endoristed instruments which give us 7 ranges of movement. There is a definite higher resolution we see and a greater magnification. There is automatic tremor filtration which enables us to do fine work. Maybe not for myomectomy, but in patients where we need to do a tuboplasty or something delicate, a large ovarian tumor where we need to retain the ovarian cortex and get the tumor. Yes, the tremor filtration helps a hell of a lot. 1,300 safety checks, and it's ideal for surgery in the obese. What are the benefits to the patients? There is less pain, lesser pain than laparoscopy. I will tell you as we go along why the pain is lesser than even laparoscopic surgery. The quality of surgery is better because you see better, the instrumentation is better, magnification is better, and so you operate better, lesser blood loss, faster recovery time, a shorter hospital stay, and fewer side effects. It's a boon for bariatric size patients. Mind you, this patient is not 65 kilos. Her BMI was 65. And trust me, we were worried and we kept her for an extra day. The day we operated, we kept her in the ICU, which we usually do not do, but we were concerned. And she had absolutely no problems. And the following day, she went home. So robotics is basically faster recovery, outstanding precision, lesser blood loss, wonderful for obese, and lesser hospital stay and cosmetically superior in a satisfied patient. So what are the things that we do in myomectomy? Like in any surgery, be it open or laparoscopic, we need to do a proper case selection. Make sure the imaging is right so that we know exactly what we are doing. Planning should be good. Blood loss management, we have to plan beforehand. During surgery, count the fibroids, suturing, retrieval, post-operative care, and selection. So what is so great about patient selection? Myomectomy is usually offered to patients who still retain a desire to reproduce. However, these days we are seeing a longer lifespan, patients having fibroids after they've completed their family, but perimenopausal or premenopausal. Occasionally I have patients who passed menopause, but they have large fibroids. And they would still like to retain the uterus. So in such patients, we could consider, but after a lot of discussion, age, of course, doesn't matter. Parity comes into being only if you are deciding about retaining myomectomy versus a hysterectomy. In a patient with a myomectomy, before performing surgery on myomas, where at the request of, say, the fertility reproductive facility surgeons, many times you need to check whether the spouse's fertility is good. On occasion, I've had patients undergo surgery for asymptomatic fibroids elsewhere while the husband is azoospermic. So we need to evaluate properly and exclude endometrial pathology and then decide on surgery. Imaging is of utmost importance because that also helps us decide route of surgery, need for surgery, and the type of surgery we would like to do. You have excellent ultrasounds. I'm fortunate to be working with somebody who gives me reports like this, who actually draws and tells me where each fibroid is located, but not everybody has this service available to them. You can do an MRI and note where each fibroid is so that you don't miss a fibroid. In a fibroid like this, where it is intramural or submucosal, more intramural, we do not need to remove such a fibroid, but in a submucosal fibroid, which is interfering with fertility, and the assisted reproductive facility doctors insist on these fibroids being removed, you need to know where exactly to make the incision. You need the correct length, depth, and orientation. Now, how do we do that without compromising the strength of the uterus? We could do intra-operative ultrasound. Here, what we do is there is a probe available which can go in through a port, and we can actually scan during surgery. And we know exactly to locate where the fibroid is so that you can mark where your incision should be. You can also have a rough idea what the depth is going to be. What is the advantage in doing this? Because in robotic surgery, you can actually see the ultrasound picture while you're operating. So you know exactly where this fibroid is located and to reach it. You can also have 3D rendered MRI images which help you locate all the fibroids and help decide how to go about operating and how to remove all the fibroids. This is more important for submucosal, intramural, and multiple fibroids when you have very many fibroids. Planning myomectomy. Planning any myomectomy is like orchestrating a symphony. You need smooth execution. Special location fibroids like broad ligament or cervical fibroids need to be planned before. Consent should be taken. Important to take consent explaining the risks of unusually located fibroids, an emergency hysterectomy if required, morcellation in bag or open. You have to put it in a bag and get it out. That has to be explained to the patient. I think all of us are aware of parasitic fibroids. Economy and time and cost, so that we are not wondering what fibroid to address next. Once it is planned, especially when there are multiple fibroids, you know what sequence to take, which fibroids to take first, so that nothing is missed. In a case of multiple large fibroids, this is a patient who was almost 34-week size fibroid, and she was insisting that she wanted only minimally invasive and robotic. So we briefed her about what we are going to do. The advantage robotics provided is the availability of camera hopping. So what is camera hopping? Now in the X and XI robots, all our ports are of the same size. They are 8 millimeter. So in the event you're not able to visualize a particular place, I will show it with okay, let me go. I will explain this subsequently to you as to how camera hopping helps us. Then we also need to make sure that there is enough blood transfusion available and keep the family periodically abreast of the condition of the patient. So what are the advantages? There is less blood loss and camera hopping and intraoperative ultrasound available. Of course, the precision in multi-layer suturing and shorter learning curve, lesser complications and much lesser pain is already well known. Port placements, these are my usual port placements. The other alternative that we can do is put it all along a transverse line above the umbilicus. Port placement, pneumoperitoneum, entry with an optical trocar, all these are safety measures that we use. The reason why robotic surgery is even less painful than laparoscopic is this little remote center that you see on the cannula. This black band is where the abdominal wall is and behaves as a fulcrum about which the trocar, the cannula moves. So what happens is that there is hardly any movement of the abdominal wall, and so the pain is lesser. How do you manage blood loss? Like in any other laparoscopic or open surgery, there are preoperative drugs available. You can use GnRH agonists to decrease blood loss and shrink the fibroids. Immediate pre-op misoprostol may be used. Intraoperatively, you can use vasopressin, tranexamic acid, and a temporary or permanent ligation of the uterine artery as one likes. Supportive treatment in the form of blood and intravenous fluids will be handled by the anesthetist, and most importantly, execution of swift surgery. Techniques used for ligation are many. You also have, you can use Pissart's needle or any needle where you can see. The disadvantage of steel needles are sometimes you may not be able to see when you are withdrawing blood into the cannula because it is a long needle, and you may land up actually going intravascular without realizing it. I was talking about camera hopping. This is the same patient whose picture I had shown the ultrasound report. The large fibroid on the fundus was obscuring the vision for the lower fibroids. The connection, the attachment to the uterine body was not very visible from the top. So this is what we did. We repositioned the camera. So this is to show you the picture from the top. So this particular area where the attachment was not clearly visible. It was visible, but we couldn't reach it. So what I did was to reposition the camera to a side, see the attachment clearly, and go ahead to remove that large fibroid. Once the large one was removed, obviously, it became much easier. Very important in any endoscopic surgery is to treasure the fibroids. Don't lose them. Sometimes your procedure may finish in half an hour and you may waste 2 hours trying to locate one tiny fibroid that you remove. You don't want it becoming parasitic fibroids. So either keep threading them in place, or you can, if you put in a bag beforehand, you can keep putting it into the bag and close it with a clip so that it doesn't fall out. So this was the large fibroid that we eventually, multiple fibroids that we removed. What is the greatest advantage of robotic myomectomy over laparoscopic is the suturing. The suturing in any fibroid should be precise, fast, and the beauty is in the performance of it. I always think myomectomy is one of my favorite surgeries because it is a blend of um, it's a blend of art and science. It's beautiful to remove the fibroids and make sure that you put it back in a good shape. So as usual, by traction, counter traction, we remove it. And then suturing can be multi-layered. We use barb sutures, and this kind of multi-layer suturing does not usually happen in laparoscopy. It's not that it is not possible to do, but we very often see laparoscopic surgeons just taking large chunks and closing it in one, max 2 layers. But here you can do a multi-layered closure, which gives the patient or the uterus enough strength to go through and to go through a pregnancy very soon. In fact, one of my earliest cases, the very next month she got pregnant. She calls me despite my having told her to wait for 3 months. And what she did was offered that, okay, I undergo a termination. And I said, no, the whole procedure was done for you to conceive, so please go ahead. And but I said, you watch whether you can deliver. It's just been a month. And this is the final effect we get. This is what I say art was and science. Retrieval. It's fine, all fine to do a fibroid, and then we need to retrieve it safely. Primarily do no harm is the basic tenet of medicine. So open morcellation has been given up. It leads to parasitic fibroids, leiomyosarcoma, and the meticulous search for fragments also takes a long time, anesthesia time, etc. So put it in a bag, in-bag morcellation, or make a small, slightly larger incision, do an excite technique, and remove it from the bag. Alternatively, you could, if it's a one or a small fibroid, you could go through the pouch of Douglas and retrieve it. Post-operative period, post-myomectomy, some of them, the small fibroids, can go home the same day. We start orally 6 hours after surgery. When I say orally, I mean normal diet. I don't mean liquids followed by next day, etc. Most patients, 98% of patients will go the next day at the most. We very rarely transfuse. Conception. Now, 3 months, 6 months is just something we say. I don't think there has been any scientific reason for defining the number of time or the number of months that a patient needs to wait. Like I said, the patient I was referring to conceived the very next month, but that's not what we would recommend. Healing time is at least 6 weeks, so we would like them to wait for at least 3 months. Lesser pain, like I said, was because of this. If you see the degree of movement of the abdominal wall with robotic and laparoscopic, that itself tells you, especially with the large fibroids, there is so much of movement that it does cause abdominal pain. Conception post-myomectomy is always a cause for concern if the suturing has not been good. This was a patient who underwent a laparoscopic myomectomy elsewhere, following which she did become pregnant, and at around 36 weeks she went back to her obstetrician with pain. Unfortunately, they examined and sent her back home saying all is well, and the following day she went with severe pain and it had ruptured. So she came back to me after that and wanted to conceive again, obviously. Now she has 3 scars: the myomectomy, the repeat suturing, and the cesarean scar. So I warned her that we may not be able to reach term, and at any point of time she has to return immediately. She did become pregnant, and she came back at around 25 weeks. And there was a hemoperitoneum, about 1.5 liters, and the scar had given way, the previous laparotomy scar. The section scar was good. We delivered the baby, 860 grams, and we needed to just transfuse 1 bottle of blood. We repaired the scar again. This time I excised and did a double layer suturing. I hope she doesn't conceive again. And the good news is that, yeah, the baby is doing perfectly well. So there are enough and more reviews. Systematic review of 2,150 records by Murad et al. In 2024, comprising 24 studies, showed without any doubt that robotic surgery enhanced exposure and dexterity, reduced blood loss, and improved incomes. Sheng et al. With 45,000 patients showed that robotic-assisted myomectomy is superior to laparoscopic myomectomy in terms of surgical trauma and post-op recovery. Our own Dr. Ruma Sinha has also demonstrated that robotic surgery is comparatively safe, lesser blood loss, shorter hospital stay, and fewer complications. So in all, robotic surgery affords less blood loss, benefits to the patients in terms of less pain, benefits to the surgeon in terms of camera hopping, intraoperative ultrasound, precision and multi-layer suturing. The learning curve is definitely shorter in robotic than in laparoscopic, but one cannot forget laparoscopic principles and training, lesser complications. So robotic surgery is here to stay. It does definitely give an edge over laparoscopic, but that does not mean laparoscopy is bad. And let me also tell you, I'm both a laparoscopic surgeon and a robotic surgeon, and I certainly think robotics does offer a benefit to patients. Anything else? And thank you once again for having me, especially virtually, and any questions, please feel free to contact me.
Thank you, Dr. Gayatri Karthik. It was an excellent presentation. It's, I think,
Thank
already
you, sir.
late. I think we'll conclude the session. I would like to thank KSOGA and Tumkur Society for giving us this opportunity. Thank you.
Thank you so much, KSOGA and Tumkur Society.
Thank you so much, ma'am. I request the volunteer panelists to answer the questions in a clinician's perspective, because eventually it is the clinician who has to make the decision on or help the couple to make a decision about that particular pregnancy. So starting this session, I would like Dr. Geeta to answer this question. What is prenatal diagnosis?
Prenatal diagnosis is a science that identifies structural abnormality and also genetic diseases in the fetus. It includes ultrasound screening, aneuploidy screening test, and carrier screening for genetic disorders, and also diagnostic tests that are done on the amniotic fluid and also the chorionic villus.
Yes. So we will be, when you talk about prenatal diagnosis, we are talking about even the preconceptional diagnosis, and once the pregnancy has, the woman has become pregnant, you want to see the genetic makeup of the fetus, and then you want to confirm it, and then you want to match it with the structural abnormalities, if any.
Can I just suggest something? Here we have again pre-implantation genetic diagnosis and prenatal diagnosis. Pre-implantation genetic diagnosis is a part of IVF. Once the IVF is done and the embryos are prepared, we would like to check on the embryos which are healthy embryos and which are euploid embryos. For that we have a test that is done even conceptually, that is PIGD, that is pre-implantation genetic diagnosis. PIGD is different from prenatal diagnosis.
Yes. So, Dr. Anuradha, what is the difference between screening and diagnostic tests?
Namaskara ellarge. At the outset, I thank the organizers for giving me the opportunity. Thank you, Dr. Rajeshri. Difference is screening tests are non-invasive, and then it identifies the high-risk cases. Then we will go to the diagnostic test, which is an invasive test, and then 100% accurate. Screening will be like double marker NT and NIPT. Diagnostic tests are invasive amnio and CVS.
Yes. So screening means we are going to first screen and then decide whether we would like to go for invasive testing in case there is a need for that. If any of the panelists or experts would like to add on to these points, just please raise your hand so that I can continue with that. Okay, so this question goes to Dr. Rajani. What are the prenatal screening modalities available?
So we have screening modalities in both first and second trimester. But before that, I would say the a priori risk is also one important screening thing. We have to take a detailed history and examine the patient. And then when we go ahead, we have the NT scan and the double marker test, which includes the PAPE and beta-HCG. And then we have the NIPT also. And then in the second trimester, we have the quadruple test and the targeted imaging of the fetal anomalies. And we have the extended first trimester screening, wherein along with the combined test, we can also add on alpha-fetoprotein and PIGF.
Yes. So going into the details of this, Dr. Madhuri, explain the biochemical testing available for prenatal diagnosis in the first trimester.
Good morning, everyone. So we are discussing about the screening tests which are non-invasive. So this is a simple serum test that we do for the maternal blood. The earliest one was the double marker test, the beta-HCG and PAP-A. This is mainly to detect the three most common trisomies, that is the trisomy 21, the trisomy 18, that's the Edwards syndrome, and the trisomy 13. These are the most three common, the Down syndrome being 1 in 700 live births. It is even more common if you do in the first trimester and second trimester, the incidence is much more common. Most of the anomalies are not viable, that leads to first trimester pregnancy loss. So then came the added test, the first trimester with the quadruple test for the first trimester with extra being the placental growth factor and the alpha-fetoprotein, which will also help us detect the neural tube defects with the alpha-fetoprotein. Then we have the thalassemia screening with the hemoglobin electrophoresis, and the penta screening, which is also with the inhibin, the same 4 as the quadruple along with inhibin test, which will be increased in case of Down syndrome and Patau syndrome and reduced in your Edwards syndrome. And finally the ultrasound screening, that will be NT and B scan that we do around 11 to 13 plus 6 weeks. That's about it.
So basically these tests are sort of an evolution of what the first test was. So you are adding on an investigation, another parameter to those tests to improve its sensitivity and specificity. And if you go to think of the foreign setup, they will counsel the patient directly for the double marker plus the NT. So patient is well known that they have to go undergo the blood test plus the ultrasound. But in our country, what happens, especially in my place, where we do not do these tests on a routine basis, the NT scan is done, something comes abnormal, then you are going back for the screening tests. So there are two, unless the NT is abnormal, unless 11 to 14 week scan is coming abnormal, the chance of undergoing a screening test is rare from where I am practicing. It depends on how, those are the points which we are going to go into detail when we go ahead in this panel.
Only thing is, madam, that time we lose time. So by the time they go in, now the triple marker is outdated.
Yes.
So we directly go for the quad. So quad is 20 weeks. I think we only should counsel them, because if you're very unlucky, something will go wrong with the patient. Yeah. Because I've had one experience like that. The patient delivered, went back, double marker was told to them, but they didn't accept that time. But she came back and asked, you didn't force me to do the test. So that's where we get stuck.
Yes.
Because that double marker is a little expensive. It's for the normal layman people. It's expensive only for some of them. But they have to do it together, because we need the scan on the same day, the double marker on the same day.
So the way we counsel is important, and change of practice.
Yes.
And whether the next thing comes is whether it's required or is it cost effective. We are going to go to that later on. But if something goes wrong, yes, retrospectively these questions do come up. So basically you want to screen with the double marker, you can add on the thalassemia part, you can add on the screening for preeclampsia as well.
FGR and preeclampsia.
So this is just a basic chart. I think one of you can just go ahead. with this?
Yes. So in trisomy 21, we have the free beta hCG, which is increased. The plasma-associated pregnancy-associated plasma protein will be reduced, as well as your AFP and unconjugated estriol will be increased. Coming to trisomy 13, the beta hCG will be decreased. The PAP-A will be increased. Inhibin A is increased. In trisomy 18, the free beta hCG will be reduced, as well as the PAP-A and AFP. And neural tube defects, AFP is elevated. In pre-eclampsia screening, we have the placental growth factor, which will be reduced. If the placenta is not functioning well, the plasma-associated plasma protein also will be reduced. So if this is reduced, we can give a screening for pre-eclampsia and start her on low-dose aspirin, right, before 16 weeks.
Okay. Next, this question is to Dr. Bandama. What are the advantages and disadvantages of analyte testing over the cell-free DNA? So please note, there is a cell-free DNA, cell-free RNA, and the mitochondrial testing available as well.
First and foremost, it is the cost factor, madam, because cell-free DNA is very costly and analyte is low cost. And when it comes to the detection rate, it is more than 99% in cell-free DNA and 85 to 90%. And false positive rate is less than 1% in cell-free DNA, and it is up to 5% in analyte. And we have the positive predictive value of 80% and 45% in low risk and lower and more false positive rates. And cell-free DNA is usually done at 9 to 10 weeks, and here it is done at 10 to 14 weeks. And cost I have already explained, and risk is like both are non-invasive, so no invasion is done. And next is this for other coverage, like cell-free DNA can also detect Rh negative status and also the sex chromosomes, so that we can be aware of the other X-linked disorders. And in analyte testing, we can also know about the placenta, so that the prediction of preeclampsia and FGR can be noted in that.
Okay. Thank you, madam. I have one add-on question to you. So this cost factor is the main thing which is coming.
Yes.
In between. Now, the cost factor, if you ask me 2-3 years ago, they were charging 20,000 for this NAPT. Now, my college did a MOU, and now they brought it down to 5,000. So now, whether we should go with all the patients, some patients.
One thing to add this to this, madam, we have to be clear. See, we have this NIPT, but there are types of NIPT, whether it is done on whole genome or it is a targeted genome. So that cost also varies. Yes. All of a sudden, even as you rightly said, it was 20,000. Even I had to pay for one of my patients 23,000. How can they come suddenly to 5 to 7,000? It's a just gimmick, marketing this thing. It is. We need to know whether they are doing on whole genome, or it's a targeted genome or SNP. It depends upon that also.
Only basic they are. They are offering for 5,000. Yes. Would that basic be helpful if we are doing it on blanket screening? That is the question.
As a screening modality, NT and double marker serves well and good. Then we can go ahead with next whatever results we get, depending on that, we can. I feel that's better like that.
Double marker is the
No,
best.
the issue is like everybody knows more than the doctor. The patient will read so much. You can't read as much as them. So that is the exposure of the patient. So they keep on asking, why didn't you do this, or why aren't you doing that, and all those things. So if patient is affordable, then everything, all these indications disappear.
Yes. And even if we add NB to the NT, the sensitivity is going up till 85 to 90%. So then going for CFF DNA, we can as well do combined screening.
So Dr. Geeta, can you elaborate the types of NIPS available and how will you choose the appropriate test so that?
Ma'am, there are three types of NIPS available, ma'am. One is normal NIPS, another one is advanced NIPS, another one is a comprehensive NIPS. In normal NIPS, it will detect the three most common trisomies what we are screening in the first trimester, that is 13, 18, 21, and it also include the other sex chromosomal disorder in Klinefelter syndromes and all will be included, ma'am. In advanced NIPS, along with this basic NIPS, what it includes, it also includes the 4 micro deletions can be identified in this advanced NIPS. The comprehensive NIPS, along with all this thing, plus 100 single gene disorders will be evaluated.
And cost also will be
accordingly increasing.
So it increases, and the chance of you finding something will be more. And then whether it is relevant or not also.
And going for invasive testing will also become more.
More. So from where I practice, only last 2 years they allowed for the amniocentesis in Vijaypur district. Otherwise we had to send them either to Bangalore or to maximum Belgaum or Dharwad medical colleges, where they were given the permission. Now they are giving permission to even small clinics, but that was not the case. So even for us, when you get a test done and then you are going to tell your patient next moment you go to Bangalore, go here, go there, they get psychologically upset. So now things are better now, but I'm just putting the perspective of what is the situation in smaller cities and smaller places. Okay, Dr. Anuradha, who is to be screened for aneuploidy?
Everybody, actually ACOG and FOXY guidelines, all pregnant women should be offered universal screening, that is a must. But at least for high risk categories like strong indication, that is age is more than 35 years, and then previous child with the aneuploidy, abnormal ultrasound finding, positive biochemical or NIPT, family history and previous chromosomal anomalies. These patients should be offered.
So,
but
Madam, I will ask
is
you,
ideal.
I feel it should be universal. You give a option to them and clearly tell them, let them choose, then you take a signature. This is what I believe, that we have counseled this person for all this, they opt for it, they don't opt for it.
Okay, so I 100% agree with this, all the panelists and experts' opinion, but I want to know one genuine opinion from you. How many of you do it universally with all your patients?
I do it universally.
What about all those patients, 50-60% of the patients are with the government sector, what about them?
I am from the set of St. John's Medical College, and it is done universally for all mothers.
Okay. So as I told you, it is the main problem is the cost and the counseling, and all these things come into place, whatever I have mentioned before, where there is no availability of these things. What is maybe very simple thing for you, maybe a very difficult thing for us because this is very strange panel discussion. All of you are from South Karnataka and I am the only one from North Karnataka. So we have our own challenges in such areas where even in a medical college, even in a medical college, I am telling you, to get even the basic things done. And we still don't have permission for the amniocentesis. I told you only last 2 years ago, certain very gine-chune private practitioners were given it, but not the rest. So that's how it is. But as per Government of India guidelines, what do they say? Government of India. Government of India, are they inculcating these guidelines in every single PHC? No, they are not. They don't have anything. They don't have any say on it. FOXY is a difference. FOXY is our OBG society people, what they are advising depending on the international guidelines. But what is the guideline of government?
Guidelines are not clear on prenatal diagnosis.
There is no guideline.
Very clear.
Because this is the problem, because if you go through the ACOG or you go through RCOG, they have got guidelines on many things. But when it comes to our Government of India or even FOXY, we have limited guidelines. We are not covering each and every topic. So I think if you ask me, we have so many wonderful gynecologists in our country, we should have really set the whole thing right. Then copy some other country and do it. So Dr. Rajani, how would you counsel a woman before screening?
So as we discussed just now, ideally ACOG recommends universal screening. But like how you said, ma'am, even in a city like Tumkur, though we offer screening for each and every patient, in our own medical colleges, we find majority of them refusing to be screened unless they are from a good economical background where they do not mind spending. They do not want to get double marker also done. But then we see that NT and anomaly scan is done universally. But like how ma'am said, if they don't agree for the rest of the screening, we write it down that double marker has been explained but the patient has refused. So that is one thing. So how to change that is that with proper counseling. So initially we have to explain to them why the screening is needed and what benefit it will give them by screening. So detection of aneuploidies, if at all not screened and they end up with a Down syndrome baby, or they go ahead for an trisomy 18 resulting in an IUD. So to prevent such incidences, so we have to explain to them why the screening is needed. The procedure for screening has to be explained in detail to them, that initially the screening test is a non-invasive test and the cost for the screening test needs to be explained. And then what happens once the results come. So that also need to be explained to them, whether if it comes as a high risk, you will need to go ahead with an invasive test which will cost this much. And if it comes as a low risk, then what will be doing ahead? We will be going ahead with the routine screening, that is a targeted fetal imaging, which is what is acceptable most of the time. And the patient has a right to accept or decline, but it is our duty to note it down and definitely offer screening to each and every patient. And if at all the invasive tests come as positive, then we need to counsel them regarding how, like a non-directional counseling regarding either termination or continuing of pregnancy, or how to deal with an affected child.
So basically the patient or the woman should be ready for the further tests.
Yes, only if they are ready for the further test.
They are happy to get the double marker done, it's just a blood test. When you start saying that you require further evaluation, then they start saying you didn't tell us before, or they may refuse your testing.
And we also find many patients.
And then the whole family gets involved. When she's going for the blood test, nobody's involved. Then the mother-in-law comes and the other family members come. And when you advise invasive testing, they don't want to get anything to touch or disturb the pregnancy. Or they will try to ask you regarding whether if the ultrasound is normal, then what are you talking about? I mean, these are the things we face in day-to-day life. So Madam would like to add something.
Pre-test and post-test counseling is important. That's the.
So,
and many a times we find people, if the combined test screen comes as high risk, they immediately want termination. They do not want to go ahead with the invasive test because they are very costly. So pre-test counseling itself, we have to explain that this is only screening.
Not only expensive, it is psychologically very disturbing to the woman, and they always feel you are doing something, and if something goes wrong, you don't know. Because already your screen is positive. It may be your bad luck that you have done an amniocentesis, maybe the baby is abnormal itself, it goes for IUD, something like that, then you will be blamed. So all these things you have to take care when you are counseling the woman. One more question I'd like to ask. Supposing you're working in a country where there are no abortion laws, then what is the role of this screening? Middle East countries have no abortion laws. You can't terminate there. Then why do you want to do all this?
To prepare the patient, they will be psychologically ready to accept an affected child, which is very important. Or they can travel to a place where...
Okay, that is also a good option. Very practical answer. That's what they do in Dubai and Middle East countries. They put them in the plane and say, go home. Then?
But in Saudi, they will not tell anything about the anomalies because there is nothing like abortion.
They have to deliver.
They have
and then
to,
what will
whether
happen
hydrocephalus, anencephaly, anything they have to deliver. And sometimes it will end up in doing a sections also.
Only thing, if it's a minor, you've got something on the scan which is repairable, you can keep the pediatric team ready.
No, we are lucky we have got very good abortion laws in our country, because one incident in Ireland was very bad. It was our Indian only who had suffered and she succumbed to it. It was, yes. So, you know, this is where I think now they have evolved. They are having laws now, I think so.
So it takes some drastic event to make a drastic decision or change in the policies. Otherwise, we don't know how many others have actually lost their life. Okay, Dr. Madhuri, explain the term double marker and its relevance.
So as you said, this was the first prenatal screening test that was devised with the beta-HCG and PAP-A. In trisomy 21, as we see, the beta-HCG will be increased and PAP-A will be reduced. So the sensitivity is only up to only with the double marker without any NT&B, it's just 65 to 70%, with the false positive being 5%. So this is the numbers have to be explained to the patient that it will have very low sensitivity. So that then on the NT&B got added, which will increase the sensitivity almost up to 85 to 90%. And
Okay. So we'll go on to the next question. Explain the relevance of quadruple marker, integrated and sequential screening. This is to Dr. Bandama, madam.
So first of all, quadruple marker consists of alpha-fetoprotein and beta-HCG and estriol and inhibin. So this is usually done at 15 to 20 weeks. And integrated test is done when we combine that is first trimester NT scan and double marker plus the quadruple marker. The sensitivity almost increases up to 96% in integrated. And in sequential screening, there are two types, that is sequential stepwise and sequential contingent. So in sequential stepwise, we are doing both irrespective. If the patient gets the first trimester as low risk, then again we are doing the quadruple marker, and next we are dividing it into low and intermediate and high risk. But in sequential contingent, we are doing in the first trimester itself. When it comes as low, then we are not going to the other test, that is quadruple test.
Okay.
One thing to add.
Yes.
In integrated screening, we are going to give the result only at the end of the test,
Yes.
after the second test.
Yes,
So the
because
diagnosis
first test
will,
is kept hidden from, we don't disclose it.
so the
in first
disadvantage is
trimester.
delayed diagnosis, but it doesn't happen with the sequential screening.
So how many of our
we are
esteemed
not
panelists are doing both the test, double and quad? Even if the double marker is normal, you are still going to do the quadruple marker?
No.
Nobody is doing.
Actually, now that integrated one we are not doing, because we can't give the result at 20 weeks. So we are only doing NT double marker. Depending on that, we decide whether to do. And TIFA we do, 20 week scan we do, structural anomalies. We have to do it.
Right. So I think everything has been covered here. I won't go through this slide again about the quad marker. Now, Dr. Geeta, what is the role of soft markers in diagnosing aneuploidy?
Ma'am, soft marker, major congenital anomaly marker, they don't need any screening, ma'am. They
Why?
have to go.
Why? Still patient wants to know why this happened. They always ask, no, why it happened, why it happened. Huh? Why did it happen to me? I am the only family member. In my family, it never happened to anybody, but it has happened to me. So they always ask that. So they mention that, okay, you are not supposed to do the screening or any test when there is a major anomaly. But why?
Ma'am, in screening, the detecting any anomalies or trisomies is not there, ma'am. It is not possible, ma'am. Always, major congenital anomaly will not be have a screen positive in aneuploidy screening, ma'am.
What about other soft markers?
Ma'am, a single soft marker doesn't have, ma'am, it is a, depends on the two soft markers present at triple soft marker present. The risk is more compared to a single soft marker, ma'am. As the
because many a times, you know, radiologists have become, or even fetal medicine specialists have become very, very keen in looking at each and every structure. And they usually give something is there. And then the patient comes with a report with us, and then they don't say anything what to do, and you have to take the decision. So, madam, could you give your experience on that?
Yes. Most commonly, we see echogenic cardiac, intra-cardiac echogenic focus, that is one soft marker. Otherwise, pelvic alopecia or pelvic alopecia and echogenic bowel.
Yes.
These are the three most common. If it is an isolated soft marker, this is only sonological clue that gives that we need to be more vigilant and go for the further testing. It's not the indication that we have to go for termination or apprehension to the patient. So we need to explain them and counsel them. Single and isolated soft marker needs further evaluation with in terms of TIFA scan and further. Yes. No need to apprehend for anxiety.
No need to be so scared about it. So anyway, just having a soft marker could be up to the prevalence of 10 to 13%. 10 to 11%. That means actually, almost 1 in 10 babies which they are going to scan, they are going to give something or the other.
But when we tell this, what is it, foci, echogenic foci is there, then they will ask us, what do you mean by that? Do we do further tests? So then we, to be careful, will say, okay, get a fetal echo done. And even if it is an isolated one, because if I feel we should just tell them these are the things, ideally we don't do.
And what happens when they get a scan done after 1 or 2 months and they say the foci has disappeared, and then they are still more happy?
Or she's got an anomaly. What we'll do that time. So this is a very tricky part. How about
because
you're very true, Rashmi, saying that. But when it comes to the cardiac focus, that is echogenic cardiac focus, it's a calcification of the papillary muscle.
Yes.
And it is seen in 4 to 7%, as madam said, 10% of the normal fetuses. So we need to counsel the couple saying that it will disappear over a period of time, wherein we can follow them up with the further scans. The chance of having the major cardiac anomaly is very rare. And we have seen.
You can ask if they have done a fetal echo, well and good, along with the scan if the sonologist
But that is not mandatory, or it is recommended, madam.
But
single isolated cardiac focus, we can just leave it for the follow-up. With my experience, I have seen.
Yes, my majority after testing and doing everything, nothing comes out of it. But still, if you still want to be doubly sure, you can go for the NIPT testing.
See, I think there everything matters about how you counsel the patient. This is a very tricky subject, as you told. You just lay them, they're educated, they'll say, for us it's no problem, echo is okay, we'll spend money, we'll get it done. And once it is done, they're very happy, okay, nothing is wrong. So, if it is not done and your bad luck, something goes wrong, then we'll have to face that. So we have to be ready for it, they also should be ready for it. That's what I believe.
Yes. Next question, Dr. Anuradha, indications for CVS.
CVS is the best option for early definitive diagnosis in high-risk pregnancies, allowing early decision. It is done from 11 to 13 plus 6 weeks. In all cases of high risk, increased risk of chromosome anomalies identified through the antenatal screening, abnormal first trimester screening results. If it is abnormal, we'll be doing ultrasound evidence of fetal structural anomalies, or advanced maternal age, previous child with previous pregnancies affected chromosomal genetic anomalies, carrier status of genetic conditions in either parent, including autosomal dominant, autosomal recessive, sex-linked, and family history of genetic or chromosomal disorder.
Okay.
Any of that, we will be doing that.
Right, since our organizer asking me to rush it up.
more than 3.
Yes, so if the screen is positive for the first trimester, then you can go for
more than 3, double marker normal.
Double marker is normal and you want to go for the
NT more than 3.
NT more than 3, you want to go for these investigations. Fine. So you want to go for an invasive one. So even if NT is more than 3, then how much more than 3 is the question? That's the question. At 3, 93% of your fetuses are going to be normal anyway. At 3.5, you got 70% of your fetuses normal. So you should know that a big bulk of your patients are going to have a normal fetus, even with a slightly raised. The more it is raised, the more chance of abnormality.
And it is again gestational age dependent. Yes. We need to go on the nomograms and we need to counsel them and follow them up. Quadruple test and the early anomaly scan.
Next question to Dr. Rajani, indications for amniocentesis.
So for amniocentesis, one is when the mother is at a higher risk of having a baby, an abnormal baby. So if the first trimester screening or the next screening comes positive and NIPT is abnormal, then when the parents are balanced translocation carriers, and when you see that the baby is at a high risk, when the couple has a previous anomalous baby which has been detected, baby with an aneuploidy which has been diagnosed, or even if the previous baby has not been diagnosed, if the previous baby has typical features, then you directly go ahead, and then when you suspect single gene disorders, and then you go ahead, and historically one we had was in RHI.
You are looking for something you're looking for something when there is something abnormal.
Yes.
Either your past
Yes.
past screening
And
has been
directly
abnormal,
when you see
or
a
there is some family history.
major abnormality in the scan as well.
Right. Next, Dr. Madhuri, can you explain these very difficult terms which are asked for when you're doing the amniocentesis? Karyotyping, CMA, FISH, and the PCR.
So now that either the patient has undergone a CVS or a amniocentesis, it has to be sent for analysis. So which one should we send it for? So what are we looking for? Are we looking for aneuploidies, large changes, like in aneuploidies, either change in the number, either extra or a deletion, which is most common? We send it for karyotyping. Most commonly it's done for all these recurrent pregnancy loss, in infertility, we send it for karyotyping. So it needs active dividing cells. Culturing is required, so it takes a long time. Many days or weeks are required for the karyotyping report to come. However, it cannot detect the small micro deletions or the micro duplications. So for that, if you're suspecting anything else like micro deletions, we'll have to send it for CMA, the chromosomal microarray. It's a microarray based technique which can detect up till it has very high resolution. So up till 100 kilobases can be detected. Any change up till 100 kilobases can be detected. Then we have the FISH, which is for targeted loci. And you're suspecting specific changes, then you go for FISH. When you have the PCR, this can be done for infectious diseases as well, like for TB and all that we do. Specific gene, single gene disorders if you're suspecting, then you go for PCR. So PCR and the FISH will come within hours. The report comes within hours, whereas your karyotyping will take weeks and your CMA will take a few days to come.
So I would suggest in such cases better to take a help of a genetic counselor. Yes. Because yes, you wouldn't be able to do everything on your own in such cases, and you may not have the time to do it also. And taking expert advice on this would would help you to make a better choice in what investigation. Now, one would ask, why not do everything? I have so much of money. Then the main is the money, because everything, the cost of each test is different. So that's the issue here.
It depends upon the indication, mainly whether it is a structural or a gross anomaly that needs to be detected, or a targeted foci, or a micro deletions. Then that accordingly, with the expert opinion, we have to go with. So
if you know if there's a past history of a child affected, or there's any parent is affected, then your life becomes easy. Yes. But if you're just hitting the bullet in the dark, then your expenses is going to go up, and eventually your results or everything may not come in your favor also. So next question to Dr. Bandamma. If you are asked to send for a clinical prenatal exome sequencing, clinical or whole exome, then how will you decide which one? Again, it's all about the cost.
Yes. So it is like this exome sequencing is done when standard prenatal tests like karyotype, microarray or NIPT do not explain the anomalies. So we have the clinical exome where a part of the genome is sequenced, and whole exome like where whole of the genome is explained. So the cost is like lower in clinical, and it is higher, and more than 20,000 plus are detected in whole exome. But I feel whenever we are like suspecting this one, clinical exome sequencing is better than the whole exome sequencing.
Yes. That's true. So one should understand, basically, at least from my side, that karyotyping may be normal, you go for the next one, microarray. If that is normal, or you know that these tests are not fitting into your diagnosis, go for the selected test. If you can't decide or can't make up which one is the best for you, take a help of a genetic counselor. That would be the best thing, and it helps the patient also to understand what is going to be the outcome, and after even coming to know the result, what they are going to plan for next. Okay, Dr. Geeta, everybody is talking about AI. How will it help in our practice?
AI will have individualized things, ma'am. It has a proper biometric validation of biometric measurement, and it reduces the inter-observer variation. So it will help in improving the standardization and predictive analysis.
So henceforth, the sonologist has to just, do a scan, and then the report will be finalized by the AI. You are happy with that or unhappy?
Unhappy, ma'am.
So that depends how much you have affinity towards your sonologist, because it's going to take over. If the sonologist reports are not correlating with your this one, you are happy with the AI. Okay, so new things we cannot prevent from coming in. So what is other new things? Epigenetics and liquid biopsy in prenatal diagnosis, Dr. Anuradha. So
both are emerging technologies and non-invasive. In this, DNA methylation differentiates fetal from the maternal DNA in the plasma. Key role in detecting fetal aneuploidies, trisomy 21, 18, and 13. It predicts the maternal fetal complications like preeclampsia and IUGR. Epigenetic assays for conditions like Prader-Willi syndrome, Angelman syndrome, and Beckwith-Wiedemann syndrome, we will be knowing it. It is emerging and then invasive, non-invasive, and then costly also.
Okay. Next. Liquid biopsy, I have already told about the NIPT. You can do cell-free RNA and also mitochondrial testing. Now, this was what we were talking about, cost effectiveness and implementation in India by Dr. Rajini.
So here we are not talking about the corporate setups. It is mainly about the government setup where the people are still poor. They cannot afford to go ahead with the costlier tests. But where this becomes important is when you counsel, you tell them that the cost effectiveness for the test versus taking care of an affected child. So the test will cost lesser than the cost that they have to pay for taking care of an affected child, and that would how it would be.
So
and once universal implementation happens, the cost will come down definitely.
It will come down. It is coming down so drastically. I am sure by next year this will not be a question at all in any conferences. Ethical and legal aspects by Dr. Madhuri. Will you terminate your Down syndrome, all your Down syndrome babies?
So I'll give a detailed information about the pros and the cons of having a child with Down syndrome, explain them the life with a Down syndrome baby, let them take a decision after a balanced information, a non-biased information, let them take a decision. I would explain that.
So we'll just, psychological impact we have already covered. Just quickly, Dr. Geeta, what will you do if you have a woman with 11 weeks of gestation and positive NIPT for
invasive testing, ma'am.
You are going to go for the invasive testing. Right. Next case, Dr. Anuradha. Major anomaly at 22 weeks, quad marker is normal. What do you do?
Multidisciplinary approach and legal consultation.
Right. Next, Dr. Rajini, a 38-year-old woman has a quad marker result as risk for Down syndrome 1 in 50. 11 to 14 week scan was normal. Now your results are coming like this. And T5 is normal. How will you proceed with this case?
Would go ahead with invasive
yes,
testing.
You have to confirm.
Yes.
You have counseling. For everybody, counseling is mandatory.
Yes, counseling and confirming with an invasive test.
Right. Evaluation of a case of isolated echogenic fetal cardiac focus, already madam has explained about that. So it could be isolated finding and you have to further evaluate it. Next, women with 12 weeks gestation has NT of 3 mm. How will you evaluate this case?
It's an increased risk of more than 95th percentile. So I would like to confirm it by doing proper NT scanning. And next, combined test.
Yes. See, some places still NT means only NT. They are not doing the whole 11 to 14 week scan. Okay. Couple comes with history of thalassemia. This is very common. At least in our place, there is a big community of people who have it. So how will you advise this patient?
First, we'll confirm about the father as well. Does he have the thalassemia trait? If both of them having the trait, then 25% of chance being fetus being affected and 50% chance of being carrier. So
right.
And then go for amniocentesis.
Right. Then we have to. Yes. I'm done. We are done. So role of multidisciplinary has been done. Counseling, we have done all this. We have already discussed these points. And if the patient declines testing, we have no role. We can't go against the patient's choices. Cost and acceptability.
One more thing I want to add in that cost and this one. Yeah. Make in India kits can be made available and the lab facility can be done in India only. Make in India kits.
Yes. So at the last I'm putting a picture up of a Down syndrome couple getting married 2022. She's a teacher and he's working abroad. Okay, so thank you. No, it's okay. We have, I have 2 minutes more according to the timer here. I am in time. We have 43 minutes.
Thank you, Dr. Rajeshwari Eliwal, and thank you, KSOGA. Thank you all the panelists for a very nice discussion.
Thank you, Tumkur, for KSOGA and organizers for giving me this opportunity. And it was a wonderful panel. Thank you, Dr. Rajeshri. Thank you so much.
On keynotes, I welcome Dr. Jyotika Desai ma'am on stage. She's a chairperson of this session. Senior Kangaluru. She's a past president of BSOG and BMS. Welcome you, ma'am. I request Dr. Durgadas Asrana sir to chair this session. We have a first speaker for the session, Dr. Jayam Kannan ma'am. She'll gonna talk about prevention and management of stillbirth. She's a consultant at Garbharakshambini Fertility Center. We welcome you, ma'am. Garbharakshambigai. Yes.
Thank you. When she lands into the labor ward, thinks that she is going to gloom like this and get a life in her light. But when things do not happen that way, and she gets into one of these 2 million babies mother, which happens every 17th second, as has been made by the London School of Management, in which India is contributing to 1 million deaths. And out of this, 50% is intrapartum, meaning thereby we as obstetricians do have a big role to be played in this one. What is needed to be improved is pediatricians have shown under 5 death better, but we have not shown this better. See, India is #1 world throughout, even though many parts of our country are better. First, 1978, the first paper on stillbirth was brought by Dr. Kubler, and in that he mentions 3 phases of this stillbirth. The first phase, the minute the patient hears that there is a baby is not having the fetal heart, not moving, she says, no, I don't accept it. My baby is moving, I am feeling the kick, my tummy is improving. That is a reaction. The second reaction is, she stares at the doctor. What did you do with my baby? You have done something by your medicines that has made my baby sleep. It takes hours and hours for her, and finally she settles down. Yes, I accept. And she tries to adjust. And the definition of the stillbirth is variant. Even in our group last week, somebody had put it as 19 weeks stillbirth. Presently, 28 weeks and 1000 grams baby is the one to be accepted as per WHO, not to speak about the 20 weeks and 20 weeks by other associations of the world. And if we start including all those things which are being talked about, the rate will be enormous. ICMR, with all this banks being put there, has started this stillbirth pooled India cohort 2025. The paper is getting reviewed, and they have looked at 29,000 pregnancies, and they made it very clear. 1/3 are anemic, 50% are multiparous. Both obese and lean. In fact, lean is more contributing to the stillbirth. And we are yet to read this. 2030, we are nearing just 4 years to go. This 12 per 10,000 should be reached. 12 per 1,000 should be reached. This definition of stillbirth is going on with all our people. And please note, we always have the textbook saying the stillbirth gets doubled. It really scares the patient, because what is the doubling rate between each week? 39 weeks, 1 per 10,000, 2 in 38, 3, 4 in 39, 8 per 40. 42 weeks is 32. That is, internationally it has been planned that no delivery should exceed 22 weeks. See, our part of the country, we are better with less than 12. We have already reached the stillbirth category. Few places in this, some part of Karnataka and Andhra Pradesh and a small pocket down south in Tamil Nadu is 10 to 17. We are almost reached, but only we are worried about this northern part which is coming up. That is why India has made a very clear decision that 38 weeks and 6 days should be the ideal time of birth for Indian patients. Always have the records of these previous abortions, previous stillbirths. And kindly note, we are talking about eclampsia, hypertension causing stillbirth. They contribute to small percentage only, as I have put it. I am going to. 2000, there are many consultants here who have been educated in 2000, 2005. And we had a big talk about Gardosi talking about recode classification. Relevant conditions of death has been classified. And this has been looked at in 2025 with a fetal pathology, 97%, genetic test, autopsy and other things. And it has been found to be evaluating little poor results with recondition at birth. And we have to really look at more about infections as causes of stillbirth. There is a paper, February, July 2024, from India, from one university at Mumbai, where preterm birth in India is due to 3 types of groups of bacteria which are definitely encoded, and that is getting evaluated outside this country. Probably that will add up this also. As per this 3 code, this percentage is given, but that is not being accepted. Now kindly look at this, what this child says, 50% is preventable. Please get my other 2 fingers also folded up, out, so that all of us are out in the world with movements. Lancet 2016 has made this very clear that 75% of these stillbirth are preventable if only we look at syphilis, malaria, non-communicable diseases and avoid all the obstetric complications which are in our hands to be taken care of, and a few congenital disorders which Government of India has accepted to terminate the pregnancy up to 22 weeks, 24 weeks. So health system need to be improved. All of us obstetricians also need to improve. Just look at this. Why we talk about it? This thing, in that they were talking about Down syndrome, cost involvement and not detecting. No. In Tamil Nadu, last month, 75 lakhs compensation for a doctor who has not done a NT scan and Down syndrome test because the baby still all right, going on well, 75 lakhs compensation. And another, they were talking about, we can write it in the paper, that patient refused to accept the Down syndrome detection. No. Another court in Tiruvannamalai has given a doctor. Previous day, the doctor has seen and said the fetal baby heartbeat seems to be little 110 to 120. Get admitted, we'll look after it. She went back home. She gave in writing, I am not getting admitted. I know my baby is not all right. But still the court says, you are a family doctor. You should have seen to it she was admitted in the hospital. You should not have allowed, saying that 10 lakhs has been compensated. Another patient from Bangalore, she has gone to Pattukotai because it's a Rasi doctor. First delivery was smooth. Second delivery, she goes there. Both mother and baby are lost and a big furor is going on. So writing alone sometimes is not all right. We have to go a long way to think about the emotional judgments which are being given to these people. India stands with antepartum and intrapartum stillbirth. You see, or more, 52% is intrapartum. So we have to be very careful in this. ICMR also has accepted this one recently. There are some steps. Now we have said all about the prevention. If you are seeing at morning 9 o'clock a stillbirth patient, what are the things to be done in that case? Review the history again. Review the gestational age and the fetal growth charts which the patient has. Did she have any bleeding at any time? Did she have any fever at any time more than 104? And carefully judge her fetal movements perception. All the ultrasounds, laboratory investigations, triple screening, double screening, anything, amniocentesis, all these things, again go through the family history also. have a checklist for this stillbirth, write all the details in that with the gestational age which has been put at the beginning, document all the past observations. Now again record the blood pressure and have all the other blood pressure records sequence noted, because one record of blood pressure above 130/90, 40% can go in for problems. Now again repeat her question after some time after seeing the first. When did she really feel the last moment? Because her first phase may be over. In the second phase, she may be able to give you a better history and talk about any small leaking that she had in the last 3-4 days and any viral infection. Just like that, did she sneeze? Did she cough also is required. And find out all the tests like ultrasound, platelet, and everything has been noted in her details also. Now, having done it, having allowed her the first phase and second phase, go to the third phase and adapt non-interference, wait for spontaneous expulsions, look for uterine infections, aware of it, watch for the fibroinjaver, wait for the labor to start, oxytocin drip as and then mifepristone, as you all know. LSES is a last resort. Never do an ARM in these patients. Puerperium is going to be really problematic, and kindly avoid sedations, liberal with analgesics only. Do not separate the couple, saying that the hospital rules are there. Now, look at the card. Take all the details about the card. Look at the placenta. Have all the details of the placenta. Preserve the placenta as per the pathologist guideline, in saline, in formalin, depending upon what he wants. Because you already know that it is a stillbirth, you should have done all the contacts and did it. And look at the baby clearly with all the details right from the hair, ear, down to the sole of the feet. And take a clinical photograph. Radiographic studies also if required. Biopsies then and there if there is any problem. But where all these things are possible, not in a place 30 kilometers from Tumkur in a primary health center. Patient should have been at least in Tumkur for this all work to be done in these cases. Lactation, please take care of it properly, and probably we can add bromocriptine also. After that, we have to slowly suggest to her about other things and never change the EDT which has been noted in the case sheet. And recently I had a case in summer, patient had 2 days diarrhea, night 10 o'clock we have recorded the fetal heart, morning 7 o'clock the fetal heart is little down 110, by 8 o'clock fetal heart is lost. Now I looked at one paper from June. The recent paper says in infections, hypercoiling of the umbilical cord, maternal enteroviral infections, undetected thrombophilia, angio2 gene which is coming up as a cause of stillbirth and 20% unexplained is the recent data of this one to be noted down in all cases where we have ruled out hypertension, diabetes and other things. Now under 5 deaths have come down, but we have not come down with this disease. Improvements are all happening. Yes, hypertensive disorders are being taken care of very clearly. With all this NRHM, we are also going up. And this London School of Management is continuously working and says extreme heat also can produce stillbirths. Please be careful when you have patient. That patient which I had was in the month of May. I learnt a lesson. Please don't learn a lesson from a patient. Learn from these sort of conferences and accordingly works. We always have the NAP with 5 pillars. The last 2 pillars which are being added are free transport for the patients to avoid cost. 21,000 newborn centers are being pushed up in all over the country so that newborn can be cared better. Liberal ultrasound with these patients, and this ENAP is going to say 8 pregnancy test is a must. Every birth to be attended by a skilled attendant. Every newborn receives a routine antenatal check, and make these 2 fingers go up with these things by looking after diabetes, hypertension, IUGR and thyroid cases. And these are the references which I have looked at it. I hope the slides are with them. References can be noted. Thank you very much for giving me this opportunity.
Thank you, Dr. Jem. That was actually a brilliant lecture. And thank you so much for keeping to time. I would just like to ask you, any questions from the audience? Yes.
Why should we never do an ARM?
Infection.
Never ARM.
Why shouldn't we do artificial rupture of membranes?
By artificial rupture of membranes, we are going to introduce
Infection to a dead baby.
the babies, the liquor would have already come down, and that this thing is not going to, the baby does not go and it is not going to come down and press on the cervix, and it is not going to press on the cervix and give that stress of stimulation of the cervix. That has been proved very clearly. That is why of late it has been made clear, never do ARM in these cases.
Yeah, ARM should never be done. That is an accepted thing.
Accepted.
I wanted to ask
you are saying infection. She is saying something
Infection
else.
is
Both
one
together.
of the factor which has been noted very
Yes.
clearly, and ARM, physiologically it is not going to, why we do ARM? Because the liquor comes down and the baby, uterus size is getting reduced and it is going to press on the cervix and start stimulation. These two factors are, one is it's infection which is coming up very dominantly in stillbirth. Hypertension is only 5.9, diabetes is only 4.9, thyroid is 5% untreated. But all these things are not the cause. Cause is mainly infection, which is still being explored with all the enterobiomes as I have shown in that case.
Just one thing I wanted to point out, that you did not mention about counseling about a dead baby. Breaking
Because
bad news spikes what we should
Yes,
follow.
time constraint. I have the
Yes,
slide on
yes.
counseling, but time constraint, because he wanted to go for the plenary, I left that slide.
Thank you,
I
Dr.
have
Jain.
to then-
Thank you
yes,
so
thank
much.
You, thank you.
Thank you.
Thank you.
Next speaker.
Thank you, ma'am, for the deeply insightful session.
Moving on to next talk, we have Dr. Ashalata Mallapur to speak on intrahepatic cholestasis of pregnancy. She is Professor and Ed, Department of Obstetric and Gynecology, S. Nijalingappa Medical College and Hangal Shri Kumareshwara Hospital and Research Center, Bagalkote, Karnataka. We welcome you, ma'am.
Thank you. Thank you so much. Okay, pregnancy is one of the nature's finest miracle, and a time when woman's body supports two lives in perfect harmony. I think judges will agree with me, isn't it? Okay, chairperson, sorry. So, but occasionally this harmony is disturbed with subtle signs of light itch, restlessness nights, which seems to be harmless, but it could carry definitely clinical significance. One such condition is intrahepatic cholestasis of pregnancy, fascinating yet challenging, where the liver for a short while it's fascinating yet challenging, where the liver for a short while it forgets its rhythm during pregnancy. See, a fascinating yet challenging, where the liver for a short while forgets its rhythm during pregnancy. Good morning, respected chairpersons, friends, and dear postgraduates. It's indeed pleasure to be here today to share brief overview of intrahepatic cholestasis. So I bring greetings from Bagalkot. Yeah. So definition, a pregnancy-specific reversible liver disorder characterized by pruritus, itching, especially palms and soles, raised serum bile acids, abnormal liver function test, and resolution after delivery occurs. Usually it is seen in second and third trimester. It's also called as obstetric cholestasis, cholestistic jaundice of pregnancy, idiopathic jaundice of pregnancy. Incidence is 0.2 to 2% worldwide, common in multiparous women, twin pregnancies. There is family history of ICP, more prevalent in South America, Scandinavia, and Indian subcontinent. And recurrence rate is about 45 to 70%. Etopathogenesis, it is multifactorial. It has hormonal factors, environmental factors, and genetic factors play important role. Hormonal factors are estrogen and progesterone metabolites inhibit bile flow, which explains late pregnancy onset, higher in twin pregnancy. Environmental factors, selenium deficiency, and there is seasonal variation too. Genetic factors, there is mutation, ABCB4. These are the genes which impairs the phospholipid transport in bile, and ABCB11 gene, which is also known as bile salt export pump, where it leads to bile acid accumulation, and ATP8B1, which disrupts the bile membrane stability and transport. So mutations reduce the bile flow, leading to accumulation of bile acids in maternal blood, and explains familial and ethnic clustering ICPs. Pathophysiology, defective bile acid transport, which leads to accumulation in maternal serum and skin. Bile acids also cross placenta, causing fetal arrhythmias, vasoconstriction of chorionic vessels, placental dysfunction, and sudden stillbirth, which is unpredictable. Clinical features. So maternal, intense itching, palms, soles, and worse at night. Scratches are seen but no rashes. Occasionally mild jaundice in 10 to 15% of cases. Dark urine, pale stools, no fever, malaise or pain. And as I told you, there is definitely a fetal problem here. Fetus can have fetal distress, meconium staining like a preterm labor and stillbirth because it crosses placenta. So investigations, the main important investigation here is serum bile acids, and elevated bile acids definitely help in management. So consultation, patient consultation is very, very important. So investigations, we have serum bile acids, more than 10 micromoles is diagnostic, more than 40 micromoles per liter, they say that it is severe, but it is again changed now according to different recommendations. Most specific and sensitive test correlates with fetal risk. Then we have serum transaminases, mild to moderate elevation, alkaline phosphatases elevated, but physiologically it is definitely elevated, non-specific. Prothrombin time, hepatitis serology negative, and other liver ultrasound of liver and biliary tract is normal. So investigation mainly we concentrate on serum bile acids. So differential diagnosis would be viral hepatitis, HELP syndrome, acute fatty liver pregnancy, drug-induced hepatitis, gallstones and biliary obstructions. So as I told you, there is severe pruritus, insomnia and fatigue. Vitamin K deficiency leads to postpartum hemorrhage, and recurrence in subsequent pregnancy is also seen. Rarely persistent liver dysfunction in this condition. Fetal complications, already I have told you. There is preterm labor, spontaneous or induced because it crosses the placenta. Meconium stain liquor, fetal distress, intrauterine fetal demise, and stillbirth. Risk correlates with the bile acid levels more than 100 micromoles per liter. Sometimes what happens, the patient comes with severe itching and we neglect usually. And suddenly when she is at term, there will be intrauterine death. So we should not neglect and we should see what is the cause and come to conclusion. Management review aims to, first is to relieve maternal symptoms, prevent fetal complications and ensure safe delivery. So obstetric consultation is important. Monitoring strategies are very important where we look at bile acid levels. So medical management, ursodeoxycholic acid, which is 10 to 15 milligram per kg per day. That's a good standard, reduces bile acids, pruritus and fetal risk. We have cholestyramine, 4 grams 1 to 2 grams per day, and relieves itching and reduces vitamin K absorption. Rifampicin is recent advances. They have added in those cases who are resistant to UDCA. And vitamin K also will be given, antihistaminic for symptomatic relief only. Fetal monitoring is very important. We usually, just when the patient comes with itching, we neglect actually, but we have to keep it in mind of this, though it is rare. So weekly bile acids Then NST and all usually not much predictive. Ultrasound for growth and well-being. Close monitoring if bile acids are more than 40 micromoles per liter. We have to monitor and we have to decide what treatment to be, what are the plans in future. So timing of delivery and timing and mode of delivery, severity of total bile acids and delivery recommendation, less than 40 micromoles per liter induced at 37 to 38 weeks, 40 to 99 micromoles per liter induced at 36 to 37 weeks, but more than 100 micromoles per liter induced even lesser, than 35 to 36 weeks or earlier if distress is there. So vaginal delivery preferred unless obstetric indications for LSCS. So postpartum care also is very important. Symptoms resolve within 48 hours, that is within 2 to 3 days. LFTs get normal in 4 to 6 weeks. Advise vitamin K supplementation for baby. Avoid estrogen, OCPs. Use progesterone only pills. Counsel regarding recurrence risk in next pregnancy. So recent advances, revised severity cutoffs of RCOG 2022 is more than 100 micromoles per liter, that is severe ICP. Rifampicin is add-on for UDCA in non-responders. Then obtacolic acid is under trial. Serum biomarkers in early predictors. Genetic testing in recurrent cases can be done, but bile acid guided delivery reduces the stillbirth risk. So we have to always monitor bile acids during pregnancy. Prognosis, maternal excellent prognosis, already told that it is reversible. It may take 2 to 3 days later after delivery. Maternal symptoms resolve within 40 to 72 hours. Fetal depends on bile acid levels and timing of delivery. So we should be very, very careful. Recurrence common in future pregnancy, about 40 to 60% next pregnancies. So conclusion, early diagnosis and monitoring are key. Bile acid levels guide management. Multidisciplinary approach improves outcomes. So it is very, very important when the patient gets admitted to take a good history of the patient, and if patient says that itching, we usually refer to physicians, they give UD leave for that and we just keep quiet. But we have to monitor, and these bile acid levels are very important for the management and especially for the timing of delivery. Guidelines, recommendations for ICPs, RCOG guidelines offer delivery at 37 weeks if bile acids are, actually there is little bit confusion. They say that they have to deliver earlier, as early as possible after 36 weeks, and they have to see the bile acid levels. Otherwise, the baby may go for stillbirth. ACOG says use UDCA as a first line treatment, delivery at 36 to 37 weeks. Society of Medical and Fetal Medicine says stratify risk by bile acid levels, emphasize fetal monitoring. Foxy India, all science and international guidelines, alliance and international guidelines emphasize early diagnosis. So early diagnosis, early treatment, and depending on bile salt levels, early delivery definitely helps in good treatment outcome. So take home messages, intrahepatic cholestasis of pregnancy, a condition where a simple itch can signal liver diseases. Early recognition and timely management can prevent adverse maternal and fetal outcomes. Compassionate care and close monitoring remain the cornerstone of good obstetric practice. So every itch tells a story. It's our duty to listen, isn't it? It is very important, especially though it is very rare. We see very rare cases of cholestasis, but when it comes, it is our prompt, take history, come to the diagnosis, and early treatment definitely helps the mother and fetus in a good condition. These are my references. So thank you. So I thank the organizers for giving me this opportunity to give talk on intrahepatic cholestasis. Thank you so much.
Thank you, Asha. You brought all the details in a nutshell, and you managed to finish before time. Just for the audience, I would like to mention that, like how Dr. Asha mentioned about the itch, how do you differentiate it from PUPPP in pregnancy? Because both come in the second and third trimesters. In obstetric cholestasis of pregnancy, you will never have a rash. That is one very important thing. Itching without a rash and itching only on the palms and soles. Whereas in PUPPP, another clue for you is the peri-umbilical halo. Just around the umbilicus, you will never have a rash in PUPPP. You'll have a beautiful halo there. Just look at the abdomen. Either way, you're going to examine the uterus. So when you see that, you know it is PUPPP. It is not obstetric cholestasis. That's one thing. And what about LCHAT deficiency? You didn't mention about LCHAT deficiency. Anyway, it's okay. Any questions? Anybody wants to ask? Okay, then we'll close. Thank you so much, Asha. Thank you.
Good morning. Thank you for such an informative session, ma'am. I welcome our another chairperson, Dr. Rachana JT, ma'am, who is secretary for KSOG and also a consultant in Surya Hospital. Welcome, ma'am. So now I welcome our next speaker, Dr. Soumya Mani, ma'am, who is a medical director and consultant obstetrician and gynecologist, and as well as a endoscopic surgeon and fertility specialist at Mani Super Speciality Hospital and Research Institute. She has been honored with the Salu Marada Timmaka National Greenery Award and a national level Foxy President's Trophy under her distinguished leadership. We welcome you, ma'am.
Thank you for your kind words. Good morning, all. I bring greetings from Mani Super Speciality Hospital and Research Institute, Hassan. Can you guess what is this? Someone is trapped in the niche. So let's bridge the gap between isthmus and infertility. As we all know, cesarean section is on the rising trend globally for various indications and so also the complications related to it. Isthmosil, it's a serious iatrogenic complication of cesarean section that might have long-term consequences for reproductive health. An isthmosil, a cesarean scar, defect or a uterine niche, it's an indentation representing myometrial discontinuity, a triangular anechoic defect in the anterior uterine wall with a base communication to the uterine cavity at the site of a previous cesarean section scar. It was diagnosed in 1961 by using hysterosalpingography, so all of us know it's not a new entity. It's classified depending on the anatomy, a simple niche with one branch, complex niche with more than one branch. Depending upon the size, it is classified as large if it is more than 50% reduction in the myometrial thickness, or residual myometrial thickness is less than 2 to 3 mm, and it is classified as small if the myometrial thickness involved is less than 50%. Depending on the location, upper 2/3 of the cervix if the cesarean is done electively or early labor, or lower 1/3 of the cervix if it is done advanced dilatation of the cervix. The prevalence, it depends upon the type of the scan we do and the time, the phase of the cycle, and also the scan done after how many days after the cesarean section. It is 61% after primary cesarean section and up to 100% following tertiary cesarean section. It is in 6 to 12 months after the cesarean section. The risk factors include the surgical factor as well as the patient factor. Related to surgery, the most important is the single layer uterine closure, where the incomplete approximation of the myometrial layers can lead to the niche formation. And if you take a cervical incision at a lower level, the cervical mucus, it interferes with the healing. Prolonged labor, if it is more than 5 centimeter dilatation and if it is more than 5 hours, the thin, less vascularized lower uterine segment can lead to the niche formation. As we all know, the multiple cesarean section, definitely it causes the cumulative damage to the myometrium leading to the niche formation. The patient factors include the genetic connective tissue disorder, obesity, diabetes mellitus, uterine retroflexion, and endometriosis. So the longer the active labor prior to emergency cesarean section, it can increase the risk level to a greater extent. And the additions, as I've already told, the most important is a single layer deciduous sparing closure technique. Single layer closure of the uterus, it increases the niche formation due to a greater risk of incomplete closure, and also the non-perpendicular suture that causes an irregular myometrial closure, and the locking suture or the tight second layer leads to the ischemic necrosis and poorly healed scar leading to the niche formation. The suboptimal surgical technique like inadequate hemostasis, tissue ischemia, and the excessive tissue manipulation, it can contribute to poor scar healing adhesions leading to niche formation. The anatomical and the functional defects are very important here. The menstrual blood retention collected in the niche that causes loss of contractility in the niche area leading to the clinical manifestation like postmenopausal spotting or prolonged bleeding. Chronic inflammation can cause breakdown products of the retained blood that causes a hostile uterine environment and impaired implantation. The junctional zone disruption causes architectural disruption of myometrial layers that again causes abnormal uterine peristalsis and impaired sperm transport. The intrauterine fluid accumulation again causes secretion and impaired drainage from the niche area. That causes mechanical interference with implantation and embryotoxic effect. The vascular compromise, that's the most important factor in all the steps, that causes the disorganization of the normal vascular architecture leading to the impaired endometrial proliferation and receptivity. Most of the time, the patient present with gynecological symptoms. The most important is post-menstrual spotting, that dark colored bleeding per vagina persisting for more than 2 weeks. The patient also come back to us with pain abdomen like dysmenorrhea, maybe due to chronic endometritis. Secondary infertility accounting for 10% of the cases. The obstetric outcome includes uterine rupture, adherent placenta, or CSCAR ectopic pregnancy. There are reports saying even 6 years after the caesarean section, they can land up with scar abscess in a niche formation because of the collection of the content in the niche for a longer time with recurrent infection. It can also cause bladder dysfunction. The problem in the IVF is the difficult embryo transfer. This is encountered in 20% of the women with niche undergoing IVF. So these are all the mechanisms where the isthmoscale can lead to the subfertility. The most important is the mechanical obstruction where the physical barrier impeding the sperm transport. The impact on reproductive outcome is huge. There is decreased implantation rate and low birth rate, increased miscarriage rate. The size of the niche is very important. If it is larger the size, the outcome will be poor. We have got different modalities to diagnose the caesarean scar niche. Of these, the most important is either 2D or 3D ultrasound with transvaginal route. Optimum timing for a scan is after caesarean section, the scar tissue in the myometrium at the site of caesarean form in 3 months and the complete healing occurs in 6 months. So at least we need 3 months after the caesarean section to diagnose the niche. It's usually done in the menstrual phase or in the periovulatory phase. It's very important to know the niche measurement where we need to take the depth, the length and the width of the niche, and the residual myometrial thickness, it's very important, and also the adjacent myometrial thickness. The distance between the niche and the UV fold and the distance between the niche and the external os, this is very important when you are opting for the surgery in case of a niche, not for the diagnosis. So the diagnostic criteria includes an anechoic space at least 1 mm deep with or without fluid and at least 2 mm deep in the myometrium at the caesarean scar site clinches the diagnosis. These are all the various measurements how you need to go for. Of course, HSG or hysteroscopy or GIS, it's not at all needed to diagnose the niche. GIS is a gold standard. This is considered only when you have a suspicion about the diagnosis. The diagnostic criteria for niche is the presence of niche with one primary symptom and two secondary symptoms with 3 menstrual regular cycles. So condition, at least minimum of 3 regular menstrual cycles should be there. We need to exclude here the cervical dysplasia, other gynecological factors like cervical dysplasia, vaginal or uterine infection, other intracavitary pathologies. So when to operate and when not to operate, it's very important. We should operate only when the patient is symptomatic, and routine repair of incidentally diagnosed niche with no plan for future childbearing is not recommended. Hormonal therapy symptomatically relieves the AUB. Oral contraceptives are suitable if the pregnancy is not desired. All NNGUs can be considered. Surgical management includes the hysteroscopic niche repair if the residual myometrial thickness is more than 3 mm, and transabdominal route is considered if it is less than 3 mm. Transabdominal route, you can go for laparoscopy, laparotomy, or combination of both laparoscopy and hysteroscopy. Where in hysteroscopic isthmoplasty, the resection of the fibrotic tissue of both the distal and proximal edges should be done, and also local fulguration of the dilated blood vessels and endometrial gland should be considered. The transabdominal route laparoscopy, it's ideally to combine hysteroscopy and laparoscopy. It's very important. The illumination with the hysteroscope, we can clinically find out the margins of the niche on the laparoscopy. While repairing through laparoscopy, it's very important to excise the full scar of the niche area, and also it should be closed in 2 layers. Continuous 2 layers and non-locking sutures should be considered. Vaginal route is preferred when the niche is at a lower level. Hysterectomy, it offers definitive treatment for the niche-related gynec symptoms. So when we considered hysteroscopic niche repair, the outcome is there is pain improvement in 97% of the cases and complete resolution of AUB in 72% of the cases, but 5% of the patient may have recurrence. So laparoscopic repair, patient has very good symptoms relief, and the most important is there is myometrial thickness is increased when we close it in 2 layers, and the pregnancy outcome rate is very good with laparoscopic route. The prevention of the niche formation includes the primary prevention is by minimizing the cesarean section rates, secondary prevention by adopting correct surgical technique, ensuring thicker residual myometrium and strong scar. So here the far near technique, it's very important. It demonstrated that uterine closure using far near double layer unlock technique may benefit in reducing isthmosil formation and ensuring sufficient residual myometrium. .5 centimeter from the incision line. This is the first stage we take it from the depth, and the next is at the superficial level. So this technique, it includes the whole thickness of the myometrium and also the serosa. So the chances of the residual pouch forming, it's very much reduced. So to conclude, the post-caesarean uterine niche is relatively a newer clinical entity but potentially iatrogenic. Increasing caesarean delivery rates, the niche-related problems are predicted to rise. For AUB, hormonal treatment preferred initially. The subfertility, definitely it requires the surgical correction. The double-layered continuous unlocked suture, that is far and near technique, benefit from the isthmosil formation. And if the isthmosil is repaired either hysteroscopically or laparoscopically, and the myometrial thickness, if it is more than 5 mm, better we consider the elective caesarean section at 39 weeks. Suppose if the patient is conceived before the repair, it is better to deliver by elective caesarean section before 38 weeks. So the references. Thank you.
Thank you, Soumya. Oh, that was a very good presentation. Any questions?
The slide, if it is at the lower level, if the niche is located at the lower level, you can consider the vaginal root.
Yeah, if it is usually a cesarean scar, it will be in the lower level. And it is a very simple technique. And it is a technique that anybody can learn. Anybody who is able to do a cesarean. All you need to do is to go reflect the bladder anteriorly, and you feel for the uterine, you feel for the niche through a finger in the vagina, and then you open it up, make a complete opening, and then suture it up. It's as simple and easy as that. People who don't have access to endoscopic surgeries or who are not very comfortable doing it, this is simple and equally effective technique.
Yeah, it can be done, and it's been mentioned also. Then you made a point that if the patient, even if the patient is infertile and the niche is asymptomatic, don't need to do anything, regardless of what is going to happen in pregnancy when she conceives, right? Okay, the other thing is, what about the decidua? Because there is a statement that you didn't mention it, that including the decidua can cause a niche. So you've done quite a lot of referring for this. Did you come across any statement regarding that, inclusion of the decidua? Take the mic, dear.
Even in ISHRA, it was telling decidia should be included while closing.
Because earlier, decidua was not included.
Not included,
But now decidua is included. We need to make a few statements about all this, that second stage cesareans are very common. You can easily get a niche in a second stage cesarean. Second thing is, if you do a cesarean very low, if the incision in the uterus is very low, again a chance. Single layer, definitely you can have a niche. So we need to dissuade our people from doing a single layer cesarean just to finish it fast. Thank you, Soumya. That
the
was
most
very
important
good.
is diagnosis is very important.
Diagnosis is very easy nowadays, very easy. Imaging is so helpful. Can you just mention about the far, near again, because that video was a bit too short for us to grasp it. Just mention how you do it with your hands. Don't have to open the video again. You stand near the mic, dear. Yeah.
Suppose these are the uterine edges, you have taken the incision here. We start closing from 0.5 centimeter from this line. The first one is we take it from the deep. Suppose if it is like this, the first is we'll take it from the below one, and the second one is also come, and the third one will the top, maybe 5 mm below the incision line, and again from here.
So you're going
out, deep
out,
and superficial.
Out, in.
Yeah, yes.
Then again out, in. Right, okay.
Deep and superficial, deep and superficial. Single, that's it, ma'am. That's it.
So that becomes like...
It should be taken perpendicularly. No, we have done for quite a number of cases.
Looks like a mattress suture, right?
It's a mattress
exactly.
Only,
so, but then mattress sutures...
She'll be doing single layer, not double layer.
No, agreed. Mattress sutures, earlier they were saying don't do mattress sutures because you are likely to increase necrosis in that region of the skull.
Sushila,
continuous non-locking.
Medicine is a cycle.
And
what
they
you reject today comes on the top tomorrow.
Decidua because you are increasing the chances of endometriosis.
That will come again after a few years. Don't do mattress. We'll wait till then.
It's okay. So it's continuous.
I have done for quite a number of cases.
The thing
maybe
is
yet to see the results, I think.
The thing is that here we are not doing second layer. You are included the second layer in the first suture. You're just saving time and also doing it effectively.
Somebody
maybe
thinks of this bright idea, and then think that's.
So the important thing, one more thing is no locking. Please remember, earlier we all used to lock, now we have stopped locking. So let us see whether our cesarean scars also have niches. Thank you, Soumya.
Thank you, ma'am.
Thank you so much.
Thank you.
Yeah?
Number one usually we use.
One,
Number one.
Two is too thick.
Number
one. Yes.
Upon our next speaker, Dr. Rajashri Paladi, ma'am. Ma'am is a director and consultant in obstetrics and gynecology at Aditya Multi-Speciality Hospital, Kalburgi. Her areas of expertise include high-risk obstetrics, infertility, and community services. She currently serves as the President-elect of KSOGA 2025-26, and she's an Honorable Secretary for the term 23-25. We welcome you, ma'am.
So you're looking at the next president of KSOGA. So hear properly.
Pranams, my respects to the chairpersons, respects to the audience and the delegates who are here to listen to my talk, and my respects to the organizers and wonderful conference that we are witnessing. At the outset, I would like to welcome you all to Gulbarga for the next KSOGA conference. So we are in an era wherein we talk of having the institutional deliveries. And we have seen that to improve the health of the woman and to reduce the mortality, we are insisting upon the institutional deliveries so that no woman dies while she's in labor. But it has the flip side as well, that because of this institutional deliveries, are we doing justice as to what is really required to the woman, or is it the motto that just to reduce the complications and to give better health benefits that we are asking to deliver in the institution? But there have been problems in the institutional deliveries as well, because we are not addressing the psychological and the mental issues of the women who are delivering in the hospital. And that is what brings up to the respectful maternity care that we talk of, that each individual woman is deserving the respect that she has to get, irrespective of what and where she is. So that is what is about the respectful maternity care. And this was noticed way back in 1970, and a movement ensured in all the countries across the world, like Canada, US, Brazil, who first noticed that there have been issues concerning about the respect for the woman, and thereby humanizing the childbirth was initiated. So United States was the first in 2010, the agency, that is the United States Agency for International Development, they supported the landscape, which was studied by Browser and Hill, and categories of disrespect and abuse were identified in the women who were in labor. And the WRA, that is the White Ribbon Alliance, they developed the Respectful Maternity Care Charter of Rights, and RMC survey by the Maternal and Child Health Integrated Program, they further propagated it. Now what does respect mean, or what are we issuing, or the address that we are having at hand is to maintain the dignity of the woman who is in labor. We all have seen the labor wards when we were in the postgraduate days, the amount of screaming and shouting which was happening from both the ends, even the patient and even the healthcare providers like the ayahs, the sisters, the nurses, etc. So maintaining the dignity of the woman, maintaining and having the informed consent. There's no longer the forced treatment protocols that we are giving, that you have to have the consent of the woman to maintain the privacy and the dignity of the woman, to have the freedom from harm, to give a supportive care, and to have the accountability of the treatment that you are providing to the woman. So RMC is a universal human right issue. Actually, this is nothing to do with, I think, not much of the obstetric scenario that we are talking of. We are talking of what all we have developed over obstetrics over a period of time in the 100 years since the first ANC protocols were started in New York. It's only in the past century that we are talking of the institutional delivery and having a protocol for the antenatal care. But as an after effect of all this antenatal care is the respect that we have lost to the woman, and herein comes the human rights for the woman who is delivering and who is in labor. And this is the serious concern of issue, because just last week I met a doctor who is a successful IVF practitioner who said that after my first delivery and the trauma that I went through because of the ANC and the delivery, I decided not to go for the second pregnancy. And this is happening with the highest qualified individual in our country, like obstetrician, and we can very well imagine what happens to the women who are not educated as well. So what we are addressing is the human rights and the psychological impact that the woman can have just because of being pregnant, for which she was not at fault at all. So it's a universal human right focused on ethical, interpersonal aspect of the maternity care that upholds the woman's right throughout pregnancy, childbirth, and postpartum period. And the woman's memories of childbearing experience is a lifetime memory. I'm sure all those women who have delivered would definitely remember the moments which have happened in the labor room and therein after. So women's basic right is to have their autonomy, dignity, feelings and choices, which is very much ignored or which is very much subdued, and it is very much snubbed off, saying that yes, this is how it is going to be and you have bear with it. So the tender loving care extends way beyond of what we are just talking of during the ANC period, and the right to have a companion during delivery whenever possible is one of the important integral factor. So the woman who get pregnant should have a basic human right of human evidence-based maternity care, which ensures throughout pregnancy, birth, and postpartum period, motherhood is to give a positive, fulfilling experience, which many women still associate with suffering, ill health, and even death. And we have seen a good number of patients who have gone into depression, and we have also heard of suicides which were committed as an after effect of having a very torturous labor. So the maternal and newborn care must be integrated, and these are both closely linked, and it upholds the choices through the supportive care and communication. And what remains very mandatory and basic component is the communication, and to make them understand that what it means to have a respectful maternity care. Identifying and addressing the mistreatment is the key to promote the respectful maternity care. So no harm basically is to be ensured upon, and no ill treatment to the woman who is in labor. Many evidences of physical abuse have been reported all over the world, and I'm sure those who are above or in their 60s would very much agree to the amount of abuses and the physical harm which was caused to the woman who was in labor, especially in a busy maternity ward in the government setup. So every woman has a right to information, informed consent, and respect for the choices, including the companionship. I, as a mother-in-law, have gone through this phase when my daughter-in-law said that she has a right to choose where she wants to deliver. And yes, I agreed to her way before I did my presentation, and I'm glad I agreed with her. Every parent or a guardian has a choice to receive the information and provide informed consent or refusal for newborn's care, best interest unless otherwise provided by law. And there is a right to the privacy. They must protect the privacy and confidentiality of the patient and not go on discussing of what has been transpired between the obstetrician and between the patient. And violations of privacy and confidentiality include the lack of privacy in labor ward and information status, especially the HIV-related or the viral disease status, the marital status, the medical history where other people can hear. This also violates the respectful maternity care, and nowadays we see that many women, especially in the West, who choose to have the babies even outside the marriage, and their integrity of their status has to be maintained. Importance of record keeping so that it helps to provide better care in the next pregnancy, and maintaining the client record is very essential so that it can be passed on to the mother and it will be of reference, invaluable reference for the next pregnancy as well. So every woman has the right to be treated with dignity and respect, and this is an understatement because it goes without saying that respect is a basic fact of human element for everybody. The gender-sensitive and respectful care and treatment ultimately improves the healthcare outcomes and brings a positive impact, because this positive mindset is very essential for a mother. The woman who is unhappy, how can she spread happiness to the baby and to the surrounding? And this itself has a lot of psychological impact, and we have seen that there's a decrease even in the lactation in a woman who has been distressed. So every woman, every newborn, everywhere has the right to good quality care. What do you mean by disrespect is physical abuse, non-dignified care, non-consensual care, non-confidential care, discrimination or abandonment of and withholding of the care, and detention in the facilities. So tackling disrespect, there are 7 rights of the childbearing woman. These rights are grounded in the international human rights, which include the Universal Declaration of the Human Rights, Universal Declaration of Bioethics and Human Rights, Convention of the Elimination of All Forms of Discrimination against the Woman. So equality for all. We see that in some of the busy institutes, especially in the government, there's inequality of the treatment care which is provided, and also in the Western world, wherein the black colored skill are totally discriminated. I just came back from a visit to the Western world, and I have seen that how the discrimination can take place at the subtle level, and you can very well imagine what happens in the labor ward when the woman is in distress. So all women are equal. They must be treated with respectful care, regardless of the background, regardless of the caste, creed, culture, educational or economic standards. Professional health care to be provided to all the women who is in labor and not discriminate between the high socioeconomic and the low socioeconomic, and whenever possible to be conducted in a clean, safe environment and by the best trained in the practices. So examples of abandonment, who are the women who are abandoned, who are in labor, is that in the facility being left unattended, not receiving any medical attention. Okay, you have had many deliveries, you will deliver this last time, you delivered at home, now sure you will deliver in the hospital. That doesn't justify us for giving the withholding of the treatment. They may be denied with a birth companion and providers failing to monitor the woman in labor and intervene in life-threatening situation. So no one can detain the woman who is in labor, and she has the liberty to take her choices of the freedom and arbitrary detention, and no one is allowed to detain the woman and her baby without legal authority in the healthcare facility, even if they can't pay for the service they receive. This becomes a very tricky situation, that even if they cannot pay, but you have the human values and rights to see that she gets the necessary treatment when she's in labor. And every child also has a right to be with the parent and the guardian, and the rooming in is always stressed upon. It has to be put together with the mother, and no one can separate the mother and the newborn without the consent. Even if the child is sick, make sure that the woman is told that the baby requires attention and the medical care before being shifted to NICU, and you just can't snatch away the baby and shift it to the NICU. And every child has a right to be having an identity and nationality from birth, and no one is allowed to deny the newborn of the citizenship. The food and water intake are not to be restricted, and denial of nutrition and denial of proper intake is also not a good practice, and demand the rights. So it is not about the right to give birth, it is about the right to receive appropriate care whenever the care has been given. Evidence on effective RMC interventions is limited, especially in the low resource or the conflict setting, but the women often experience one or two of the extreme. Either there is a very less care or over care given when they are in the institution. So this is a balance which has to be set in, and too little, too late, or too much, too soon is also not good, and they reflect upon the non-evidence-based practice, while many vulnerable women receive no care at all. Now, medicalized maternal and newborn care. What do we mean by that? The routine use of practices during labor and childbirth that are not evidence-based, that are unnecessary, unwarranted, are unfamiliar or undesirable to women, do not improve the health outcomes for mother or the baby, and may do harm, prioritize the needs for providers over needs of the woman, and encourage technology or interventions without proven benefit. So it is not a one carpet or a one rule for all, that we have to categorize what is the care that we are giving. Don't overdo it, don't underdo it. And common practices which are harmful are restricting the ambulation, lack of companion or family during labor, overuse of anesthetic drugs in the name of analgesia, administration of oxytocin too soon or too much, restricting the fluid and food. Routine episiotomy is now a matter of concern, and early cord clamping. Unnecessary routine episiotomies can reduce the maternal and neonatal morbidity if they are restricted to evidence-based indications as described by WHO in 2008, associated morbidity which can include the perineal damage or tear, and dysmenorrhea. So ethics of good practice is beneficence, non-maleficence, autonomy, and justice for the woman, and a normal birth should encourage her to be normal and have a positive control and skin contact with the baby after birth. Choice of birth position is also to be encouraged. It is not necessary to restrict her in the dorsal lithotomy position, and all the women in labor should have a support in the form of either a spouse, partner, family member, midwife, or a student trainee. And what is all involved? See, the pregnancy and the labor is not restricted just to the mother or to the family. There are multiple stakeholders to decide the outcome of a positive maternity care, and this include the healthcare providers, the training institutions, the policy makers and the donors, the human rights activists, and the women advocates. So several challenges can be overcome, and women who lack education about their rights, the informed consent and importance of respecting their choice is to be made sure. Not that she can have a choice of whatever comes to her mind. It has to be communicated to her very well. Counseling has to be done and told about the good and bad of the choices that she takes. So respectful maternity care means no discrimination. There has to be autonomy. It has to be timely, safe, maintain the secrecy, maintain the dignity, Target of the quality care should be this, and preventive, promotive, curative and rehabilitative measures are in the form of continuum care and no abandonment and no financial hardships, because no informal payment, no detention at the facility for late payment, these are also to be taken care of. And ultimate goal is that it should be the core goal for all healthcare providers and health system, and supportive measures for the women. The behavioral aspect comes into a lot of play here, and this is what will make the maternity care a very comprehensive management. It's not just about preventing the complications, but it is preventing on the impact which is going to be on the woman's mind for a long time until her death. Thank you very much for the patient hearing.
Thank you. You did a perfect landing, you know, and being the next president, you've set a very good example.
Thank you, ma'am.
Excellent.
Thank you so much.
Any questions from the audience? Any questions?
This is more like a moral science and the social addressed to the women of all that we are as an obstetrician and gynecologist doing practice, but ultimately not to forget the basic goal that we have to be humane in our approach to the woman.
Yeah, I think he has a question there.
Madam, very good, excellent, and need up the talk.
Thank you.
Just one suggestion. Being I'm in a medical college, I want to bring to notice that respectful maternal care has been started in all government hospitals. Everywhere. It is in the name of Laksha.
Yaksha, yes.
All birth companions are allowed inside the labor room, but only is there in all medical colleges it is difficult to allow male attenders. Everybody is allowing female attenders with respect their choice, their mother, mother-in-law or sister, anybody. One person is being allowed nearly since 2016 onwards in our college and others also. It's mainly done by National Laksha program.
Correct, sir. India has a long way to go in terms of allowing the main companion, because a lot of interactions have to take place between the care provider and the recipient and the attenders, that not many women are comfortable to have the male along with them. But if they understand the outcome and the bonding which increases in the couple by having the male partner in the room is definitely a way forward, because partnered parenthood is the way now that all the youngsters are following.
This is allowed in Laksha program,
Yes,
madam,
yes,
but
yes.
because of lack of facilities, multiple patients,
Yes.
it's difficult to allow male attenders.
And privacy of the other woman who is in labor, because you know it's a general ward in the general labor room wherein 5-6 labor tables are there
very
parallel.
true. In private hospitals, I
They
think
do
they're
allow.
doing it
We
nowadays.
do allow, yes.
But
They're doing it
is
regularly, but
allowing a male attendant inside is difficult in government hospitals,
it is not
because
possible.
15 to 20 labor patients inside, and allowing a
Yes.
male is difficult.
Absolutely.
And the second point, in government, there is no payment, including OPD sleeps till delivery, pediatric and OBG sections. There is no payment, except
see, when you say no payment, it is
It's
not
not
on
on our
paper.
hospital, it's
It
all
is
government
on-
hospital.
No, it is under the table. It happens everywhere. Everywhere it is happening. We are
Well,
noticing.
see, healthcare is the
No,
basic.
just I want to say
Healthcare is the
government,
basic provision
it's not
of the
government are doing best.
Doctor, let
we are
me
watching
clarify on this. The two main concerns to be provided by the government is, one is education and second is health. So healthcare has to be mandatorily free for all the tax-paying or every responsible citizen of the country. But then it goes without saying that there are many undercurrents which occur there, which are not in our purview in every center in the world, not only here in India.
I want to know which colleges.
Just to shift the table, the patient from the labor table to the ward.
Sir, you're
That
from
is
which
not-
college? Do mention, sir.
Gadag
Which?
Medical College, madam.
Gadag Medical College. Thank you, sir.
Yours is an ideal hospital. Very good. We are very proud of your Gadag Hospital. But we know in Bangalore, we can only talk about Bangalore. In Bangalore, we know in government hospitals to give a bedpan, to take out the bedpan, to shift the patient, to show the baby, not just the fourth class, even the obstetricians have been known to
Doctor
take.
categories.
I'm not joking.
As per the rules, it is not
Yes,
allowed,
it is
madam.
wrong. But then, you think everybody follows the rules? Are rules being followed in offices?
Ma'am.
Don't you think they take a bribe for every small paper? file
Doctor,
to
in
be
India,
moved?
the rules are meant to be broken.
Exactly,
Madam,
exactly.
if you are thinking that means we
is
can't
very
talk
sad.
about it, madam.
No, we are not thinking. We are being practical. We are being, see, definitely, as we all know, that the healthcare is the basic requirement and the basic right of every individual of the society in the nation. 100% it should be free, and that is what is being told, and that is what we are giving. Okay, it's good. It goes without saying that.
Yeah. But it is going behind the screen.
Doctor, yes, behind the screen,
That's
not
what
on
we are
paper.
telling.
Anyway, it is beyond our control, so let us not discuss the issue.
And we don't justify that behind the screen. It's sort of.
And we can't
Rajeshri,
even
I must
stop
say it was an
because they're like
excellent talk.
Thank you.
bandicoots.
Thank you so
They're like
much.
bandicoots. Thank you. And,
Thank you.
Shall we close this session? Okay. I thank the organizers. Yes, thank you, Rajeshri.
Thank you, ma'am.
Thank the organizers for giving us both a chance to chair this very interesting session. We'll close it. We have time for a very short tea break and come back here at 11:15 for the plenaries. Allah.
Ma'am, I request all the chairpersons and the speakers to please
Thank you
move
so-
to the chairperson for KSOGA. Okay. Sorry, ma'am. Okay, I would call upon Dr. Hanmantvi, sir, who is a professor and head of the Department of Obstetrics and Gynecology at K.H. Patil Institute of Medical Sciences, Gadag. He has held several notable positions, including HOD and past secretary of GOGS and secretary of the Kannada Sangha at KIMS Hubli. He also serves as the chief editor of the GOGS and Nandadeep Bulletin. We welcome you, sir.
Good afternoon to respected chairpersons and Dr. Ashwin Madam and all the faculty. First of all, I would like to thank Tumkur OBG Society and Siddhartha Medical College and KSOGA for giving me an opportunity to participate in debate. Today's debate, we know it is myomas in infertility, to operate or not. Here is my duty to present what is physiopathology and evidences. Madam will say their version, and it is up to you to decide which is better. Our questions will remain like that only, or partial answers will be there. We'll see at the end. Coming to the myomas, these are benign uterine tumors. Around 20 to 40% of reproductive age women will suffer from uterine fibroids. Among them, nearly 5 to 10% of infertility cases have direct or indirectly affected by fibroids. So, how they will affect for infertility? Mechanism, most common is distortion of uterine cavity. Once it distorted, it will interfere with normal rhythmic uterine contractions, impaired implantation, and there is a greater distance for sperm travel. It may encroach on tubal ostium, so occlusion may be there. If it is compressed, blockage may be there. Not only that, altered contractility will result in difficulty in sperm and embryo transport. Vascular and inflammatory changes will occur inside the endometrial cavity, that is junctional zone. It will end up in poor endometrial receptivity, impaired implantation, abnormal endometrial maturation, and alteration in oxygenase activity. These are the pathophysiologies. What is books is given that now. What evidence will say? Before going to evidence, we'll have a little bit look at the fibroids, Pigo classification. Submucosal fibroids, that is 0, 1, 2, have major impact. Whereas intramural fibroids, 3, 4, 5 have moderate impact if they are more than or equal to 4 centimeter. Subserosal fibroids, that are 6th and 7th category, have minimal effect. Whereas pedunculated fibroids usually have minimal unless cavity distorted. Coming to evidence of submucosal fibroids, Richards et al. Study says that submucosal fibroids are the most detrimental
and their removal improves reproductive outcome. Number of cavities in the host myometrium decrease in case of myomas. It may affect calcium metabolism, thus by raising the intracellular calcium. Hence, myometrial irritability and hyperactivity will be there. Disruption of the rhythmical contraction process of junction zone will be affected. And another study, 2008, says submucosal aoma have global decrease in endometrial Hox gene expression, which is a molecular marker of endometrial receptivity. 2007 study says, that is IVF model, shows that patient with fibroid distorting endometrial cavity have impaired implantation and pregnancy rates. Many other studies like Donage et al., Hart et al., Kalof et al. Studies says that large intramural fibroids more than 4 centimeter reduce IVF implantation and pregnancy rates. Myomectomy restores success rate. Another study, fibroids that distort the uterine cavity are going to impair implantation and pregnancy outcome. Hence, myomectomy will improve the fertility. Whereas, evidence also says that subserosal fibroids have minimal effect on infertility. Surgery is not routinely needed. These are review studies. Donage et al. 2004 says that distorting the uterine cavity, which are not distorting the uterine cavity, and control group clearly says that when fibroids distort the uterine cavity, there is a less fertility rate, pregnancy rate, compared to not distorting and control group. Even submucosal myoma also shows that implantation rate, clinical pregnancy rate, and spontaneous abortions are more, where implantation rate, pregnancy rate are less compared to control group. Coming to the multiple small fibroids, even less than 5 centimeter, also have impact on pregnancy rate, ongoing pregnancy, and live birth rate, which are less. Even after you are going for IVF, that will also shows that lesser pregnancy rate. These are studies showing that among these only one study shows that little bit variation, but rest all the studies shows that lesser pregnancy rate after IVF. Even after conception, miscarriages are more in fibroid uterus when you are doing IVF. So, after seeing all these evidences, researches, analysis, RCTs, we come to the conclusion that myomectomy will restores normal uterine cavity. So, it improves implantation rates, it enhances spontaneous conception and IVF success. It allows full-term pregnancy. So, these are the evidences, pathophysiology, what bodies will say, particularly RCOG guidelines, Green Top guidelines, ACOG, and our POXI. Which are the fibroids needs surgery? Submucosal fibroid, if it is more than or equal to 1 centimeter, needs surgery. Intramural fibroid, more than 4 centimeter, are distorting the endometrial cavity, needs surgery. Multiple fibroids with cavity distortion needs surgery. Symptomatic fibroid in infertile woman, repeated palliverse is there, needs surgery. Coming to the evidence supporting, prospective study bulletin et al. Says that 43% pregnancy after myomectomy. Even RCT trial Cassini et al. 2006 says pregnancy rate increased from 27 to 43% after myomectomy. Meta-analysis of Priest et al. 2009 says increased conception, live birth rates after removal of submucosal or cavity distorting fibroids. These are specific guidelines says RCOG guideline Green Top 2017, myomectomy improves fertility in cavity distorting fibroids. ACOG 2021 says consider myomectomy before ART when cavity is distorted. POXI 2022 says it recommends myomectomy for infertility with symptomatic and cavity distorting fibroids. ASRM Practice Bulletin 2021 says myomectomy is needed for submucosal and cavity distorting fibroids even before ART. We think that only surgery is there, other modalities also there. Okay, we'll have a look at other modality, medical therapy. Evidence says it is temporary. Recurrence is common. Urinary embolization is there. It will says it will decrease ovarian reserve, so it is not recommended. Hence, myomectomy restores fertility, so best evidence. I want to re-say, myomectomy restores fertility, best evidence, so myomectomy is needed. In summary, fibroids distort uterine cavity and reduce fertility, where myomectomy restores uterine function and improves conception. It is supported by major guidelines and meta-analysis, so it remains gold standard for selected infertile women. In conclusion, in properly selected infertile women, myomectomy significantly enhances fertility outcome. So, myomectomy remains the definitive treatment for cavity distorting fibroids. These are my references for evidences. With this, I will give further evidences for other version of this one. Dr. Rasmi Patil, madam.
I now invite Dr. Rashmi Patil, ma'am, who is a senior consultant in obstetrics and gynecology at Apollo Hospital, Bannerghatta. She serves as the quiz committee chairperson for KSOGA 2025-27. She is also a joint treasurer of BSOG 25-26 and a FEC member of BRCOG 23-24, in addition to being an RCOG online faculty. We welcome you, ma'am.
Thank you, respected chairpersons. Thank you, Hanuman sir. And thank you for asking me to argue some points with you, sir. So first question to begin with, how many of you have dealt fibroid and pregnancy? Please raise your hand, including you, sir. Yes. Okay, you have not seen the others. Have you seen or no? Fibroids in pregnancy, everyone? Okay. So let me start regarding whether infertility, are we supposed to operate or not? And me being a laparoscopic surgeon, saying not to operate is a little bit, confusing, I must agree. I bring greetings from Apollo Hospital. Let me tell you the first case scenario, a gravida to abortion 1 with 6 weeks, 5 days pregnancy. She is having 3 fibroids, Figo 3, 4 and 7 with sizes 3, 6 in the anterior lower segment and then right lateral and fundal. She was advised to undergo termination of an ongoing pregnancy which was heart rate was positive. Second, a laparoscopic myomectomy after that, and then 6 months to 1 year, give a break, and then followed by conception. And if there is any difficulty, please come to me, I will treat your infertility. I mean, like, what scenario are you creating? 2 years down the lane, is she going to think about becoming pregnant again? Is this really required? No. This patient, I did counsel to continue, and she delivered 3.5 kg of a healthy baby. I had to do cesarean because the lower segment was not allowing the engagement. Now, can fibroids cause infertility? Yes, sir, I do agree on this. Can all fibroids cause infertility? A big no. Do all fibroids need removal? A biggest no ever, I could say. Now, let me see evidences. I am taking some evidences almost 15 to 20 years from what sir was discussing about. These are also recent evidences which are supporting your say, sir, that fibroids may be the sole cause of fertility in 2 to 3%. I will take the positive aspect. Fibroids are not the cause in almost 97 to 98%, right? If we see this condition, they are not the cause. So I'm looking at the positive aspect of it. And depending upon the location, as sir discussed, I wouldn't be telling more about the FIGO and all. And pregnancy and live birth rate appear to be low in women with the submucous. I do agree with that. Resection has been shown to improve this. In contrast, subserous do not affect. Intramural do not affect to a great extent, but recommendation you should individualize. Myomectomy should be discussed individually with the patient all the potential risks and benefits and other symptoms apart from the fertility, and then only when she agrees we are going to go ahead with that. As we see, being a laparoscopic surgeon, myomectomy, one of the, I think, most commonly operated surgery. And now with laparoscopy, robotics, everything, people wants to try hand on even the tiny, teeny fibroids which are present. So one of the most commonly encountered findings on the scan also, only next to the over-reported or abused PCO that we see. Now let us see some evidences which are there. Severe symptoms may develop in only 15 to 30% of cases, and the extent that it depends only on the fibroid location, number, and size. So if you are seeing this, 70 to 85% of people, they are not related to this. And even the uterine fibroid related fertility in 2024, they have told that it's a kind of fertile battle everybody has. And not all myomas are going to behave the same. And International Federation, even that has told that consider first the location again on the similar grounds. Even meta-analyses are also supporting the same. The impact of management of fibroid for fertility, which was again published recently, they have told that they are present in 5 to 10% of infertile couple. Again, I am taking positive, 90 to 95 do not have, and sole reason amongst them is 1 to 2.4. Again, if we see, 98% are in my favor. Now, risk of obstetrical outcome, if you are seeing, preterm, malpresentation, placenta previa, abruption, cesareans, all these are present, PPH also, and even the retained placenta. Let us discuss the cost of myomectomy now. If you see 1.2 to 2 lakhs, almost, right? If we go for an open surgery or a laparoscopy, or now the robotics also is pitching in, so almost 2+ lakhs it's going to go there. Who is going to arrange for that? And almost all the women with symptomatic fibroids, they initially try to choose some non-surgical, and most of them do benefit from them. So if you are looking at the other aspects, we have options, as sir discussed. There are other medicines that are available, though temporarily. It may benefit when they are trying for pregnancy. Once pregnancy is there, fibroid doesn't go, baby grows, everything is fine. There are ultrasound energies that are there, radiofrequency ablation, and KSOGA is supporting me in this debate. I'll tell you why later. Or they may even opt for hysterectomy later on. Cochrane reviews have also told that you can include treatment. It may benefit to a certain extent with the other symptoms, and if you're considering fertility, a short term followed by later doing the fertility treatment, you may not be even requiring to remove the fibroid as such. Even reports have been there for uterine artery embolization and then following successful pregnancy outcome. So why do we need to operate? There is a huge mental stress. Is this really required? The burden of undergoing surgery, the family commitments, the professional commitments. I have to take a leave. How many days should I take a rest? Post-operative recovery, when I'll be going back to my work. What is the time gap again? 6 months to 1 year, depending on the scars that we are creating on this uterus. Mode of delivery definitely changes. Trial of labor can be risky, yes. Do you think risk of uterine rupture is going to be there? Definitely. Is this additional stress required for us, both for the patient and for the obstetrician? I don't think so. How about the recovery, the leaves they're going to take? Caregivers have to compromise so much. Mental exhaustion is there. Everybody's quality of life starts getting affected. And at what cost are we getting these additional things if I see? Whenever they want to plan a pregnancy, you have to wait for the uterus to heal. How long? Nobody knows. Can we define an absolute criteria for this? No. Now let me tell you that how many miscarriages have we seen which is absolutely and purely attributed due to the fibroids? And what about the correlation of location if we see? If you're looking at all the FIGO classification, how many are these components are there in the submucous? Majority are intramural, they are not distorting the cavity as such. Let us see her pregnancy journey then, and how many cases of growth restricted are we seeing? There are like 2.5 kgs, so many babies are normal for the Indian growth as such. And as I gave an example, even 3.5 kg with 3 fibroids, she has delivered a healthy baby. And can the location of placenta play a role? Can you define that next time when you're going to see the placenta is going to sit only on the fibroid? No. It can go and sit anywhere and gets its nutrition adequately. Uterus is such a vascular organ. And 2.5 kg, as I said, it's very much common for us. Should we blame the fibroid for this? Don't all these babies do well? And what about the labor? Challenging vaginal birth, if lower in the location, yes, it could be there. Risk of PPH. Aren't we trained sufficient enough to PPH? Yes, we are. Challenges during cesarean, customize your incision on the uterus accordingly. And at the same time, if you're doing cesarean, you can opt for cesarean myomectomy also. Why simply do 2 surgeries and later on, have the risk of rupture everything. And in the era of cosmetic gynecology, being a trained cosmetic gynecologist, I would say that a scarless abdomen versus minimally scarred abdomen also, what is your preference, please? And as I said, KSOGA is helping me in this. Look at the workshops that they have conducted. They are telling you, do the cesarean section, learn the art of preventing PPH, do the CTG proper workshop, do the cosmetic gynecology, do the hands-on microwave ablation. Why are we all concentrating on this? To prevent surgery, right? So if we are looking at all these points, we have to consider, is it really required? And I would say guidelines are made to guide us. It is not a 100% plus and minus rule. You have to customize your treatment options. Not all fibroids affect the fertility. Many women with fibroids do not experience infertility and their ability to conceive is not affected. The evidence is every one of us have dealt with a pregnancy and fibroid and a successful maternal and the fetal outcome. Location and size, they are the key. The specific type of fibroid, size, location of, these could be the main factors, yes, but please customize your treatment options. It is not recommended to undergo full fertility evaluation. Don't we think about all other options and then blame the fibroid? Rule out all the important causes first and then only subject. She is going to have an anesthesia. She's having that risk. She's going to have an operative risk. So if you're going for a surgical modality, it should be the last one. And I'm saying this because even I practice laparoscopy and fibroid removal. So keep it last. Let us upgrade our skills as an obstetrician and as a gynecologist to handle these fibroids well. Let there be surgeries only when there is applicable and there is a proven cause for this infertility. Let the uterus grow the babies properly once they conceive rather than the fibroids that are growing. It is given an option. And do not please try to scar and then try to heal, put your Surgisil, everything. Consider this as a last option. And an uncut uterus is the best uterus that will say thank you to you. Thank you so much.
Thank you so much, ma'am. That was an enlightening session.
Yeah, sir, you have anything to say? Yes, sir, revertal. I call you upon for revertal.
I agree with your first case itself only. I will never advise when pregnant woman is there, terminate it and operate it. When nature has given, we'll allow it. If it happens mishaps, then we'll see. With that one, I want to add my experience. Anyway, I am not practicing so much IVF. I am also laparoscopic surgeon. One patient had given ovulation induction, fibroids less than 3 centimeter. And she has gone some other places, she has conceived, and she has been 14 weeks. Our IVF person has told, better to undergo abortion and operate. And she has called me back. I told her, when nature is the same word, please wait and watch. But Madam case, it has ended a good result, but in my case, 21 weeks she got aborted. After that, he has sent her for lap myomectomy. After that, now she is 36 weeks of pregnancy in Dharwad. And another thing, my opinion, Madam opinion is same only. She has told 2 to 3%, I had told 5 to 10%. Her own side itself, it was there, 5 to 10%. I am not saying that all will affect. Only 5 to 10% will be the effect. And opinions, evidence will be variable. It's not 100%. I told with location, subserosal fibroids will not affect. Don't worry about it. And cost. If fibroid is there, you are going to send the patient to IVF. I don't know IVF how much cost is. Anybody can IVF cost how much will there is to start?
So not every fibroid patient will
No,
go
you
to
are
IVF.
sure, madam. Just 2 minutes time I will finish at that. Madam told 1 to 2 lakh for hysterectomy. IVF will start minimum 5 lakh.
To 1.2 to 3.
No. If you take the surgery also, myomectomy I will do in 15,000. That doesn't matter. Hospital staying, their respective cost, repeated this one, and beyond that, stress. Of course, surgery, stress will be there. When woman, if you ask infertility woman, stress not only she is having stress from husband, grandmothers, grandparents, including their parents will have a stress, and that as if she is the only responsible person for the infertility, and husband will next month or next day he will plan for another marriage. That stress is more, or avoiding surgery is more. We have to think of it. Yes, we agree with madam, not all fibroids cause infertility, but those distort uterine cavity will surely need myomectomy. Several analysis, madam herself has told, myomectomy is needed for particular cases. Madam has shown surgical risk are real, stress is real, but low in experienced hands. Modern laparoscopic and hysteroscopic techniques which will minimize adhesions and blood loss. P.C. Malhotra sir was just 1 hour back, he has told, operator should not be there. He should become surgeon. When surgeon operates, these complications will be less. Means skilled hands. Delaying ART may be short term cost, but restoring uterine anatomy prevents repeated IVF failures. As madam also accepted, medical therapy is short term therapy, and recurrence risk can be managed properly with proper technique and follow-up. So, my take-home message is, not all fibroids. In carefully selected, surgeons, experienced surgeon's hand, myomectomy is not excessive. With the stress, with the cost, it is essential for restoring normal uterine function and achieving pregnancy. With this, I will conclude my words.
Thank you, sir.
Thank you, sir.
Now I request Dr. Rashmi Patel to.
Yes, sir. So,
revert.
sir also has proven some of my points, and I would say that many of the hospital chains now 75,000 plus IVF, all the packages are also available if we see. And if I have to refer any myomectomy patient at 15,000, I'll definitely send to sir because he is going to do the best and at the low cost. But having said that, these are the same people who are going to take care of her when she gets operated. Do you think they are going to provide all this? Who is going to bear the cost? Will all these people are going to bear the cost for her? They may try to blame her. And if you're giving some medications, what medications are we thinking about? It are all the hormones and all which are going to shrink. Once it shrinks, she gets pregnant. The pregnancy itself is providing those hormones to control the fibroids. There are rarely some incidences where fibroid undergoes some degeneration or something. It's like less than 1%. And yes, as sir said, the myomectomy has shown a successful outcome for the previous aborted case. But if we see, every one of you have dealt with the fibroids and pregnancy, where successful pregnancy till 40 weeks also we have seen. So submucous, yes, I do agree for sir regarding the cavity. It should be normal. The home should be good for the baby to grow. But at least allow the baby to grow. See whether the uterus is capable. Do not label her fertility problem due to fibroids just by seeing that, okay, this is 3 centimeters, even 1 centimeter, come on. So you have to see which one is causing. Do not label, extensively work up for the cause of fertility. When everything is ruled out and nothing is left, and you see that submucous fibroid, then only label her as fertility problem due to fibroid. Thank you.
Yeah, very nice. Now, just for fun, we'll go for, voting from the audience. Ready, audience? Yeah. Now, you can raise hands for both and not raise hands for both. You can choose to do that.
Nota.
Yeah. Yeah, you have the right. Your rights are reserved. So now first, contestant, Dr. Hanmant Patel. You can raise your hands, whoever is for. And Dr. Ranjita, please help me counting.
We have one more year.
Okay. Yeah. Now for Dr. Rashmi.
Sorry, all lab surgeons.
Yeah. So my judgment is both of them argued very well. And everybody knows surgery has limitations and medications has its own pros and cons. That is why OBG, which was a surgical specialty, is converting into a medical specialty. Even for ectopic myomas, which were treated surgically, now are treated medically. So I declare with the doctors like this, patients are the winners.
Thank you, ma'am.
It was indeed a very, what do I call it, excellent presentation by both of you. I think the thought that we all need to, the message that we all need to take from here is submucosal fibroids more than 1 centimeters, if it is picked up, when the woman has come for fertility evaluation, when you have made sure all other factors are normal, I think we should go ahead and operate and then get her pregnant. Of course, with hysteroscopy and the expertise by doctors like you and other surgeons, hysteroscopic surgeons, the results will be excellent, rather than the woman getting pregnant and then trying it on her, knowing very well she had a submucous fibroid, and she got pregnant, she had a miscarriage. That could be very traumatic for the patient and the family, especially with a long history of married life. And it has been very, very clear that submucosal fibrosis distorting the cavity needs surgery. And of course now, if they are not planning to get pregnant with submucosal fibroids, of course the newer drugs like mifepristone could be tried to reduce the bleeding and a decrease in the reduction of the fibroid size.
So, madam, one figo will go to sir, remaining all figo will come to
Yes. Both will share. Yeah. Thank you so much.
Thank you, ma'am. Thank you, sir. It was a very interactive session and it was a very informative session. I request the chairpersons and the speakers to please proceed to the wall of gratitude for a picture. I now call upon Dr. Jeevan sir to take the further proceedings.
Good afternoon. Kindly don't leave. For our next session, our chairpersons designated ones are, Sunday afternoon they've left. So now I request our scientific advisor, Dr. Jyotika Desai ma'am, to be the senior most chairperson. Ma'am, please. Then I request Dr. Indra Shivanand ma'am, HOD, SSMC. Ma'am, please do the honors. I request Dr. Dwarkanath, ex-HOD and Professor SSMC. Sir, please join us as a chairperson. And I also request Dr. Nagesh sir, consultant, Janani IVF Center, as chairperson. Sir, please do the honors. I request the MCs to take over and introduce Dr. Subhash Malli sir. Please stay back.
We have our first speaker, Dr. KSOGA Conference, sir, who is a distinguished consultant at Baby Memorial Hospital, Calicut, Kerala. He has served as the chairperson of the endoscopy committee.
Very warm good afternoon to all the people assembled over here, respected chairpersons and the organizers of this event. Thank you very much for this wonderful opportunity. Well, we bring myself and next speaker, Dr. Fesi, we bring warm greetings from Calicut, Kerala and from Cochin. It's a need, even if there are 5 or 10 of us on a Sunday afternoon, I think it's very, very lucky enough, because I think education is something which matters and we are here to impart our education and our system. These are my credentials and what are my gum greetings, and one of my career highlights till now is been to get a postgraduate super specialty degree in the field of endoscopy. And I'm very, very happy to say that I'm the first in the country to start this course of FNB, in which we have this degree which is recognized by the NMC. And again, the left is the EAGLE project. I'm the national coordinator for the EAGLE project, which is actually every aspiring gynecologist should learn endoscopy in the postgraduate level. So I think we do not have much of exposure in the postgraduate level. Hence, we have been to 260 medical colleges in this, 160 medical colleges in this country till date. In the last 1 year, in the last 9 months, where we've gone and taught endoscopy on a one-day training. It's all expenses paid by us. Coming to the topic per se is laparoscopy complication and its prevention. The word prevention is a misnomer because you cannot prevent many things. These are all something which happens by the act of God also. So why laparoscopy? I'm not here to sell laparoscopy to you because I know that laparoscopy is something which is actually accepted by most of the patients. But of course, cesarean section is one thing which we cannot still be able to be done by laparoscopy. We have a better recovery, we have a shorter stay, we have less post-operative pain, low blood, and of course a scarless abdomen. So these are the advantages that we have in here. Now, how common are complications? It depends on the expertise of the surgeon and of course how much of experience that you are. It's almost for every 1,000 cases, we have about 3 of these cases, 3 to 6. But of course, most often than not, 1/3 or 1/5, almost about half of 50% of these problems are basically when you enter. If you enter into the abdomen safely, I think half of your worries are over. So I think the entry techniques are very, very important for us to understand. But if you ask me which is the best entry technique, I wouldn't have an answer for the same. It's one in which you're comfortable with. Okay? There is no clear cut and what I'm doing is right and what you're doing is wrong. No. The fact again remains that whatever is good in your hands, which you're comfortable, go ahead and do that. Risk factors, there are a few risk factors like, morbidly obese, prior surgeries, pelvic infection, bowel distension, adhesions, cardiopulmonary. As and when you go in from the government sector to the private sector, the contraindications come down because anesthetists are very, very flexible in the private sector and very, very rigid in the government sector. This is what happens. Of course, in a medical college also, they are very rigid. I have anesthesia friends also, so do not worry about it. The fact again remains again is that the more and more number of cases that we do, the more comfortable, more better that we become. Okay. Now, complications, it could be position related, access related, new peritoneum related, surgery, and more importantly, post-surgery also, right? The lithotomy is what we normally give, but you could give a good pad because we do not have a common peritoneal nerve palsy or a pain across. So always give a good thing. Now, access related, I will say universal steps for safe access. The question is, do you have a universal step for safe access? I believe it's a very, very vague thing, All you can say is, a good anesthesia team, a relaxed abdomen, empty stomach, empty bladder, prepared bowel, experienced team, and excellent equipments. But what I will give more importance is the man behind the machine. It's not just the thing, the man behind the machine that really matters. Man here means women also, please. So do not consider me to be a sexist comment over here. Varus needle is very, very important. The first thing that we do is, I would not be here teaching you how to put a varus needle, but all I would like to teach you is that what precautions that you. Whenever you put a varus needle, the first thing that you need to do is always decompress the stomach. Because many a times it is the junior PG or the junior assistant who will actually bag and mask. With the private side, it's okay. A lot of air goes into the abdomen. The moment you put it, you can do a gastroscopy sometimes. So to avoid gastroscopy, so always put in Ryle's tube. And not only put in Ryle's tube, you see to that it's actually drained. You have to always compress the stomach. Now when you put it a varus needle or any surgery for that matter, head low kodamma, head low kodo. No head lows. Okay? It has to be always in supine. Only once you enter inside, you see everything, and only then the head low comes into picture. If not, your line of access goes wrong, you may actually do a aortic compression also. That's what, whether it's palmas or subcostal, you have to be very careful. Okay? This is very important again. Now again, you can see here, in a lady with less BMI, let me be very, very good. Less BMI, you could at 45 degrees. Because at 90 degrees, you may see the aorta also or the retroperitoneal pain. So actually go on 45 degrees. But in a lady with an increased BMI, I think it's obese. Sorry, I'm not supposed to use the obese. You always go perpendicular to the abdomen. Okay? Now, primary closed entry is what we normally follow other than the others. So why an intraumbilical entry is because you have a fixed peritoneum, it's a thin one, least vascular and cosmetic. But please understand this very simple physics. The moment you go through the umbilicus and when you put in a port, the distance between the vessel and this is only about 0.6 centimeters. Okay? But when you inflate it up to a millimeter of 20 millimeters, you get about 5.6 centimeters, which means you're getting an extra 5 centimeters, which could actually be a safety margin for you. Okay? Hence, it's always better to go with a high flow first with the varus. You extend it because this 5.6 centimeters really will help you out later on. Okay? But of course, what excess? 5 liter oxygen, 5 liter carbon dioxide ಜಾಸ್ತಿ ಆಗುತ್ತೆ ಅಷ್ಟೇ. So for this 5 liters, let's not be stingy, not a problem at all. Okay? High pressure entry, as I said, is always. But more important is your secondary ports. When you put your secondary ports, always put under vision. Unlike what many of us sitting over here would think that, putting the primary port is more dangerous. No, putting the left lower port is more dangerous because you have a high chance of damaging the sigmoid and the external leg vessels. So do not think that the primary port is, it's the secondary port which always matter. Again, in the court of law, you may be pardoned for putting a primary port somewhere wrong, but the secondary port you cannot put because it's done under vision. So the court of law, you will be very, very rigid about that. Okay. Now in these cases, scarred abdomen, any of the alternate sides of, you can go to the Bahamas point, you can go to Jane points. I personally am a big fan of the supraumbilical incision. All my life I've put supraumbilical, come what may. Okay. But in the supraumbilical also I've done a colonoscopy twice in my life. So you have to be very careful about all those things. Okay. But again, sometimes it's called as BB. What is B and B? Not your BV, B and B. Bhagwan Barose sometimes. Okay. So take home message again, all this things. Now with the vessel injury, coming down directly to that. Very important, how common is vascular injuries? It's quite rare, but when you have it, you will never forget it in life. Okay. That's what problem you have with this. Which injuries can I injure? Which vessels can I injure? Well, you can practically injure any of the vessels in the abdomen. So to be very careful and try to avoid this. Now there's a very, very common thing. Mary, you'll also get it in YouTube. It's also my own personal photo also. This is how you can put, very nicely, inferior epigastric artery. So what we are taught here is always do a trans-illumination, right? It will not help you. Please understand, a trans-illumination will not help you to get a deeper epigastric. For a superficial one, you may be able to see, but in a lady with an increased BMI, you will not be able to see anything. It is just for our own manki tasali that we see all those things. So all those things don't help at all. Okay. Now for this, the best thing is either you can use a suture material or you can coagulate. I personally would really like to coagulate because that can give you a very nice sleep in the night. Okay. And more importantly, simple thing, mochi. All the ladies, not the brand mochi, the one in front of the bus stand, one who will put that mochi and create. So that mochi. Similar one over here, that's what normally do. Now this is a video for positive time, I will just go it across. Now this is a very nice, when you feel that you know many things in life and when you feel that you have conquered many things, this is what life will teach you, So this is what happens, very nicely done, very nice, very nice. Okay. Dr. Rashmi is very happy with the harmonic being used. Okay. You don't want to use. Shearer also, fine. Neevella shearer andre naam en madadu. Bengaluru avalla shearer andrange. So now, yeah, done. Good, nice try. So now what we do is, again you can see here. Now here, what is going to happen now for positive time, again, I don't want Nagesha to throw me out. You can see this. Again, your ligature is being used over here. Now what is important is the angle in which you put, and more importantly, now prematurely if you actually would like to take it out, it's a sticky one. Please see this. Kachak. Okay. So basically what you should do is always clean your instrument. Come back to the basics. I keep saying this. Learn your basics properly than studying all advanced things. If you know your basic anatomy, you know your basics, you're right. Clean the instrument. Do not remove the instrument till it's well coiled. The machine, these are all new gen machines, that will give you a backup. Keek, there is a sound. The moment you hear such a sound, then only you withdraw. And we're not in a hurry. We're not here to show that, in surgery, time doesn't matter. It's your patience, and at the end of the day, the patient that matters, as madam said previously. Bladder injury is very, very good. You must be bored of hearing this. Bladder is a very forgiving organ, and bladder belongs to the fat belongs to the bladder. Yes, I do agree. Dr. Puntamekar would have told in the morning. I'm a student. So all these things are good, but please understand it's very, very becoming common. Previous LSCS, previous adhesions due to endometriosis, trocar injury while full bladder. I even had the misfortune of doing a cystoscopy once because I believe my sister, and she said yes, I've drained it. No, especially if you're doing under spinal. Then that's for another day. Spinal laparoscopy under spinal. You give a lot of preload. Many places, that's a full bladder, you can do cystoscopy also. So always go back to the basics, what the teachers have called, empty the bladder before you start the surgery. Okay. Now do you find out? You can find a lot of presence of fluid, urine in the field. You can see the presence of gas. When you open up the bladder, all the CO2 will go into the urosoc bag, and you can see the urosoc, and of course rent. Now again, there's a very nice case, You can see me, I'm a very great surgeon, I'm a very nice surgeon, you can see how well I'm operating. Okay. But as our teachers have taught us, surgery is always basically a combination of traction and counter traction, right? You can see me how much of my left, and there's not much. So that's why you can see this, very leisurely, very nicely, very well, very nice cut that I've given on the bladder. Okay. Now it's not a mistake to fall down, but it's a mistake when you refuse to get up, right? No, look at me. I've realized. So I'm just seeing what is there inside. Now you see suddenly my left hand, you see. Now see the uterus. See this on the right side. You can see over here. A good traction on the posterior side. Uterus is well big bit. See the left hand, automatically the energy comes in the left hand. And this is what should have been done. Again, going back to the basics, traction and counter traction. ನಾವೆಲ್ಲ ದೊಡ್ಡ ದೊಡ್ಡ ಸರ್ಜರಿಗಳು ಅದೆಲ್ಲ ನಮಗೆ ಬೇಡ ಅನ್ಕೋಬೇಡಿ. This is what happens. Okay, so this is what you normally do. You can see the nice champagne effect and go ahead and do this. Okay, now again similar to this, it's very important to understand and recognize an injury than saying that no, it was mistake. If you miss it, then you have a mishap. But if you recognize on table, we are saved. You can put a methylene blue, you can put a flat cystoscopy, anything is fine. But again, management. For a smaller one, you can use your Vicryl, interpret sutures, single layer, that's good enough. If not, the newer barb also you can use 3-0 barb. I've actually used in a patient just a couple of weeks back. That's okay, not an issue. But if you have a larger one, you actually use suture it out in 2 layers and you interpose it. Okay, this is something which is good. Now again over here you can see what happens now. This is a difficult case. This is a very difficult case. This is a case of sacrocolpopexy. Of course, you have to dissect the bladder. That's what I'm doing now. In spite of my best efforts, you can see a good plane has been coming up. Okay, and suddenly I see somewhere over here, again. Okay, can see this? Very nice. So now you suture it off with your Vicryl. I'm not saying here, I'm not here to show that I'm a bad surgeon. I'm here to say what mistakes you should not do. Okay, so you can suture it across in 2 layers, single layer, figure of 8, anything is fine. But more importantly, it's a closure. It's not a watertight closure. Okay, we're not here to strangulate or kill somebody. We are here to just bring them approximated. Okay, when the PGs they do cesarean section, don't do that. We are here to strangulate the tissue because that's where it is the most and other things can increase in life. Do a check cystoscopy at the end of the day, fine, good enough. Prevention of bladder injury, you anticipate difficulty. You dissect following the principle, fat belongs to blood. Sharp dissection when you're not sure about it. Less energy source near the bladder. And of course, lateral dissection. Okay. Risk factors for ureteric, a lot of things. Just for the sake of recognition, I will just go across to this. Durga sir, fantastic conference, sir. Now, management, of course, in a urology one, you can always, you always call the urologist for help. Now, cold damage, if it's a very not with energy, you just cut it across. You can put a stent, wait. Many a times, even if the fistula also, the stent would actually, it's a smaller one. But it's an electrosurgical one, there is no excuse. You have to do a corrective surgery because that tissue is necrosed, it will not heal. Okay, but preoperative stenting is a big thing. We all talk a lot about preoperative stenting, but believe me, you don't have to, you have no reason to believe me after seeing so many complications. But of course, preoperative stenting is something which I'm not for. I really do not believe in preoperative stenting. Now, this is a habit which most of us have now. Once we do the surgery, we do a cystoscopy, we see everything is all right. We see the jet of urine coming out. Wow, superb, everything is all right. This is a false notion. This will not rule out any electrosurgical injury. This will only tell you whether you have transected the ureter completely. Even it's a partial transection, you will still have this thing. So do not go by this. Of course, go for my friend. If you can do a good tubal cannulation like Dr. Rashmi Patil and team would do, okay, I'm taking your name because of myomectomy. I'll come down to you sometime later. Okay, you can put in a stent and we do it across. Yeah, Nagesh sir is a good person, very nice hysteroscopic surgeon. Sir, you also do tubal cannulation. If you can do a tubal cannulation, this also will work out. So that's enough, right? That's good enough. Before they throw me out, I'll just finish off. So I said, will stenting help? No, it doesn't help you out much. I was very sure it will come. The bell will come now. That's why. Okay. Now, in big specimens in MIs, you can do a vaginal morcellation. You can do a caldoplasty. Through the POD, or of course, power morcellation. I am not here to tell you about power morcellations and leiomyosarcoma. No, I'm not interested in that. I'm only interested in tell you that, please understand there could be a spread of undetected sarcomas in very few cases. And I would just like you to see this video here. Okay. Nice video, nice fibroid, nice myoma, very nice, super. Again, time illa dik bega hogta idini. Okay, now I cut it across. Now please see this video, a lot of fluid is coming up. What is more important is, can you see the planes? The planes are very well maintained. Okay, the planes are very well maintained. It is actually very nice. Okay, I'm getting it, you can see this. What are we taught? We are always taught that in malignancy, the planes are not maintained, right? The planes are not very well maintained. You can see over here the planes are very well maintained, but again, unfortunately, this was the case of uterine sarcoma. So basically, do not be under the illusion that once you see this. Again, go back to your basics. Clinical history of rapid growth, and secondly, changes on MRI, which would mean that a lot of vascularity is there, and thirdly, LDH2, then LDH1. LDH1, LDH2, I'm not sure if it's available in Bangalore also. You have to send it to Bombay. It takes about 4,000 rupees. It takes about 1 week to 10 days time. Okay, so do understand this. Again, morcellation, something which you all love. Nange baratte nime again baralla. But again, I keep saying this: when you do a morcellation, always keep this under your vision. I always say, when I teach my fellows, I said, whatever you operate in laparoscopy, it has to be in the center of the screen. Okay, it cannot be on the sides. Always see. Open surgery, your vision, you see everything. Whereas here, you're dependent on somebody else. So now you see how arrogantly somebody X, Y or Z is doing this modulation, Again, unnecessary. So suddenly I see here, what has happened is you have gone and caught all the appendix apoplectic. You can see here and it's bleeding. If it were to be a lateral sacral vessel, I would have been doomed. But luckily it is just an appendix apoplectic, so it's okay. So always see, go back to the basics. What is it? See and do, not D and C. Okay, that is why. Okay, so always yes. Give me. ಇವತ್ತು ಬೆಳಗ್ಗೆ 3 ಗಂಟೆಗೆ ಬಂದಿದ್ದೇವಪ್ಪ ಒಂದೆರಡು ನಿಮಿಷ ಆಯ್ತಾ. So we had a flight, we had to wait in the airport for 4 hours. The flight got delayed. So now again, leiomyosarcoma and wind back macerations again over here. Now, GI injury, just 2 more minutes please. I have told a significant proportion is always unrecognized, and that is why it's important to recognize it on table. Because unlike bladder, bowel injuries are very, very, you have to have a good bowel preparation, good high index of suspicion, identify the injury during surgery, easier said than done. Okay. Now, intraoperative dissection, always do these things. Okay. Now, lastly, you can see over here. Okay. This is where you have actually injured. When you use a harmonic, when you use a bipolar and a sealer together and you stamp on the wrong foot pedal, see this? This is iatrogenic. Chicken tandoori tara madbitvi. You can see this. Now, this is what the problem again. I am telling you, this is simple things. Footsteps. See, I am not here to teach you all big things. I will teach big things for the endoscopic coverage. Here, we are here for the basics. Okay. And that's why please be very careful. And if we switch it off, I will just pause it, I will just go off. When you do not close the port properly, you can see over here, you can have a subacute intestinal obstruction secondary to the lodging of this on the port side hernia. Always close your ports well. I am showing this so that I can scare you, so that you can do it better, not to stop doing this. Okay. Now again, this is a good thing, that always check your bowel. Accidents, it's what you learn after you know everything that counts. So learn from your mistakes and do not say that. Small intestine, better prognosis, early detection. Large intestine, bad prognosis, colostomy may be required. Good experience requires, good judgment requires experience, and experience comes from bad judgment. Okay? Take home message. Dwarkanath sir is very, very happy. Take home message. Surgery only if it's indicated. Proper training in MIs is very, very important. Knowledge of anatomy and equipment is very important. Teamwork is also equally important. There is no one-man show in endoscopy. It's always a team effort. Everybody matters. And explain all possible complaints. Nanagashte barodu nimigenu baralla. Never say bere yarugu baralla. No. You always, when you point a finger at somebody, 3 fingers are pointing at it. So be very careful about it. This is how we always expect an ideal surgery to be. Hello, Nagesh sir? An ideal surgery should be like this. But reality in life is something like this, sir. This is how the real. Ella blur agirthe yenu velakagalla. So that's why. Okay. Thank you very much. Again, it's good to learn from your mistakes, but it's better to learn from other people's mistake. Okay. Right.
Thank you very much, sir. Really, Srivas sir, it is very indeed to see that even though the topic is prevention of complication, how bold you are to show really the complication and stressing on the point that basics are the most important to see that no complication or the complication at the most is definitely preventable. Thank you very much. Nice.
Subhash, you showed us two Aishwarya Rai. Both are acceptable to us.
I should have been saying that any Aishwarya is fine.
We'll take questions at the end. Now I would like to, I request Dr. Rekha Rajendra Kumar, the supposed to be judge of this, chairperson of this session. She joined us at last. Thank you so much, ma'am. Please write out her CV.
Sure, Dr. Fesi CV. Dr. Fesi, next. Yeah. Thank you.
That was a wonderful session by Subhash sir. I now invite our next speaker, that is Dr. Fesi Lewis sir. He is the professor and head of the Department of Reproductive Medicine and Surgery at Amrita Institute of Medical Sciences, Cochin, Kerala. He has held several prestigious positions, including the Foxy Vice President 21-22, ICOG Governing Council Member 21 to 26, and ICER National Executive Member 2020-25. He also serves as the Secretary of the Kerala Chapter of IAGE, Vice Chairperson of the Kerala Chapter of ICER, and is the President-elect of KFOG 2026. We welcome you, sir.
Welcome,
Good
Dr.
evening to
Fesi.
you all.
Thanks for coming all the way from Cochin.
Good evening to you all. I think it is always nice to be back to Karnataka, where I also did my postgraduate from Manipal. So, my topic today given to me is success of ART in PCOS. Okay, as you all know, the PCOS, even though population it is less than 10%, up to 30% of the infertility populations, infertility population comes on with PCOS. And coming to the PCOS with infertility management, IVF is not the last treatment, first treatment. It is the last after lifestyle manage changes, metformin and other drugs, ovulation induction, laparoscopy surgery, and lastly only the IVF comes. So the indication, I'm not going to the minute detail of indications. So if there is associated male factor, tubal factor, or unexplained after treatment, or failure to conceive with the routine treatment, then IVF is indicated. And very rarely also, sometimes very resistant PCOS who doesn't respond with the routine ovulation induction. Now there is extended letrozole and gonadotropin regime, sequential regimes are there, but still do not respond. Then nowadays there is a shift of going to, for instead of laparoscopy surgery, to go for an IVF. That is one of the indication. But actually it is both comes under the third level of according to the latest guidelines. So how can we improve the ART outcomes in PCOS? Basically the things which you have to consider is the obesity in PCOS patient, excess androgen, the higher incidence and chance of over hyperstimulation syndrome, whether excess insulin, whether it is really culprit we had to see, and excess LH is there. So in obesity, ovulation induction requires more gonadotropin for oocyte recovery, and lower rate of oocyte recovery in obese patients usually, and greater multifollicular response and higher cancellation rate in obese patients, and appears to be a factor independent of the PCOS also if there is obese. So also the obese patients has got comparatively low pregnancy and live birth. And in addition to that, you can have technical aspect of difficult accessing the ovaries, anesthesia risk, and difficulty in embryo transfer sometimes. So that are the things additional to that in PCOS patients with obesity we have to face. And coming to the LH and androgen excess, it is determinal to the egg and embryo function. And increased intraovarian androgen may induce more earlier antral follicles, so it's more AMH and refractory to FSH. FSH resistance is more common in PCOS patients. So implantation also it is found to be if there is LH androgen excess is there. So coming to the OHSS, I will come to that in the management part. So there is definitely significant risk of increase in PCOS patients, up to 10% increase, and higher responders. Definitely we have to go for cancellation most of the patients, and when there is large amount of follicles, the basic principle of OHSS, as you all know, is the VEG, vascular endothelial growth factor. That release is more, and so there is high chance of OHSS is there. And insulin may act as a gonadotropin augmenting thick and granular cell response to LH and FH in those patients. So which are these patients with PCOS who are at risk of OHSS? This high-risk patient, especially young patients with PCO, typical bulky ovary with thick stroma and more than 10 antral follicles, and aesthetic, that is thin patients. This I just put as compatible so that when we see a patient, we have to counsel accordingly. And if there is multiple follicles, especially some studies tell us as more than 35, I'll come to the ASRM criteria later, and as a typical necklace pattern. And if there is pregnancy, suppose if you transfer in those patients and the beta-HCG rises, definitely the risk is more. And especially in the luteal supplementation, if you give HCG, there is definitely high chance of OHSS. So you must be very careful in a luteal phase support with HCG in IVF patients with PCOS. And previous history of OHSS, this is important. We have to always take the previous treatment history, whether or ovulation induction or even the IVF history, whether there was history of OHSS, and especially if the E2 on the day of HCG, if more than 4,000 picogram per ml, is definitely a risk factor. So coming next factor is that implantation. There is, even though more oocyte you get, there is definitely implantation problem is there. This can be due to intraovarian and androgen excess and suboptimal oocyte development and quality is there. That endometrial also dysfunction is there. It is mainly due to the, again, androgen receptors. There are other postulates there. I'm not going to that, insulin growth factor, glycodyline alone. And all, but that all are postulated possibility where the implantation is less in PCOS patients. And the clinical pregnancy, it is controversial. whether PCOS as such is more than that in obese patient also. Obesity is also is an independent risk factor in obese PCOS. And excess ovarian reserve, we may feel that more oocytes are there, but definitely immature oocytes will be there, and more chance of low fertilization rate, even though oocyte is more. And the cleavage rate, that is the embryo division, is also less in those patients. So this lead to the net implantation failure, because we will be putting those embryos which may have low implantation rate. So it can also lead to high miscarriage rate. So pre-IVF evaluation, ovarian reserve, definitely we will come to that. And mock embryo transfer, other endometrial cavity assessment, all as usual, but not routinely indicated only in doubt. That all are routine as other patients. But basically, if doubtful patients, we have to do the pre-IVF endometrial cavity evaluation and also ovarian reserve evaluation, mock embryo transfer must, so that this improves the outcome of the IVF in the PCOS patient. So coming to the ovarian markers, as you all know, there is the hormonal hormones are FSH, inhibin, estradiol, IMH, and ultrasound, androgen follicle, and ovarian volume are there. But what in hyper-responders we have to see is that if the IMH is high or the androgen follicle is high, these are the two sensitive marker for hyper-responder. Even though there is no definite cutoff about IMH above which, okay, patient can go for hyper stimulation, but definitely if the IMH value is high, more than 5, definitely there is high chance of hyper-response and hyperstimulation can occur in those patients. So glucose intolerance is there, we have to screen, especially in obese PCOS. And whatever it is, we have to individualize the stimulation protocol, looking at the IMH, basal androgen follicle count, and the day-to-day 3 FSH level. In the PCOS patient, sometimes there will be a disparity, or FSH may be high, and the BMI. This all, according to that, we have to do the stimulation. And regarding the metformin, it is little controversial whether all PCOS patient has to be given metformin. There is no data with the myoinosol. That's why I did not put in that. So definitely metformin has found to be favoring and decreasing the hyperstimulation. This is what the recent PCOS guidelines, both in the 2018 and 2023 guidelines, tell that definitely in agonist protocol we can give metformin, and also in antagonist also it has been postulated we can give metformin, and the dose recommended is 1000 to 2500 per day in divided doses. Definitely it is found to be decreasing the chance of hyperstimulation. So risk of OHS is reduced when we give metformin. Clear-cut data is there with agonist protocol also, antagonist also it can be. So what is this agonist and antagonist protocol, which will you choose for IVF? This is a routine agonist protocol or long protocol where we start a GnRH agonist before cycle, and after the periods we will start the gonadotropins and continue the agonist. But in short protocol, instead of initial desensitization, we start agonist on the day-to-day 3, but it is not at all advised for PCOS patient. That's why I'm not going to that detail. So we can give agonist. People were giving, even we were giving agonist when we started IVF practice 20 years back. So we had to give longer period instead of the routine previous that initial phase. We give one extra dose of depot or start for 30 days before, so that the suppression effect is more and hyperstimulation is less. But now it is universally accepted for PCOS patient. We have to go antagonist protocol. Antagonist protocol means after the starting gonadotropins after 5 days, or when the follicle is 40 millimeter, we add antagonist. So it doesn't have a stimulation flare-up effect, directly suppress the receptors, and when the follicles is given, we give HCG. So why this antagonist? Because low number of follicles is there, and reduction of the incidence of severe OHSS in antagonist protocol is there right from the older studies. This is 2006 study, and definitely this is the Cochrane, old Cochrane also telling that the incidence of hyperstimulation is less. But more than that, when we have hyper response, especially in PCOS patients, or the E2 is high, instead of HCG, we can give GnRH agonist. So the HCG effect is not there. Agonist will produce the flare-up effect and the final oocyte maturation, and we get oocytes for the ICSI purpose or the IVF purpose in antagonist protocol. So starting dose of gonadotropin has to be with the age, BMI, existence of PCOS, previous history of OHSS, previous hyperresponse. So we can start with smaller dose. This is I have shown with the agonist protocol, where we wait and slowly increases dose. The chance of hyperstimulation is less. This same thing can be done with antagonist. So in antagonist we can do even mild stimulation protocol also, or the step-up protocol. Also the routine gonadotropin alone also can be done. So what is the advantage is that chance of hyperstimulation is less, but still the patients can hyperstimulate, can occur. So people have tried step-down protocol. In step-down, start a higher dose of 300, then reduce the dose. But the problem is step-down means follicles will get atresia, and suppose all the follicles can collapse and it can affect the oocyte quality. So people have tried sequential protocol. So initially step up, then step down also. But otherwise, we have to titrate according to that. I'm not going to minute details with that. So when we give the HCG for final triggering, there is no much difference when you use recombinant, that is RF-HCG or urinary. People have tried recombinant LH, but not much studies, and it's not universally accepted. So other thing people have tried is giving pre-treatment, giving OCP treatment, whether it is agonist or antagonist by OCP pre-treatment. So that it reduces the elevated LH or androgen levels, favorable for oocyte quality and implantation, pregnancy rate, and lower incidence of OHSS. So we start OCP, then withdrawal bleeding, and then start gonadotropins, and then the routine antagonist protocol. So we have to monitor with the serum estradiol and ultrasound frequently. And people have tried the same also, it's giving HCG instead of 10,000, 5,000, 3,000, there is no difference. So, but what the main difference is that I just previously told, GnRH agonist, when we use instead of HCG, it can produce the final flare-up effect. So instead of HCG, we give agonist, so it displaces the receptors and causes the flare-up effect. But the main problem is that when we give that, there is luteal phase defect. We have to freeze the oocyte or embryos and transfer in the subsequent cycle. That is the main thing. And this protocol of antagonist with the agonist trigger has been told as one of the major development in the IVF stimulation in the 2014 onwards, which was highlighted in the focus of reproduction in the essay. And afterwards, if you look, many of the European centers is routinely changing into the antagonist protocol. The incidence is increasing. And even in 2010, in the ASRM tells that antagonist protocol has to be done to prevent hyperstimulation with the agonist trigger. So that has been for some time. So what are the other advantage of antagonist protocol? Is shorter duration of treatment, less injection, less consumption of gonadotropins, no flare-up effect or cyst formation, which can produce in long protocol, no pituitary desensitization, and more physiological, less incidence of ORHSS. But only problem is that if you are using agonist trigger, we cannot transfer in that cycle. So people have changed into two-step protocol. That means you stimulate and freeze and subsequent transfer. That is segmentation of the IVF stimulation. So no OHSS is there. And better endometrium in thaw cycle, some people are telling, and less ectopic pregnancy in thaw cycle. There are some studies comparable or even clinical outcome, but there is no clear-cut data for that. That's why I put question mark for this. And to select according to ASRM, two more slides, is that AMH value. They told us if you are for antagonist protocol is 3.4 AMH, IFC more than 24. There is no consensus among that. Or if the stimulation developing more than 25 follicles, or the estradiol is more than 3,500, some people tell 4,000, or if there are oocyte retrieved is 24. So gonadotropins, people have started right from the initial gonadotropins to the long-acting gonadotropins, but there is no consensus whether HMG or recombinant FSH will be better. So some people tell recombinant FSH, OHSS will be less, but there is no data supporting to that. This is the latest guidelines of PCOS consensus tells that whether you use urinary or FSH, both it is similar rate. And the next thing people have started doing is that IVO, in vitro maturation. When the follicle is 40 millimeter, retrieve the oocyte and mature it outside and transfer it afterwards, after 2 to 3 days maturing in outside. But the problem is the clinical pregnancy rate is less, spray implantation rate is less. So people are, different studies are going on and refining the techniques which will improve the rate. What the issues they are expecting is that low fertilization, technically difficult oocyte retrieval when the follicle is small, culturing of the immature oocyte, lab facilities must be excellent, endometrium may not be developed to transfer fresh. What about the birth defects? There is no concrete data with that, and increasing miscarriage rate. That are the things which I have to overcome. So PCOS patient for IVF, we have to, obese, we have to advise weight loss. In some South Asian countries, acupuncture they are doing, but there is no other Western data with that. Or other herbing of the, we are at the end of the beginning, not at the beginning of the end. So that applies to the PCOS in the IVF field also. Thank you for patient hearing.
Thank you very much, sir. It's a nice, clear-cut, crisp presentation on ovarian stimulation in PCO, especially. So now, all over the world, we are practicing Freezall, like antagonist protocol. It's a segmentation of IVF, and we need, our aim is to have a OHSS-free clinic. So that's what. Very nice presentation. Thank you.
Okay. Thank you.
Dr. Fessy, just I use even sometimes OCP pre-treatment in PCOS patients, even in case of IUI. Before IUI, of course, for the IVF, we do the ANTAC protocol, and as you said, the triad, what we call the organist trigger and the Freezall protocol, I agree. But even in IUI cases, sometimes if I feel the follicles are not okay, like the size has not come down, or I have not had the proper cohort of the follicles, or the LH was high, but I do give them the OCP IUI, for 12 days.
IUI, the problem, I don't give OCP because the chance of success rate with one IUI cycle is limited. 15%.
Yeah, but
we'll be wasting the chance.
I start with the gonadotropin itself right from day 3 in the next cycle. I start with a good dose of HMG in those cases where I have given the pre-treatment with OCP. I'm just talking about the IUI cycles. IUI I'm more comfortable with the IVF, to be frank, for the PCOS patients compared to the IUI.
Not comfortable.
And I'm more comfortable with IVF, in especially the resistant PCOS cases, than IUI.
So I did not, I just mentioned one thing. Now with resistant PCOS, I have been last for 3 years using extended letrozole.
Yeah.
And with the gonadotropin sequential regime. And initially I was using only 2.5 for 10 days. Now with 5 mg for 10 days is still not for all patients. Those are not responding with 2.5 is getting excellent results.
Yeah, and meanwhile the endometrium also.
No.
It is for IUI cases.
Because the chance of 1 or 2 follicle development is more monofollicular. So that we cannot aim like that for IVF, even in PCOS patient.
And we get the good endometrium also when we wait. The synchrony is much better.
Definitely, even if the follicle has become 16, 17 millimeter, we give at least 1 dose of gonadotropin, so that the endometrial effect is good with that.
Yes. And
no, I give for extended letrozole 10 days. 10 days.
What's your experience with many follicles being developed with letrozole? Usual dose.
Usual dose in those patients, extended letrozole will be better. For those
smaller dose also, for a longer period.
For longer period. The advantage is because of that letrozole, when it is there, there is the short half-life, but the anti-estrogen effect is there. So only after that, usually the not many follicles will develop. But even with the extended letrozole, can get very rarely with the many follicles developing. Those we have to go for a low dose step-up protocol. We have to go.
And just for the benefit of juniors, the laparoscopic ovarian drilling in case of PCOS is out of the window. Nowadays, we don't do the laparoscopic ovarian drilling at all. So one case reduced to Dr. Malya.
No, but I don't agree to that.
It is there, but there is still a role. Yes, I don't say no, but it is. Yeah, but no, but there are also many studies which say that gonadotropin, when we give, has on-par studies which show that gonadotropin has given enough and good results.
No,
It is only for a small section of patients, the laparoscopic
patient's
ovarian
needed
drilling.
is coming down because of this extended letrozole or letrozole.
Yes, it is a very small section of patients.
With the IVF antagonist protein. Even I remember before antagonist, we have done laparoscopy, drilling or wedge resection, because whenever the patient is stimulated with the long protocol, patient is having hyperstimulation. And patient, those days vitrification was not there, so we have to freeze the slow freezing, the result of recovery is less. So I think I have done a few patients, because whenever we stimulate for IVF long protocol, patient is hyperstimulation and patient end up in complication, we have to cancel the cycle. So we had to do this and afterwards stimulate the patient.
But now, yeah, okay, fine,
okay.
yeah.
Okay.
Thank you for your valuable insight, sir. I now call upon our next speaker, Dr. Girija ma'am. Ma'am is an associate professor at the Hassan Institute of Medical Sciences. She has a special interest in urogynecology. Thank you, ma'am. Welcome, ma'am.
Good afternoon, everyone. I immensely thank for the opportunity given. Double thanks for giving me the credit of being the last speaker of Sabyasachi Hall for this conference.
I'm glad you see it as a credit.
Yes. Yeah, my topic is on shoulder dystocia, obstetrician's nightmare. So from nightmare to mastery, shoulder dystocia turns experience into wisdom. So why do we say it is a nightmare? Of course, it is an obstetric emergency. Delay in relieving the shoulder which is impacted will lead to neonatal hypoxic brain injury and even fetal death. And it, of course, when it happens, it creates a lot of panic situation among obstetricians. And at that moment, it is very difficult to recall all the manners which are mentioned in the textbook. And anxious obstetrician end up pulling on the head, leading to neurological injuries. And obstetrician has to live in that fear of litigation, leading to nightmare. So coming to the incidence of shoulder dystocia, the global incidence says it ranges between 0.15 to 1.7%, but there is varied incidences from 0.7 to up to 3% in some of the literatures. This is because there is no agreed upon diagnostic criteria on shoulder dystocia. Coming to definition of shoulder dystocia, there are various definitions. Shoulder dystocia is defined as a vaginal cephalic delivery that requires additional obstetric maneuvers to deliver the fetus after the head has delivered and gentle traction has failed. And that's another definition. And head to body delivery time exceeding more than 60 seconds, though it is less accepted definition. Can we predict the shoulder dystocia? One has to be aware of existing risk factors in laboring women and must always be alert to the possibility of shoulder dystocia. How much ever we predict, the conventional risk factors, whatever we say for prediction, it has predicted only 16% cases of shoulder dystocia. Majority of infants with birth weight more than 4.5 kgs do not develop shoulder dystocia. 48% of births complicated by shoulder dystocia occur with infants who weigh less than 4 kgs. So coming to the risk factors, we have pre-labor risk factors and during labor risk factors. So pre-labor risk factors, as we are all aware that if there is previous history of shoulder dystocia, maternal obesity where BMI is more than 30 kg per meter square, high estimated fetal weight more than 4.5 kg, maternal diabetes wherein there is 2 to 4-fold increased risk of shoulder dystocia, women who are short-statured and who have small pelvis. So during labor, those who need oxytocin for augmentation of labor, prolonged first and second stage of labor, arrest of labor, and instrumental delivery, all are the risk factors. So to predict shoulder dystocia in non-macrosomic fetuses, clinically not suspected macrosomia, in those fetuses, there is an article which says machine learning based prediction of shoulder dystocia without suspected macrosomia using fetal biometric ratios. So it is published in 2025 in the month of, I guess, July, wherein they've given that BPD to AC ratio and AC to FL ratio are used to predict shoulder dystocia in clinically not suspected macrosomic fetuses. And this is another study. Again, it shows in less than 3.5 kg weighing fetuses, the fetal biometric estimations would help in prediction of shoulder dystocia. So can we prevent? ACOG recommends elective cesarean section if estimated fetal weight is more than 4.5 kg in diabetic mothers, more than 5 kgs in non-diabetic mothers. And induction of labor at more than 39 weeks in baby weighing more than 4 kg reduces shoulder dystocia in 40% cases. And of course, tight glycemic control in GDM cases is a must. So that is the study on early induction which reduces shoulder dystocia without increasing adverse events, which was published in July 2025. According to this study, induction at around 38 to 38.4 weeks slightly reduces the incidence, about 2.3% compared to standard, that is 3.7%. But however, RCOG guideline is against induction of labor to prevent shoulder dystocia. So should we plan elective cesarean section? Yeah, it's already covered. But then doing elective cesarean section alone may not reduce the incidence of shoulder brachial plexus injuries. We are worried about brachial plexus injuries. Brachial plexus injuries can occur even without occurrence of shoulder dystocia. There are various other causes for shoulder dystocia, and it can even occur with maternal propulsive forces. And it can even occur with cesarean section. In 2 different series, the range of 4 to 12% incidence of brachial plexus injuries have been reported. So how do we recognize shoulder dystocia has happened? That is, we all are aware of this turtle sign, wherein the head, which once after delivered, the chin retracts back into the vagina. And the baby's shoulder failed to deliver despite gentle downward traction, requiring additional manures. So that is when the shoulders lock and the time stands still. It is the obstetrician's composure that delivers hope. So coming to management, we are all aware of these mnemonic helper, which is recommended by RCOG, ACOG, and FOXY. Call for help, additional help, and evaluate for episiotomy. L stands for legs, that is macrobus manure, pressure, and then enter manures, that is internal manures, and remove the posterior arm and roll over. This is the algorithm for management of shoulder dystocia, which is described. The external and internal manures, when both these manures fail, we can repeat depending on who has performed these manures, or go for more other destructive manures. Coming to macro-robots manure, here it is shown that it is the correct technique of putting the mother in extended the lower limb, which has to be hyperplexed, is that the assistant has to put pressure on the posterior aspect of the maternal thigh, and as he is pushing, he has to lean towards the mother's head, so that it helps in lifting up the maternal pelvis and increases the diameter and flattens the lumbosacral curve. That is how it acts. But then in women who are obese, It is difficult to hyperflex the limbs. Also, in failed instrumental deliveries, it is not going to work. So this is what is shown. Pelvis gets lifted up. And along, if that fails, once Macrobert's maneuver is done, gentle traction is given. If it's not that going to work, maybe simultaneously we can try that suprapubic pressure with heel of both the hands, pressing, identifying back of the fetus from downward, firm downward oblique pressure has to be given. So it works on the principle that it adducts the shoulder so that it reduces the bisacromial diameter and also simultaneously helps in pushing the fetal shoulder towards the oblique diameter. That is Rubin 1 maneuver, that is suprapubic pressure. Then once these external maneuvers fail, one can go for internal maneuvers, that is Rubin 2 maneuver and corkscrew maneuvers. They work in the same principle. In Rubin 2 maneuver, where obstetrician's hand is put on the posterior aspect of the anterior shoulder and put pressure and try to rotate the shoulder, so it helps in adduction of the shoulder. Simultaneously, along with this, the other hand is put on the anterior aspect of the posterior shoulder and helps in the rotation so that shoulder gets into the oblique diameter. So all these external suprapubic pressure where it may not work in obese mothers and internal Rubin 2 and Wood's corkscrew maneuvers can act synergistically. So again, it is the same picture which shows Wood's screw maneuver. Reverse Wood's screw is opposite of what we do in Rubin 2 and Wood's corkscrew. And what is coming up is posterior arm delivery, wherein the posterolateral aspect of the maternal pelvis, because of soft tissues which is resilient, where the obstetrician can put the hand through the posterior aspect of the maternal pelvis, so that depending on which side the fetus face is facing, obstetrician has to introduce the hand and then try to trace out the upper arm and then try to hold the forearm and bring the wrist along the across the chest. So this is the posterior arm delivery, where obstetrician is able to reach the arm, can try this posterior arm delivery. And simultaneously with the little finger, you can flex, give a pressure on the antecubital fossa so that it will help in flexing the arm. There was one critical expert review which compared both external and internal maneuvers. So this is a comparison table wherein Macrobursts along with, usually it is done along with suprapubic pressure, and rotational methods and posterior arm delivery, wherein it showed success rate of posterior arm delivery is much higher, that is about 86%. The mechanism in Macrobursts, though we use Macrobursts and suprapubic pressure quite often, the mechanism is not that clear, whereas in other two maneuvers it says that shoulder moves towards the oblique diameter, so wider pelvic dimension. As well as brachial plexus injury is more common in Macrobursts maneuver because we pull on the fetal head. And regarding the staff required, where the additional 2-3 people are required in Macrobursts maneuver, whereas in rotational and posterior arm delivery, if the obstetrician alone conducting the delivery can switch over to doing internal maneuvers. So no extra staff is required in case if there are low resource, human resource. So when all these maneuvers fail, next is switch to all fours position on each chest position. So this is what it works with the principle of reverse Macrobursts maneuver. But then this is mostly in community settings. Midwives are trained to conduct delivery with this all-force position. And in case all these maneuvers fail, there is what is called as posterior axillary traction, traction with both hands, traction with sling, and traction with even if shoulders level are more than at the level of above the sacrum, even long right angle forceps is advised to use. So last are Zevanella maneuver, where head is pushed back and cesarean section done. Abdominal rescue procedures, where hysterotomy is done to manipulate the shoulder so that baby is delivered vaginally. And destructive like cleatotomy and symphysiotomy, less often practiced. So time target is less, try to focus for less than 3 minutes head to body delivery. And complications are well known. Maternal complications are lacerations of all the surrounding structures, 3rd or 4th degree perineal tear, lateral femoral cutaneous neuropathy, postpartum hemorrhage and uterine rupture. And neonatal complications are well known with brachial plexus injury, HIE, and fracture of the clavicle and humerus. What about recurrence? 7 to 10 times more common to recur, and nature of event and steps taken to be explained, possible maternal neonatal complications to be explained. And future pregnancy, increased recurrence in next delivery, early diagnosis of macrosomia and delivery planning. Preconceptional counseling is very important for strict glycemic control in diabetic mothers. Of course, this part is very important, that is documentation. The exact time of head delivery and shoulder delivery has to be documented, and sequence of maneuvers attempted have to be written in order, and name of the personnel present at the time of delivery has to be documented. What is the UPCA score at 1 minute, 5 minutes, 10 minutes, and CTG, card gas analysis, and signature and countersign by the team head, and no fundal pressure. This is what one has to emphasize. So this is a proforma wherein all the points are mentioned. Everything, it has to be filled, and it has to be there in the labor room. This is another proforma. So medical legal cases, recognize complications, not a negligence. Documentation is the strongest defense. Informed consent obligation, fundal pressure and unskilled traction are indefensible. Compensation of up to 5 to 30 lakhs have been awarded for brachial plexus injury. So proper documentation and team drill are very, very important to reduce the legal exposure. So of course training, yes.
Thank you,
Done,
ma'am.
ma'am, done. Thank you.
Thank you, ma'am. Every 2 years, we are getting a new maneuver for shoulder dystocia. Now we have got shoe-horn technique for shoulder dystocia. That is, shoe-horn is nothing but men used to slip the legs into the shoes. So that is a method, newer maneuver for shoulder dystocia. Thank you, ma'am. As we are running short of time, I request all the delegates to move to